हम लाइव कर रहे हैं। राहुल डिस्प्ले कर सकते हैं सीवी को, प्रोग्राम वाला।
Sir, is it visible?
हाँ, फुल स्क्रीन करो।
Hello.
Excuse me, Vasu,
Yes,
can you send me
it is
the
seen.
whole program? Can you send me the whole
भेज रहा हूँ मैडम,
program?
भेज रहा हूँ।
Hello. I think so. My video is not working. Dr. Trivedi.
Welcome, Prakash. Good morning.
Hi, Rishikesh. How are you?
But you are audible, Dr. Prakash.
મિસ્ટર ઇન્ડિયા થઈ ગયો છું, દેખાતો નથી ને?
મિસ્ટર ઇન્ડિયા થઈને બી કાફી છો બધી જગ્યાએ.
કાઝીભાઈ કેમ છો?
હેપી ગુરુ પૂર્ણિમા ગુરુજી.
You can take it ahead, ma'am.
Yeah, thank you.
Yes.
Thank you very much.
Vasu, please start.
So, very good morning, all the respected faculty and all the dignitary and delegates who have joined for this today's wonderful program on Fertility 360 Research to Practice. And before starting the program, we would like to extend our Guru Purnima wishes to all the learned faculty who have joined us and to share their immense expertise and knowledge with the delegates in today's program. To take that today's proceedings ahead, we would request Dolly Mehra ma'am to take the things ahead.
Thank you, Vasu. Good morning, dignitaries and delegates. Happy Guru Purnima. Sabhi Guru Jano ko mera sadar naman. We have so much to learn in Foxy from all the members of Foxy. There are so many things we can learn from each other. So before starting our program, let's pray to Lord Ganesha with folded hands to have an auspicious beginning of this very great web conference. Vasu.
Yes, ma'am. Give me a second. I'm sharing my screen.
मैं करूं?
ऊपर मेरे को उसका तार दो ना उधर से अटैच करके।
इसका था
वो लैपटॉप का उसके बैक में के उसमें ही है।
I request everybody to please mute.
अर्चना को बोली हूँ।
Dr. Shishma, please mute yourself.
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
Okay, so to start with, I welcome everybody for this 4th web conference. This is called as Mytri web conference. And we've done 3 in the past, very successful web conferences. The first was on master techniques and tricks in operative OBGY. The second one was high-risk pregnancy summit best practices. And the third one was seeing the unseen advances in OBGY and sonography. And now, welcome to this Fertility 360 Research and Practices. There have been many, these web conferences have been very successful for almost 3,000 to 4,000 delegates, joining in with these web conferences. And we have covered almost all the topics of OBGY in these conferences. The organizing chairperson, Dr. MC Patel sir, has been the main pivotal role behind these web conferences. And he also has the credit of conducting mammoth task of Happy Learning series, which has completed almost 300 sessions, and it has covered almost all the Foxy societies throughout the country. MC sir has been a great clinician, a diligent academician, and expert medico-legal person. He has been helping Foxy members all throughout the country. He has helped almost 300 Foxy members in cases of medico-legal crisis. He has helped so many Foxy societies for making their preamble and the constitution of the various societies. And sir has been helping each and every member of the Foxy. He's just a phone call away whenever there is any medico-legal crisis or any clinical crisis. Sir is just a phone call away, even during the night times. So I also appreciate the fact that sir has been a great social worker also. He has been spending almost a month every year in the northeastern states of our country, where normally people cannot reach, and he has helped so many underprivileged people over there. He has helped to conduct so many health camps over there, school health camps over there, and various public awareness programs have been conducted by sir. So sir has been a great visionary, and I welcome MC sir. And then I would welcome today's guest of honors. Welcome, sir. Welcome for your welcome address, sir.
Yes.
MC sir.
Thank you, Dolly, for the kind words. It gives me immense pleasure to welcome you all on this very interesting WebCon. And just mentioned by Dr. Dolly, we completed 3 WebCon with very huge success. And this is our 4th, and it is exclusively on infertility. And we know, as far as ART treatment part is concerned, it has grown very rapidly in India. And as far as a number of centers and cycles are concerned, highest growth in ART center and number of ART cycle performed every year, India is leading. And it has become global fertility industry and reproductive medical tourism becoming a very significant activity as far as this ART practice is concerned. But in spite of all this, there was no standardization of procedure, no standard reporting, etc. It was inadequate. And so now we know ART Act has already come, and then after our responsibility has increased manifold, because as far as ART Act is concerned, we have to strictly follow provisions of ART Act during our practice in infertility area. And as far as our infertility practice part is concerned, we are also observing that fertility index is decreased, and many times what happens, due to some reason, there is late marriage. Even after marriage, they plan pregnancy very late. And in this situation, almost 30, 35 years of age is already reached. And then they plan for baby, and many times they could be troublesome for them. And they have to rush to our obstetrician friend, ART specialist friend for assisting for pregnancy, etc. So we have selected topic exclusively on infertility for today's WebCon, and we have invited master faculty which are master in their own field. So welcoming you all, I welcome Dr. Rishikesh Pai. He has kindly consented to be chief guest to bless the webinar, WebCon. Rishikesh is good friend of mine, good friend of all of our Foxyan friends. Apart from immediate past president Foxy, he has never identified himself as a past president or at that time president of Foxy. He always used to say, I am a good friend of all of you. And he's a very simple person. welcome Rishikesh and thank you for sparing time to bless
Thank
us
you.
for this webinar. I also welcome Dr. Prakash Triveji, one old good old friends. He is also always with me in any of my academic activity, and he is also phone call away for me for any of my academic activity or any other assistant. And he has also kindly consented to be guest of honor to bless the webinar. And inviting all the delegates, all the convener, coordinators, faculty, moderator, panelists, and all the delegates who have joined this webinar. Thank you very much. Over to you, Dolly and Sita.
So now I welcome our today guest of honor, Dr. Rishikesh Pai. I would say an ever smiling Foxy president and our Bollywood Foxy hero. So can I have CV of Rishikesh, sir? Can I have, yeah, Vasu, please. So, sir has been past president of Foxy. He's also the regional trustee of Asia Oceanic International Federation of OBGY FIGO. Sir has been the professor and head of the reproductive medicine DY Patil University, medical director Bloom IVF Center. He has been the associate secretary of South Asian Federation of OBGYN and CEPHOG. He is the country lead of FIGO Gates Leadership Development Initiative, steering committee member, Innovation Equity Forum National Youth of Health USA and Gates Foundation 2023, chief administrator, Foxy Manyata Initiative 2017 till date. He has been the group and society liaison FIGO Women's Cancer Committee 2021-2023. He has been the steering committee member of WHO PPH Group 2023, organizing secretary Best Ishre ISAR IFS India 2024, scientific chair of 67th AICOG January 2025 Mumbai Annual Conference of Foxy. And he has also been the founder chair, Indian Special Interest Group, American Society of Reproductive Medicine, past director of corporate affairs, external affairs, and assistant treasurer, International Federation of Fertility Societies for total 9 years, past secretary general and senior vice president, deputy general, treasurer, chairman of Foxy for total 10 years, past president of IVF Societies of India, SR, and past president Endoscopy Society of India, IAG. He has received many awards to his credit. He has also received honorary FICOG, fellowship of RCOG UK. He has delivered over 800 lectures, 40 plus orations, has contributed to many books and various clinical practice guidelines, and he has been editor of 18 books and author of 42 national and international publications. Welcome, sir, with folded hands. Can I have your blessings, please?
Thank you very much. I would like to first of all thank Dr. MC Patel and Dr. Alpesh Gandhi. They have been my great friend for many years, and they are very big stature people for inviting me for this program. Dr. MC has been the past vice president of the federation, and as you rightly said, he had a lot of social work has done, and I wish him the best. And I would like to also recognize Dr. Alpesh Gandhi, who is the scientific chair of this conference, and he has had a lot of Alpesh has done a lot of fantastic things during his presidency. Especially it was during the COVID time, and he was the first president to really innovate and created a lot of impact in our federation and our organization as well. Also, I would like to recognize Dr. Prakash Trivedi, is our past president and a giant in the field of endoscopy, and my very good friend and colleague, and has been the president of the Endoscopic Association of India as well as the IVF Society of India. And so he's also done a lot of impact. And I would also like to recognize Dr. Tank, who is our president. He's a very dynamic president, and he's taken us to the next level. This year, Dr. Tank has done a fantastic work in the field and also got one of the biggest grants which in the history of medical organizations in India, for nearly a 3 million plus grant. And there's a lot of exciting new projects from Gates Foundation. He has got a lot of projects coming from USAID. And so we are going to see a different, paradigm shift in our Foxy operations in the future. So he's a great friend of mine, and I also look up to him. He's got a lot of new ideas, new thought. He's from the new generation, so things have to keep on evolving in our organization. And then we have a lot of other good people. Dolly Mehra, thank you, madam, for introducing me so well. And Dr. Sheetal Punjabi is my very good friend. I can see other people, Mehul Damani, then Bhavik, then Pratibha, and other people as well. Sushma, Monica is there. So a lot of other good people are there, and I would like to thank them for all this. Coming to the topic, of course, the topic is Mytri. This is the fourth very successful web conference which have been arranged by MC Patel and Alpesh Bhai, and also the Happy Learning series, which has come. Congratulate you that you have crossed 300 numbers in the Happy Learning series. So congratulations for that. As far as the IVF is concerned, it is my passion actually. When I came in, there were only 10 people in India who started. I was fortunate to be one of the 10 people in 1990. We started the IVF. Before that, of course, we were all looking up to the two great people, one from Calcutta, the scientists, and the other, Dr. Indira Hinduja, my teacher, and both of them did a lot of pioneering work. But 1990 was the start of the IVF industry that was there. And then ultimately, then slowly it evolved. We taught a lot of more people, and today we are 3,000 plus centers. The ART bill has just come in, and I was just the other day giving a talk on what the future of ART. And you know, when I wrote the talk, I realized that it's got a fantastic future. So it's not fair for me to tell people not to enter this field, because the future is great, and we have to look at the field, not, as Dr. MC Patel has rightly mentioned, not from the prism of India specific. We have to look at the world. Our IVF industry or whatever, we are going to capture the whole world. That is what we have to do. And no one can stop the Indians from doing it, because the Indians are very skilled at what they do. Maybe we are not that much into innovation. Now, of course, things have changed. We have also started doing research. In the olden days, it was a struggle to get the hospital going, get a loan, start a hospital. Now, our next generation has come in, and that next generation is going to do research. They are going to innovate as well. But mainly, we are very well known for replicating thing what is invented abroad. We can do it very well at a very good, successful way and in a cost-effective way. So that's what we have done in IVF. The industry is, you will be surprised that the present industry is nearly $24 billion, and the CAGR is in the region of 10 to 16%. So the growth rate is massive in the industry. And at the same time, one thing I would like to say is that we must also maintain equity. So as a doctor now, because Dr. MC Patel is very much into medico-legal, so he understands that one of the big problems that we face now.
Rishikesh, your voice is breaking. Is it my network or is it your network? Right?
Aggressive. Can you hear me, MC?
Yes, sir.
So they look at us a little negatively. So we have to, because they think that we are more money oriented. So we have to make it an effort to tell them that we are not money oriented. And the only way to do it is to serve our poor people and tell the people that we are serving them. Only serving is not enough, but to tell people that we are serving them, and that equity is very important. To take care of our poor is a very important service commitment that we all must have in our life. And in IVF also, we must see to it that in the future we have a lot of free work. So in my practice, I do a lot of subsidized work for my patients as well. And to those who can't afford it, I give them at a very low cost. And it is our commitment, it is our dharma to do that part for our patients. So I don't want to take much time. technology is important, but more than technology is the dharma, which is very important. Saving, serving our people, our poor people. They are a very important part of our existence. Without them, we are nobody. So we must always keep that in mind. So thank you, Dr. Patel and Dr. Alpesh Bhai, and all of you for inviting me here, and wish you the very best for everything and the very best for a successful webinar. Thank you.
Thank you so much, sir.
Thank you, Rishikesh, for sparing time. You are always with us in any of our academic activity, and you have expressed very good thoughts about this infertility area and overall FOXY activity. Thank you for sparing time.
Thank you so much,
Thank you,
Rishikesh,
MC
sir.
Bhai. Thank
Thank you, MC sir. And now to welcome our next guest of honor, Dr. Prakash Trivedi, sir, who we all know is a pioneer in endoscopy in our country. So can I have, So Dr. Prakash Trivedi is a gynecological endoscopist, a urogynecologist, and an ART consultant. He's director of Dr. Trivedi's Total Women's Healthcare Hospital and Akar IVF ICSI Center. He has been the Maharashtra University, recognized postdoctoral fellowship training center for minimal access surgery in gynecology. He has been pioneer of 3D laparoscopy, hysteroscopy, urogynecological surgery, and IVF ICSI in Asia. Recipient of Senior Scientist National Award for designing cost-effective urinary incontinence correction tape used since 2002.
Dr. Dolly, it's enough. Dr. Dolly, this much is enough.
Please, sir, you are a pioneer, and sir has been the past president of FOXY, IAG, and ISA. Welcome, sir.
Yeah.
I'd like to have your blessing, sir, please.
Guru Purnima is a very good day, and with extremely nice people like MC Patel, Jaideep Tak, Rishikesh Pai, Sheetal Punjabi, Kazi, Doctor, and so many others. I think so, the concept overall is a very good concept, and most of us know Dr. MC Patel for such a long time. And covering infertility 360-degree is a brilliant idea. And all are struggling for good education. And today is the best day wherein the delegates can learn, being Guru Purnima, and all the speakers and part who are very active and very knowledgeable. For some reason, my mobile sometimes make me Mr. India, sometimes make me Shah Rukh Khan. I don't know what is the problem, but I think it's a great initiative by Dr. Patel, Alpesh Gandhi, and all of you, and wish you that you have a very useful webcon. Thank you.
Thank you, Prakash Bhai, for sparing time. You are always with us. I mentioned prior also, and you have spared time for us. Thank you very much.
Pleasure.
Thank you so much, sir. Thank you, MC sir. So the best way to find yourself is to lose yourself in the service of others. This is the motto of our MC sir. And I'm really grateful to our scientific chair, Dr. Alpesh Gandhi sir, for guiding us in conducting this Mytri web conference. And to start with the academic session, now I request Dr. Sushma Verma to move forward with the first session, that is the oration. Dr. Sushma, over to you. Dr. Sushma, are you there?
Madam is available. Sushma
Dr.
ma'am, can you unmute? Sushma ma'am, can you unmute?
Please unmute yourself.
Dr. Sarfaraj Kaji and Sushma both are coordinator. So
Dr.
if
Kazi,
Sushma is
you
not
start
available,
in the
Sarfaraj
meanwhile.
Kaji can take over.
Okay, no problem. First of all, thank you very much, MC Patel sir, to to invite me.
I also unmuted me.
You can start, ma'am. No problem.
No, sir. You can start.
Okay. So first of all, thank you very much, MC Patel sir, and happy Guru Purnima to all the gurus who are sitting here, who are teaching us every time and who make us our career far better in each field, not only the infertility, but each and every field of the OBGYN. So my job is to introduce my two chairperson for the first talk. That is Dr. MC Patel sir and Dr. Narendra Malhotra sir. Dr. Malhotra sir is there?
No,
Is
he
he
has
joined,
not
sir?
joined, but we continue when he will join.
So shall I read his CV or
Oh yes, one by one.
Okay. So
Rahul,
first of
CV.
CV, please. Dr. MC Patel sir is the chairperson for the first talk. He is the presidential candidate for this year, for next year. First of all, best of luck, MC Patel sir, for your candidature.
Thank
He
you.
was the vice president in Foxy 2018. He has organized AICOG in 2017. He was the organizing secretary. He also chairing Ethics and Medico-legal Committee Foxy 2011 and 2013. Honorary secretary of the SOGOG right now, organizing chairperson of MMCon 2018. Honorary member of State Supervisory Board PNDT Committee. He is helping lots of gynecologists who are in trouble in case of medical legal issues. He was the past president of Ahmedabad Gynec Society, and he was also the national president of National Medicos Organization in 2016 and 18. He was also the president of IMA of Ahmedabad in 2007 and 2008. And the president of Lions Club Gatlodia, Ahmedabad, 1997. He is the guru for me, and I always request everyone to support his candidature for the presidency. This.
Thank you, Kaji, for kind words. You introduced Dr. Naren Malhotra also.
Okay.
If Sushma has joined?
Yes,
Sushma ma'am, you can
yes,
introduce.
then she can introduce Dr. Naren Malhotra.
Yes, yes.
Vasu, please display the CV.
Vasu, CV of Dr. Naren Malhotra.
Yes, ma'am. Yes.
Yes, it is there.
Okay. It's a proud privilege for me to introduce such a star faculty in between us for today's webinar. I would like to welcome and introduce Dr. Naren Malhotra sir. Actually, Dr. Naren Malhotra does not need any introduction, but we have a lots of achievement that
I
sir.
think there is a problem with the voice audio, ma'am.
Yes, just a minute. Dr. Ghazi, can you continue? Because there is some problem in my side.
Okay, ma'am. No problem. No problem.
Okay.
The gem of the personality, Dr. Narendra Malhotra, we can say professor, director, president in each and every field. He, I think, he's the only one who became president in each aspect of the gynecological field, like ISAR, ISPAT, IFUMB, FOXY, AOGS, ICMU. He is the director of Manyata CSE. He also has the project Positive Health Rotary District Director, International Relations Director of SAFOG, Director of Ian Donald School of USG. He was the professor of Sarajevo School of Science and Technology in Croatia. He is the founder editor of SAFOG Journal and member of FIGO Guideline Committee and chairman of Smriti NGO, which is working on the new level of the care. He has got many awards. He has written many books, and he has also published many chapters and papers, more than 500 presented papers, and over 1,000 guest lectures given in India and abroad. And he has also given 40 orations and so many awards under his name. He is the, I can say, he is the king of Foxy, according to me. Now I will hand over the stage to Dr. MC Patel sir, both our chairperson, to introduce our speaker for the first topic.
Thank you,
Vasu?
Dr. Yes. Thank you, Dr. Kaji.
Hello.
Hello.
Vasu?
Yes, sir. MC sir, you can continue, sir.
Okay.
So let us go to Oration, Prestige Oration, and it is given by Dr. Jaideep Tak, our President Foxy. So Vasu, let me have a CV of Dr. Jaideep Tak. Yes. So just I mentioned Dr. Jaideep Tak is President Foxy this year, and he has served Foxy in a different capacity from joint treasurer to treasurer, joint secretary, then secretary, and he was instrumental in drafting so many guidelines as far as Foxy's administration is concerned. Say, for example, election, just we are having online election, and he was the instrumental person, pivotal role of Dr. Jaideep. And when we preferred appeal in Honorable Supreme Court for PCPNDT, he was also very instrumental organizing all this activity. So he is chair YGAA committee AO4, project lead Foxy USAID project 2022-2024, secretary just I mentioned, awarded FRCOG honorary causa by RCOG, past president of Mumbai OBGYN Society, immediate past deputy secretary AO4, immediate past chair International Federation of Obstetric and Gynecologists, that is FIGO committee for safe abortion, past chair publication and newsletter committee AO4, past chair reproductive endocrine crinology and infertility committee AO4, and past chair MTP committee Foxy. And as far as MTP committee is concerned, he had worked a lot in this area, and still he is guiding as far as any consequences related to this area is concerned. But above all, just mentioned by Dr. Rishikesh Pai also, he was very instrumental in obtaining project lead for largest ever grant awarded to Foxy, that is $2 million US. So roughly 16.6 crore Indian rupees. And he was very instrumental for this grant. And he has designed that grant to be utilized in our different area of India, and particularly in rural India, to take utmost care of our patient as far as female health issues are concerned. So without wasting much of your time, coming to the subject is unexplained infertility. And we know, as far as infertility part is concerned, when we go with all the selection of patient and history taking and investigation, many a time we do not find anything either at male part or either at female part, and still they are facing infertility problem. And in this type of problem, when it is unexplained, how to deal with that very situation, and the best person is Dr. Jaideep Tak. I request Dr. Jaideep Tak to go with the subject. Over to you, Dr. Jaideep. Thank you.
sir.
Thank you very much.
Thank you. Thank you. I think Dr. Narendra Malhotra has joined, if I'm not mistaken. If
Jaideep?
Am I audible?
Yes, you are audible.
I think Dr. Narendra Malhotra has joined.
Yes,
Narendra,
yes,
are
Dr.
you-
Naren, welcome.
Yeah.
Your opening remarks, and then we can go to the oration by Dr. Jaideep. Naren,
Maybe he's on mute. So should I start, sir?
or we can go accordingly, Dr. Jaideep. He will conclude.
Okay, no problem. Thank you. So first of all, thank you very much, sir, for inviting me to give this important presentation. And congratulations on all the wonderful efforts that you are taking vis-a-vis the virtual learning programs. I understand that in your other series, which is the Happy Learning series, you have actually done something like 201 you were mentioning, which is quite a tremendous achievement, I must say. I used to do this series on obstetrics and gynecology with the webinars, and I can tell you that it is quite an effort to put even a couple of them together, and to do 200 of them is really a significant achievement. So congratulations for that, sir. And this is, of course, the fourth web conference of this series, and it is being heavily attended. So many congratulations to you, Dr. MC Patel, and all the very best for all the future endeavors within Foxy. I have known sir for the longest time. He is a very gentle, simple, and humble person, always very, very helpful. So thank you very much, sir, for always being there for everybody. And congratulations again on this wonderful webinar. Let me also acknowledge the scientific chairperson, Dr. Alpesh Bhai. It was a privilege actually to work with Alpesh Bhai in the times of COVID. He really turned that threat into an opportunity, took it by the scruff of its neck, and introduced so many innovations within Foxy. Always a privilege to work with him and everything. Thank you also to the conveners, Dr. Sheetal Punjabi, Dr. Rupal Shah, and the MOC for this event, Dr. Dolly Mehra. And I can see so many eminent personalities here. Thank you very much, Rishikesh, for those kind words. And of course, Dr. Prakash Trivedi. And I can see Dr. Rishma Pai, Dr. Sonia Malik, Dr. Sushma, and everyone over here. I think I see Mehul Bhai and Monica and so many others. So thank you very much again for having me here. The coordinators for the session are Dr. Kazi and Dr. Sushma Verma, and chairpersons are my very, very dear friend, Dr. Narendra Malhotra, and of course, Dr. MC Patel, sir. I must say, it is a privilege that Dr. MC Patel, sir, has chosen to chair this session in this webinar that he has organized. What I'll do with unexplained infertility, and I understand that I have around maybe 25 minutes to cover this topic, is to give you a brief overview first of unexplained infertility, point out the problems in the literature on this issue. Then we'll talk about how to arrive at the diagnosis of unexplained infertility and what are the diagnoses which are commonly missed, and then a brief outline on the treatment of unexplained infertility once we have established the diagnosis. So if you look at this graph, and this is a graph of a Medline search, sorry. This is the graph of a Medline search that has been done on unexplained infertility. And if you look at that green graph at the bottom, which is parenthesized over there, you will see the number of articles that have been published on the topic of unexplained infertility every year. Understandably, if you see a graph like this, and that graph starts tall and then it starts coming down, it means that the number of articles that have been published on the topic every year are reducing. And because they are reducing, it means that the interest in literature on that topic is also reducing, or maybe it's possible that all the issues surrounding the topic have now been resolved. But if you see a graph like this, which starts small and then keeps on increasing, it quite clearly means that there is a lot of interest in the topic. The topic is generating a large amount of literature, and therefore that topic is still relevant. If you look at within this very, very heterogeneous kind of a literature which is available on unexplained infertility, it would serve us well to actually look at the guidelines for a very comprehensive overview of unexplained infertility. And I'm very happy to share that as recently as 2023, the ESHRE has actually come out with some excellent guidelines on this topic. These guidelines are freely available on the internet. And again, this is from the same group which has recently updated the guidelines on PCOS. They're extremely comprehensive, and I would encourage you to go through them. So let us delve into the topic of unexplained infertility by first asking ourselves, why are couples sometimes infertile? And if you look at the breakup of the cause, and these figures are from the UK, they obviously will be variable depending on the region and the demography, you'll see that unexplained infertility accounts for close to 25% of all patients, which means that in 25% of all patients, you as a obstetrician, gynecologist, or infertility specialist may be unable to answer adequately when the patient asks you, doctor, why am I not conceiving? And that's why the amount or the incidence of unexplained infertility would depend on how you would make a diagnosis and what would be your threshold for diagnosis. So let's try and answer these questions. Do all patients need all investigations and that entire huge packages which are very popular nowadays? If not, then how will we decide who needs what? And in fact, if you have a patient who's coming to you from someone else, then what are the most commonly missed diagnoses? So when you want to evaluate infertility, and this is something I often tell patients, that at its very basic, what you need is a sperm, an egg, and a uterine cavity with open tubes. And that's what the evaluation should actually be looking for. You should be looking for patency, ovulation, and a semen analysis. And always, always, always remember that unexplained infertility is a dynamic diagnosis. For example, when the couple comes to you on the basis of infertility, on the basis of history, you may find that there's a certain incidence. But as you do the investigation, that incidence should ideally fall. To give you a very, very vivid kind of an example, let's take the case of azoospermia. When the patient comes to you afresh and you take the history, nothing seems amiss, and you say that, all right, this looks probably like unexplained infertility. But then you get the semen analysis done and you find that there is azoospermia or severe male factor, and then that patient moves out from the diagnosis of unexplained infertility and falls into the bracket of severe male infertility. And that's why unexplained infertility will always be a dynamic diagnosis. You may sometimes, for example, when you do a pickup, find that the oocyte quality which you obtained at the time of pickup was really, really very poor. And that could be, in a way, an explanation at that late stage for what was thought to be unexplained infertility. So what are the basic investigations? Well, there are two parts to this. One is, when do you offer it? And the second, what do you offer? So obviously, you should offer infertility evaluation after 1 year of unprotected intercourse in women who are less than 35. After 6 months of unprotected intercourse, mind you, there's a difference between investigating and treating. Once the investigations come in, you should then decide whether that patient needs a treatment or not. And of course, despite these thresholds, remember that if there is any obvious cause for infertility, offer the investigation immediately. There is no point in waiting for that 1 year or 6 months. Don't forget preconception care and bundle the investigations for preconception care, like screening for rubella immunity, G6PD, thyroid, etc., as a package when you are investigating a patient for infertility. So the basic infertility workup would consist of a ovulatory status, ovarian reserve, if it is indicated tubal patency. And I know there is debate on whether you should do a tubal patency test first or do a few cycles of oral ovulation induction. The logic really is that when you have a normal ultrasound, the large majority of patients will actually have patent tubes. So do you want to do an invasive procedure, or do you want to actually treat her initially for 3 to 4 cycles with simple treatment, assuming that the tubes are patent? The debate is not settled yet, and there are vehement proponents of each school of thought on either side. Personally, if the ultrasound is normal and there is no history of, say, for example, tuberculosis, etc., my preference is to do a few cycles, maybe 2 or 3 of oral ovulation induction first. And if that doesn't seem to work, then I go on and test the tubes. You need to, of course, do a complete fertility imaging, and a laparoscopy is indicated only and only if there is a suspicion of endometriosis or pelvic adhesions. Sometimes it's not important what you do, it's equally important what you don't do. And if you look at these guidelines, which I had referred to, the ESHRE guidelines, the recent ESHRE guidelines from last year, you will see that there are a whole lot of things which are sometimes done, which are really not recommended to be done in unexplained infertility. Now, mind you, I'm not saying that these tests should never be done. The point here is that they should not be done as a matter of routine if there is no other suspicion. So testicular imaging, anti-sperm antibodies, sperm DNA fragmentation, all the way down to microbiology testing of semen is not recommended when the semen analysis according to WHO criteria is normal. Also, in women, testing for anti-sperm antibodies, thyroid antibodies, thrombophilia testing routinely, oxidative stress in women, genetic or genomic tests, etc., is not routinely recommended. So if you're suspecting something, that's a different story. But as part of the panel of tests that you would otherwise do, don't really subject the patient to all these investigations. Also, don't subject them, for example, for the testing of androgens routinely, homocysteine level. PCR as a standalone diagnostic test for endometrial TB is really not justified to confirm the diagnosis and initiate anti-COX treatment. And of course, no need to screen routinely for APL syndrome. So again, not based on evidence, but based on the experience of doing infertility treatment for over 2.5 decades, I have put together a list of what I have found when, earlier that patient has been labeled to have unexplained infertility. And some of the things you need to look for are sexual history. It is surprising how reticent some patients are when it comes to their sexual history, and they don't really want to share the details. It does sometimes need leading questions, but I can assure you that it will be worth your while. There is, of course, sensitivity around this topic, and the questions then need to be framed in a very sensitive manner. Look at sperm morphology, particularly if it has not been done according to the strict Kruger criteria. Sperm survival tests, I'm not really sure how effective they are, but sometimes they could be the answer. Hysteroscopy, in the absence of adequate imaging or in the presence of suspicious uterine cavity findings, is something which could really be valuable. When, if at all, you're going to do a laparoscopy, don't forget to look for subtle endometriosis. A second puncture in a laparoscopy is really quite crucial to keep the bowel out of the way, lift the ovary, and make sure that there is no subtle endometriosis. And always when the scope is in, don't forget to turn the scope up and look at the subdiaphragmatic surface of the liver to look for the Fitzhugh-Curtis syndrome, which is violent string adhesions between the anterior surface of the liver and the peritoneal cavity, because that could actually indicate pelvic inflammatory disease. And when there is subtle pelvic inflammatory disease, oftentimes that's really the only thing that you will see, which will then give you a clue as to the diagnosis. Serum prolactin levels. Now, again, this has to be treated with caution. You don't want to attribute infertility to serum prolactin levels, which are borderline, like 30, 40 in a reference range where the higher limit is 25. But sometimes patients do have hyperprolactinemia causing anovulation or sometimes dysovulatory behavior, which can ultimately result in infertility. And of course, never forget to look at the changes in the status of previously conducted investigations. Sometimes it's good not to take investigations at face value. So if you put all this together and try to explain what seems to be unexplained, a lot of times you will actually find that a lot of times you will actually find that women with unexplained infertility, and this comes to light when you are doing your IVF procedure, women with unexplained infertility actually turn out to exhibit lower ovarian reserve, and within this lower ovarian reserve, it probably causes a reduced fecundity. Having said that, if you look at the literature,
Functionality of features are different. They are like a table. You see, the table is supported by four strands. If any of the strand is
Dr.
broken,
Aditi,
Ma'am, please
mute
mute
yourself.
yourself.
stable. If the stress is placed on this table,
yeah, thank you. So if you look at the lacunae in literature, one significant part of studies which look at unexplained infertility is that perhaps we don't take into account the fact that there is a significant rate of unassisted pregnancies with expectant management. It's also very variably defined. Some people sort of say that early stage endometriosis couples with mild factor infertility actually gets bunched into patients who have so-called unexplained infertility. And really, there are very limited, well-designed, adequately powered, randomized controlled trials on this issue, which take all this into consideration. Obviously, when you are faced with a patient of unexplained infertility, there are some general principles that you have to follow. But if you really ask me, the most succinct way I can put this is never forget that a lot of patients who present with so-called unexplained infertility ultimately land up conceiving on their own. And I would say this, that we need to keep the basic consideration of medicine that first do no harm when you're talking to these patients. If you are going to treat unexplained infertility, you obviously need to start with oral ovulation induction. And despite all the hype around other ovulation induction agents, I still refer to clomiphene citrate as my go-to sort of a drug for oral ovulation induction. We generally start with around 100 milligrams. We don't really think it's such a great idea to start with 25, 50, 75, and then go to 100, always from day 2 of the cycles. And because I believe that giving the HCG trigger produces what I like to call the idiopathic luteal phase defect, we give a luteal support to all the women. We never do clomiphene IUI unless there is a evident problem in depositing the sperm into the vagina, like say hypospadiasis, previous cervical surgery, or erectile dysfunction. And we generally stop at around 3 to 4 cycles of clomiphene to then move on to the next agent, which is of course letrozole. It's very, very crucial to define clomiphene resistance adequately. Clomiphene failure means she's ovulated and failed to conceive. Clomiphene resistance, on the other hand, is a very different animal. It means you've given the maximum possible dose of clomiphene for the maximum possible number of days, and then she is not conceived. It's important to make this distinction because the future approach for these patients is very different. If you look at letrozole, you know that letrozole was actually some time back not considered to be a part of our armamentarium. It is now fortunately back, but when it came back, the recommendations of the DCGI seem to be that you should use it 2.5 milligram once daily for 5 days for 3 cycles, and that's it. This is contrary to the guidelines and recommendations which are available internationally, where they say you can give it for up to 10 days with up to 7.5 milligrams. But in India, the drug controller has told us this. So this is what we must follow. If you are planning to do an IUI, then you should optimize the IUI. If you were to do this study, and I know that this is not really possible, but if you were to do this study, then you would see that for an IUI cycle, the best way to do it is a pure gonadotrophin cycle. I would regard anything other than that as a bit of a compromise, and I would not really regard that as a complete IUI cycle. We know that when you are talking about supplements, and supplements are popular for unexplained infertility, remember that the benefit of supplements, unless there is an absolute indication, is not really that great. I'm going to stick my neck out a little here and talk a little bit about endometrial thickness, which has always been regarded as something which is extremely crucial. Now, I'm not undermining the importance of the endometrium, but there is now excellent evidence to show that you should not at least cancel a cycle on the basis of just having a poor endometrium. There is good evidence to show that, and the range for what is considered to be an endometrium, which is sustainable enough for us to have a pregnancy, is now actually very, very, very broad. So let me end by talking a little bit about ART in unexplained infertility. And when it's unexplained, you obviously don't want to have a failure of fertilization. And that's why we try to do these kind of things like artificial oocyte activation. It held a lot of promise, and we did do this in a few cases, particularly in cases where there was unexplained infertility and then a failure of fertilization. Now, mind you, they're very niche area. There are very, very few cases you will see for this, but it seemed to help at that time. Do you really need to do an ICSI for everybody with unexplained infertility? The evidence may not support it. In fact, the latest guidelines say that you don't need to do it. But at our clinic, again, because patients pay out of pocket in our kind of a setup, we think it's a good idea to do ICSI for all patients with unexplained infertility and not have the problem of failed fertilization. Do you need to transfer more embryos in patients of unexplained infertility? Quite clearly, the answer is no. These patients do equally well with fewer embryos. And really, there's no specific adverse kind of an effect in patients of unexplained infertility who finally land up becoming pregnant. At the end, should patients of unexplained infertility have accelerated treatment vis-a-vis conventional treatment? The answer quite clearly is that it depends. It depends on what I like to call the fertility potential. Women with a higher age, with borderline problems of infertility, which is not severe enough to categorize them as having a problem and bunch them as unexplained, should probably have an accelerated path of treatment. And women who are otherwise quite okay can go with the conventional path. So just as a rule of thumb, a conventional pathway would be 3 cycles of oral ovulation induction at least. I normally do around 5, around 3 to 4 cycles of IUI followed by IVF. And in an accelerated pathway, you could sort of put this or reduce this. So let me end with this picture, which I'm quite fond of, and you will see why I'm fond of this picture, because it speaks to me about the problems of patients who have infertility. Now, that is a baby born after, as it is written there, 4 years, 7 attempts, 3 miscarriages, and 1,616 injections. This baby was born to a lesbian couple in the UK, and what they did after the baby was born, they wrapped the baby in a pride blanket, and what you see surrounding the baby are all those 1,616 injections in the shape of a heart. And it speaks to me, this picture, because it alludes to the struggle, the financial effort, and the emotional turmoil which our infertility patients undergo in striving to get pregnant. And it behoves us that we do the best for them. Thank you very much again, MC Patel sir, Alpesh Bhai, for asking me to give this oration. It is my pleasure and privilege, and I'm very happy to see my very, very dear friend, Dr. Narendra Malhotra, who has joined. Hi, Narendra.
Thank you, Dr. Jaydeep. As usual, excellent, with clear concept and clear carry homes. Over to you, Dr. Narendra Malhotra, for concluding remarks.
So very good morning to all of you. Apologies for joining a little bit late, but I've heard the whole lecture right from the slide number 2. See, unexplained infertility is going to be a challenge, was a challenge, is a challenge, and going to be a challenge forever. Because once the word unexplained is there, if you can't explain anything, you can't, how do you treat it? With the ART, with understanding of fertilization, with understanding of ICSIs and all, a lot of it, the unexplained has become into explained infertility. Other thing which we need to remember is the expectant treatment, who to give to. So we must keep in mind that age is very, very important. Age will predict pregnancy. Even a patient with a low ovarian reserve of a younger age group has a better chance of getting pregnant than an older age group woman with a lot of eggs. So that also has to be kept in mind when you're going to plan how to treat actively, how to treat aggressively, or whatever. So unexplained has become explained to a lot of great extent, and expectant treatment should be done only in younger patients with good AMH and good ovarian reserve. The husband and the should be thoroughly investigated. There may be or may not be a role of fertility enhancing adjuvants, which is controversial, and mild stimulation with timed intercourse would be my first line of choice. And if it doesn't conceive, then of course we add IUI. And when we add IUI, it would be adding some HMG to it or gonadotropins so that we can get better result. And of course, remember, with clomiphene, with gonadotropin, luteal phase support is there. So that concludes what Dr. Jaideep Tank has said so beautifully, so simply for all of us to understand. Thank you, Dr. Jaideep, for explaining the unexplained. And thank you, Dr. MC Patel and Alpesh, for inviting me here to chair this great oration. Thank you.
Thank you. Thank you, Naren, for sparing time for me. You are always with me in any of my academic activity. Thank you. Thank you very much.
Sir, I have a question. Can I ask the question?
No. In oration, usually we do not
Jaideep sir,
entertain
and
any question.
It's the oration. It's the oration. You ask
Madam,
question on WhatsApp.
So no,
You ask
no
afterwards.
question. You can put it on WhatsApp. We will try to solve in other. Yes. Yes, over to the coordinator.
Sir, you have to excuse me. I am at Mahabalipuram. Just have to go to Chennai and catch my flight. So I will make a move. Thank you very much, sir.
Even if
Thank you,
excuse me, I'm in another conference.
Nice talk, sir.
I'm in another conference physically in Gurgaon. So excuse me. All the best for this full day congress on infertility. Fantastic idea.
Excellent explanation on unexplained infertility by Jaideep sir.
Thank you, Dr. Karasi. Bye. Hi, Rishma. See you. Bye.
Yeah.
Ma'am, now you can invite another coordinator.
Sarfraz sir, I'm there. Thank you, Sushma ma'am and Sarfraz sir, for coordinating the event. And thank you, Jaideep sir, for accepting our invitation. I also thank Narendra Malhotra sir for being the chairperson of this session, along with MC Patel sir. We now move forward to an excellent panel discussion by none other than Dr. Rishma Pai ma'am. Can we have the CV slides, Vasu? Dr. Rishma Pai, madam, has been the former president of almost all the organizations in India, including FOXY, ISAR, IAGE, and the prestigious Mumbai OBGY Society. She also has an honorary fellowship of the FRCOG of the Royal College of Obstetricians at London. She has been awarded the FIGO Women's Award at Paris and the Lifetime Achievement Award by the Indian Society of Study of Reproduction and Fertility at Tapisar and at the ISSRF 2001. She has also won the B.N. Purandre Award, the most prestigious award from the Mumbai OBGY Society. Currently, she is the treasurer of the IFFS and a member of the Menstrual Disorders Committee, FIGO. She is a practicing consultant at Leelavati, Jaslok and Hinduja hospitals. She has been awarded by the Health Mentor Award by the Lokmat Group, the Power Women Award by the Governor of Maharashtra, and the Vidya Bhushan Award by the ICOG 21. The list award is non-ending, ma'am. We welcome you as a moderator of the panel discussion today. I would request Dr. Bhavik, are you there?
Yes, ma'am.
Yeah, can you introduce the panelists in short for us, or should I continue?
The panelists for today's panel discussions are Dr. Asha Bakshi ma'am, Dr. Rahul Tyagi, Dr. Jay Shami sir, Dr. Mehul Damani sir, Dr. Veena Panath ma'am.
Yeah. The first slide, please. Dr. Asha Bakshi madam's flight is delayed, so she will not be able to join. She will land at around 11:30, 11:40, sir. She's currently the secretary of ISAR, the member of executive committee of AICC RCOG West Zone, the founder chairperson of MPIAG and MP ISAR. She's also the member of the advisory committee of PCP NDT Indore. She has also held various academic posts of the indoor as well as Foxy. We welcome you, ma'am. Our next panelist for today, Dr. Rajul Tyagi, madam. She is the director of the ART unit and the high-risk pregnancy unit at Javitri Hospital and Test Tube Baby Center, Lucknow. She is currently the president of Association of Private Gynecologists of Lucknow, the vice president of ISPAT Managing Committee, the vice president of ISPAT UP chapter, and the past secretary of ISAR UP chapter. She also has various awards to her credit and various publications. We welcome you, ma'am.
Hi, everyone.
Our next panelist is Dr. Jayesh Amin, sir. He is the clinical director of the Nova Wings IVF Group. He is the national advisor of IFS, the past additional joint secretary of IFS, as the past convener of the Fertility Preservation Society, also the past secretary of Gujarat IFS chapter, and the HOD at Nova Wings IVF Training Academy. We welcome you, sir. Bhavi, sir, can you introduce our next three panelists, please?
The next three panelists are Dr. Mehul Damani, sir. Sir is the director of Planet Women IVF Center. Sir is ex-honorary assistant professor at VS Hospital, Ahmedabad. And since more than 25 years, sir is practicing the fertility. And Sir's center is a Foxy recognized training center for infertility. The next is Dr. Aparna Raul, ma'am. Ma'am is practicing since more than 25 years at Aurangabad. Ma'am is the secretary of the Aurangabad OBGYN Society in 2005. Ma'am was the chairperson of Free Paper in AICOG 2005 and managed 800 papers in 16 halls successfully. Young Gynecologist Awardee at 16th AOFOG Malaysia. Gold medalist in MBBS in Anatomy, Pathology and OBGY. Silver medalist in Physio and many other things. The next is Dr. Kasturi Donimath.
Yes, Donimath.
Yes, ma'am is the professor and head of the department of the OBGY at Karnataka Institute of Medical Science, Hubli. Ma'am is more than 30 years of experience and she has been the past president of the Karnataka Society. Yes, ma'am. Over to Rishma, ma'am.
Thank you.
Thank you so much. Good morning to all of you. Pleasure to be here today. Very, very well put together event. Congratulations, Dr. MC Patel. I already messaged Dr. Alpesh Gandhi and told him what a wonderful scientific program it was. So thank you for that. Of course, Rupal, Sheetal, they're all expert in putting together events such as these. And today I really have a very, very wonderful group of panelists with me, experts, I should say, and privileged to have a conversation with them really about this extremely complex subject. So just give me a minute to share my screen. All right. I think I can be seen and heard.
Yes, ma'am.
Lovely.
Yeah.
All right. So let me start by saying the challenges are what makes life interesting and overcoming them is what makes life meaningful. And I think as practicing OBGYNs, one of the great challenges that we face in our practices is treating patients with recurrent pregnancy loss. It truly is a huge, difficult disorder because it's multifactorial. There are so many etiologies possible behind it. And it's a huge psychological burden, not only for the patient, but even for the doctor. Because when the patient keeps coming back, looking for an answer, looking for an explanation, looking for a solution, we very often have nothing to offer them. And so there is, it's very, very important for us to know as much as we can on this particular subject. So the dilemma starts from the very beginning, from the definition. Like the Royal College of OBGYN says 3 or more consecutive losses before 24 weeks is recurrent miscarriage or recurrent pregnancy loss. Whereas the American Society of Reproductive Medicine and ESHRE both call a patient as having RPL after 2 pregnancy losses, consecutive or otherwise. So the dilemma starts from there. But let me start with this very, very interesting study, and that will set the tone for our conversation to follow. Very, very sort of almost an impossible study, you may want to call it. It's a 40-year-long study. They started in 1978 and they followed patients for 40 years. And this Danish study then established that pregnancy loss rate in women increases gradually with age and goes up to almost 30% in women who are 45 plus. So it's almost a 7-fold increase in older women compared to younger women. And the lifetime risk of getting pregnancy losses, 1 pregnancy loss happens in about 18% of patients, 2 pregnancy losses in almost 4% of patients, and 3 pregnancy losses in 0.8% of patients. So they concluded by this exceptional study that one of the major reasons for pregnancy losses is female age, and obviously all the associated factors which go with it. So let me now bring all our learned panelists in. What, according to you all, are the main etiologies of recurrent pregnancy loss? Anybody can take the mic because I can't see everyone very well.
So as you have already told Dr. Reshma, that it can be due to the, first of all, most important is the age of the patient and history of the previous abortion. One, depending upon the what is the her genital this uterine condition, any anatomical defect in the uterus or not, any fibroid, adenomyosis, endometriosis, septum, or any bicornate or unicornate uterus. So anatomical is the one of the very important factor. Any history of previous infections, any infection can be there. This is also can be there, or there can be the just like tuberculosis. There can be also, and the lifestyle. Lifestyle is very important. The reactive ROS stress is very important. And immunity, yes, one of the very major cause, but most burning causes nowadays is the genetic. Absolutely. Genetic is the very important cause. We have to know what is the chromosomal analysis of the parents, what is, and if the patient is having the recurrent abortions, then we should have a whole exome sequencing of the both parents. And thrombophilia and autoimmune, this Apla syndrome can be there.
Right. So thank you, Dr. Rajan. You pretty much enumerated what we have on the slide. As you can see, when you have 20 different causes being told to you, it's obvious that nobody really knows what is the reason behind this. And like you mentioned, age is one of the most important factors. Genetic causes, a lot of focus on that, and above all the other causes that you mentioned. So let me go on to the next thing, because nobody really knows the right cause. So once we don't know a cause, then what are the tests? Do we do a whole gamut of like 25 different tests? So what are the standard tests which are recommended for RPL patients today? Would anybody like to take this?
Good morning, madam.
Hi, Dr. Kasuri.
Yeah. So the routinely standard tests which we see and do are, one is to assess the endocrinological system, like thyroid, diabetes, and any uterine abnormalities. Uterine abnormality, uterine septum. Hello, I'm able to hear, madam.
Yes,
because I was in Mahabalipuram. Hello.
Absolutely, we are hearing you well.
Yeah. So anatomical, the investigations to rule out mainly the imaging and the hysteroscopy, to rule out the anatomical causes. Then endocrinological. Then we will rule out the Apla syndrome.
Yes.
Investigations to rule out the Apla syndrome. Then thrombophilias. Then inherited thrombophilias, protein C, protein S deficiency, and all those. And then where we suspecting genetic causes, then we do parental karyotyping. And if you have known the previous abortus, then if it is 2 or 3, then third one, we send that abortus also for
microarray and then genome sequencing and all, so that whether we want to know whether those mutations and all, they recur in the next pregnancy, or the parent is whether she is dominant or a recessive trait for this thing. And then antinuclear antibodies. So these are the common things which we do. But nowadays we are finding lots of immunological causes. So we do investigate for natural killer cells and other immunological CD4, CD6 count, all those for immunological causes also. Now the immunologists do recommend this.
So let me just go through with you, since you've mentioned most of the major points already, and you're stepping into a controversial zone. So we'll come to that in just 1 minute. What I would like to conclude here from what you have told us is that the recent tests which are recommended by the ESHRE guidelines, which have just come in, is that you could do a genetic analysis of the pregnancy tissue. That's important, or parental karyotype, because now patient has already had 2+ miscarriages. So this is something which we can do. They definitely recommend antiphospholipid antibody screening and beta-2-glycoprotein screening. ANA is a little less specific, but it can be done. They also, obviously, like you mentioned, ultrasound, 3D ultrasound, or maybe in some cases, further detailed study for the uterine anatomy. And most of them recommend a sonohysterography, which I feel in India hasn't become very, very popular, but it appears to be the method of choice, even above sonography and hysteroscopy for most of the world. So sonography is what they're recommended. So now my next question is really taking off from what you were venturing into, just mentioning thyroid screening and lifestyle analysis. So my next point is that patients are often subjected to many tests, like you said, because we find so many different issues going on. So are there any tests which are not recommended? And that is what I would like our next panelist to discuss. What is it that, you've seen tests, people coming with 100 reports, what do you feel or you recommend are not to be done? Would like Dr. Mehul or Dr. Jayesh or somebody like to take this up?
So I think so the protein C and protein S, the thermophilia, which are not that much of common. So we are not going to be recommended that type of protein C and protein S, which we are not recommending in a clinical practice.
Because those are very expensive tests also, yes.
We are not recommending. And something like that MHPFR mutations, that is also very not common. That is also we should not recommend it to the patients. So these are the two things which is, and then the controversy arises that whether should be actually the karyotyping. There are some RCOG guidelines which say that if PCOS shows anything, then you always go for karyotyping translocations, which was. But still, I believe that if there is a more than 3 or 4 pregnancy loss, I'm just recommending karyotyping will be the way forward to go ahead. So I think so. These are the tests should not be recommended. I think so. Torch also I'm not recommending. Absolutely. Because
I'm glad you brought that up. Yeah.
Dr. Isma, I think HLA testing routinely should not be recommended.
Yes.
And it is not mandatory for all to do torch testing, as Dr. Jayas has mentioned, because it is still so frequently we have seen in our practice that people are doing torch testing.
Yes.
So that should not be the.
We all know it doesn't cause recurrent pregnancy losses. It may cause a pregnancy loss at some point. So this is very important. And most important, the hereditary thrombophilias, we should not, because it costs more than, I think, 20,000 rupees to do that test. And it is not something which is recommended, along with, testing for LH hormone, luteal phase insufficiency, even ovarian reserve testing. These are all controversial NK cells. None of these are recommended as one of the routine tests for
uterine natural killer cells and peripheral blood natural killer cells should not recommend it.
Yeah, it's not part
of the research level at Dr. Mehul Damani says, yes, not recommended definition. We should just go and get it. What is not recommended? Not recommended means it's not routinely prescribed.
Yes, exactly.
But nothing is not going to be find out that in research ways you can investigate the patient. That is the definition of not
message. Dr. Jayas, message is that it is not for all.
Yes.
Yes.
In a particular specific situation, research-based, you can. So let's come to one of the most important causes which we think today is responsible for recurrent pregnancy losses, which are genetic problems. Because and we've already discussed this, as the age increases, and look at this, less than 25 years old, 0.13% chance of miscarriage, and 100 times more if the patient is over 40 years of age. So age is critical. So products of conception testing, I think some of it has been mentioned. Very briefly, if someone can tell me, we are not talking about first abortion, we're talking about third onwards miscarriage. So products of conception always, and which test should we do? And parental karyotype, yes or no? Dr. Anybody, Aparna wants to come in?
I think when we have a third miscarriage and onwards, we should definitely try to do if product of conception is available, and we have to go for a CGH testing.
Absolutely.
And parental karyotyping should be definitely done.
Yes.
When it is more than 3 abortion onwards.
I think so. So I don't think that's very, very controversial. And that I think will give us a lot of information. Important thing is, to the products of conception, do a CGH or a NGS. That is important, not your routine karyotyping. And this very interesting study a while ago said that if you actually analyze the products of conception, and if you go ahead and do a karyotype of the parents, over and above all the other tests you do, hysteroscopy, HSG, anti-phospholipid, everything karke, if you do this particular test extra, you will get significantly more information. And almost 90% of patients will not be unexplained, will become explained, which means genetic causes were the major reason. And only maybe 5 or 10% patients will remain unexplained. So unexplained RPL is becoming lesser and lesser with the inclusion of these tests. So these are very important and interesting studies which have come in. So that is all about the parental karyotype and, looking at the balanced, unbalanced translocations. Sorry, you wanted to say something, Dr.
Yeah, I think, Reshma, we should go for microarray test of the product of conception and DNA storage. DNA storage. So suppose if something goes, then we can go for NGS. Directly, we can go for the NGS. So microarray followed by DNA storage.
Yeah, so basically go into more depth of the analysis of the genetic material. So while we are on genetics, we all now have access to pre-implantation genetic testing. IVF is being done, embryos are biopsied. So is there a role today? So you might as well do IVF for everybody, do a genetic test and put back only euploid embryos. So if somebody wants to give the importance of pre-implantation genetic testing in RPL.
See, let me tell you something.
Yes.
PGT, if you see the ASRM guidelines, and they are saying that nowadays, because when you're dealing with the recurrent pregnancy loss, to reduce the spontaneous pregnancy loss, you can advise PGT as a part of the treatment. It's a very controversial treatment when the patient is very young. But there are different studies also there that when there is recurrent miscarriages and recurrent pregnancy loss, these are the group of the TG group of the patients. When aneuploidy embryos percentage are as compared to the normal patients are very high. So PGT will help it out to only to reduce the spontaneous pregnancy loss. That is what we can say. As you rightly said, that publications which was practically that when we are doing CGH array for product of conceptions, and it says that which is giving you really 90% informations.
Yeah.
But practically it was something different that we are having a lot of POCs and then we examine. Even we don't have a maternal contamination nowadays, we are also focusing more on maternal contaminations by keeping the maternal blood as a control.
Check with the maternal
Right.
blood. Important.
And the band, which was the newer all the technology. And I think so we are not doing the shaver technique by hysteroscopic that we can remove only the tissue and not contaminations with the endometrium and giving the base idea. This is how the technique is so important, but it is not routinely we are doing in India. So what I want to say that at the end of the day, still we are missing the bus. That yes, we are advising PGT to only to reduce the higher chance of the aneuploidy, specifically when we are treating after 3 or 4 pregnancy loss. But more of about when we do CGH array, more of about that the genetic abnormality of the embryos are still we are not getting 30% in the conditions where we feel that something else is there. and where I think so immunology science is or something we have to explore the immunology science. That is what my my understanding and my clinical experience. Somebody can enlighten. I am still doing when the advanced maternal age is there. Yes, of course. If it is associated with the advanced maternal age, yes, of course, I will do PGT. That is the message that I can
You
consider.
brought out important points, how to collect the POC, etc. Now, my what I wanted to bring to everyone's attention was that typically pre-implantation genetic testing is PGT-A for aneuploidy.
Yes,
But
A.
it is important to know that PGT structural chromosomal defect, the SR,
SR is always there.
is the important one as far as recurrent pregnancy losses is concerned. That is what will reduce the number of miscarriages on the way to having a successful live birth. And just PGT-A without known structural chromosomal abnormalities does not really help. So PGT-SR is what we are looking at. And that is what looking for PGT-M, PGT-SR. So you have to have a very advanced ART lab, which is doing these genetic studies. And otherwise, just with the plain testing of PGT-A, you may not get the benefit. All of us have already mentioned a bit about thrombophilia. So we are reinforcing. Anybody wants to offer anything new that should we be testing for thrombophilia in RPL patients? Anybody has any experience or they want to share something? The thrombophilia screening, or should we just assume? Yeah. So I think we can just go ahead and say that for
very rarely we do, madam. Actually, not routinely, we are not doing it.
Exactly.
In cases which are not, it's like even 3, 4 also not responding, again, unexplained missed abortions in the second trimester and first trimester. Very rarely, if the patient is affordable, then we carry on, especially
hereditary thrombophilia. Hereditary, we should not be testing. Factor V, prothrombin mutation, MTHFR, protein S, we should not be doing those routinely unless there's a very strong clinical history or something like that, or a known case. That's different. And when we go on to the acquired thrombophilia, we go on to the antiphospholipid syndrome. We all know the association with recurrent pregnancy loss. So my question is a very quick run through on diagnosis of antiphospholipid syndrome, and then how do we go ahead and test it?
We do lupus anticoagulant, beta-2 glycoprotein, and anti-cardiolipin antibodies usually.
Perfectly
and
fine.
usually we repeat them. And even if it comes positive, we repeat them after 12 weeks.
Perfectly fine. So within 6 weeks or 3 months, that's a recommendation for repeating all these tests. And these are the only tests which are necessary for diagnosing antiphospholipid. Another question I had is, very often we don't find anything, and we empirically treat the patient with aspirin and low molecular weight heparin. So is this something which you all do in your practice? Do you recommend it? What do you suggest?
We are putting routinely aspirin, madam, but not low molecular weight heparin. Aspirin we are giving 150.
Yeah. We are also giving aspirin only, not LMWS.
And when do you start the aspirin?
We are starting in the first trimester only. As soon as we see the fit lot, we start.
Okay. Is that not too late? Most studies recommend that if supposing aspirin has to be given, you should really start
Even preconceptually, we are giving sometimes.
Preconception.
I have something. Can I add something?
Please.
Yes, sir.
Yes. I have, because I'm working more on recurrent pregnancy loss, and I know that it's a research HLA. It is a research, but I'm just giving my research output that what's exactly going on. And I believe that 3 molecule is so important in the treating the recurrent pregnancy loss. And one of that molecule is low molecular weight heparin.
Absolutely.
And research, which my research is saying that it's a paternal allele. We are focusing on paternal allele, but 07 is there. Then the very high dose of low molecular weight heparin is required in that patient to prevent the. So I want to segregate that which group is only required low molecular weight heparin. Everybody is not required low molecular weight heparin. So now we are coming on that research that if this allele is there, then we are giving low molecular weight heparin. If this allele is not there, then we will not give anything else.
And when you say high dose of LWMH, how much is that?
Yes, I'm giving, that is paternal C07 is there, then we can give 60 milligram twice.
My God.
That 60 milligram twice, look at my experience of last 20 patients, they even not a single drop of bleeding during their pregnancy. Even if you give 40 milligram, and if it is more than 40 milligram a day, definitely there will be hemorrhagic episodes. The patient, those who are not going to sustain if it is not required in the body. 60 milligram BD is a too much high dose. So I want to say that this is my experience. I'm sharing that C07 paternal allele is going to provide the platelet aggregations in the fetus, and where the loss is because only to provide a low molecular weight heparin in the high dose. That is what we isolated the group of
Have
the
you published
patients.
this yet, or is it?
Madam, this is only 20-25 cases because it's a use. So I can go ahead and then we want to publish. You are very right. That's why this is the
I
open
feel
discussion
we
and
should
sharing.
not discuss that right now because it's a very specific area, very, very few patients, and unique, maybe a syndrome, if you will. So we need to stick to standard recommendations, which if you have an antiphospholipid syndrome, you give them low dose aspirin, 75 to 150, and you give LWMH 40 milligrams per day, typically going up to maximum 80. So I think we should stick with that as a general recommendation for everybody. And maybe in a particular unique situation, there may be, a particular medication or therapy that you might want to subject the patient to. So even the Cochrane review in 2020 has said that the combination of heparin and aspirin may increase live birth in patients with persistent, RPL, antiphospholipid syndrome, when compared to just any of the treatments. So if you have APS, you have to give both. Aspirin alone may not be beneficial. And even the ESHRE guidelines have said, and look at the specification that they have given, 3 or more pregnancy losses, we suggest aspirin and low-dose heparin. So not just randomly to anybody. We often, all of us are guilty of empirical therapy because we don't know what to do. And we give it sometime, but these are the recommendations and we have to be particular about it. And I think all of us need to counsel our patient that these are the recommendations, but if you want, we can try because we don't have anything else to offer you sometimes. So already we started with discussion about some anatomical factors, but all of you are aware that the recent guidelines, they've brought about a huge shift in the management of anatomical causes of recurrent pregnancy loss. So in our head, the moment there's a septum, remove it. The moment there's a submucous fibroid, remove it, and then there's been a big shift in guidelines. So what are your current practices looking at all the new guidelines that have come in, not only from ESHRE, but from many other international societies?
Madam, if she has a septum and if she has...
Is Dr. Aparna with us? Or no? Dr. Aparna, are you with us? I don't think so. Okay. So we will go ahead. Please go ahead, Dr. Kasturi.
Madam, if she has a septum and if the patient has repeated abortion, practically we go with resection of the septum. That is there in anatomical. About bicornate uterus or this thing or this thing, that's all controversial. But for septate, good results. I've seen practically good results.
So easy to treat also.
Yeah. So,
what about submucous myomas?
Submucous myomas only if it is distorting the cavity.
If it is distorting the cavity. Submucous will distort the cavity.
Yeah.
Only submucous. I'm not talking about type 4, type 5. I'm talking about submucous myomas. So
submucous we will do.
Submucous.
And if the septum is large enough, then we will do.
Yeah.
If it is occupying only 1/3 of the cavity, we may omit.
Right. So again, like I said, we are all in a dilemma situation, and that's why the talk is on deciphering dilemmas in RPL. Because you know that, and there are hundreds of studies, if you look into it, on how almost many people were resecting septum, submucous myoma, everybody advised go ahead and resect it. But even the Cochrane review many years ago, 2017, said that there is no evidence to support the surgical procedure of septum resection. And now you know that the latest guidelines, which most people follow, the ESHRE guidelines 2022, say that there is no benefit of hysteroscopic septum resection, metroplasty not recommended, insufficient evidence supporting hysteroscopic removal of submucous myomas or polyps in women with RPL, and intramural myomas, even which are distorting the cavity, it is not recommended to remove them. So even the last thing, which is intrauterine adhesions, they say there is insufficient evidence for benefit. So it's very, very like a big shift in the recommendations. And so, which is the reason I'm bringing this up, is many of us do many things, but our patients are very well informed. So you do need to tell them that the recommendations which have come out recently say that you may or may not remove a septum. But if we are doing this, we don't guarantee you success, but this is the thing. And you take them into confidence before doing the procedure. So, because
Dr.
tomorrow
Reshma,
when you're doing a mucus, submucous myoma resection, they will come and show you this. Why did you do it? It was not necessary. Go ahead, Dr. Mehul.
yeah, but I think all the other countries' guidelines still do not support all these things, and they continue to support the septum resection and submucous fibroid.
Septum, I disagree. Septum has been for many years. It has been reinforced that septum resection has no benefit. And let's just go back to this one. No, go back to this Cochrane review. Cochrane Can I suggest whoever speaking to mute themselves? Can you please mute? So even Cochrane review, which is summary of all the main research papers which are published, said that there is no evidence to remove septum. And this was way back in 2017. So I think that has been a big controversy. And I agree with you, it's very controversial because all of us have been doing all this.
But for all the practical purposes, if you see a big fibroid in the cavity or big septum in the cavity, and with the history of 3 abortions, you cannot leave it.
So which is why I'm saying to you that we need to take the patient into confidence and make the decision with the patient. You should not make the decision. You should tell the patient, I feel that it will help you, but some of the recommendations say don't do it. So you have to decide how you want to go about it. You understand? So that's what I'm just trying to say, because we need to now be very careful how we practice. It's not like the old days that what doctor says is God's wishes. So it's become quite different now. So another very difficult point is male factor. Does it have any role, or is it just everything is a woman's burden?
No.
So does the male factor have any role in RPL?
Yeah, it's a very important role, especially DNA fragmentation test, and especially the anatomical. The count is not very important, but the morphology is very important for the male factor. So if the morphological defect in the head, then you have to always look for the DNA fragmentation test. And if this DFI is more, then you have to give the all antioxidant and this. So stress, DNA fragmentation, and morphological. This, I think this is very important. Of course, this varicocele is not going to affect.
Right. So essentially you are
But
saying
most important is in male factor. Male factor, most important is their habits. Smoking, alcohol, those are the important things. Tobacco, that is affecting. And actually it has taken a backseat. For RPL, we go on investigating the lady, but we never ask about the husband and his lifestyle or this thing. So his habits, we have to ask. Yes. And if those are taken care of, then I think we can get good results.
I don't know how many men are going to give up smoking and alcohol to support their wives in this journey. I hope they do. But is what
madam, it makes a difference. It makes a difference, madam.
That's what the guidelines recommend, that all you do is assess the lifestyle of the husband. And they're saying DNA fragmentation, even today, is more like a research project. It's not like if a person has high DNA fragmentation, you give, it's going to cause RPL, not directly connected at all. So of course, from our side, we try to do everything we can. No harm really giving antioxidants, but they've really not been proven to be beneficial in that sense. So it really comes back to unexplained, because half the things they're saying there is no, benefit in doing this and doing that. So why then, we are eventually left with unexplained. And like I mentioned right at the beginning, once you do a detailed genetic study, most unexplained will become explained. But there'll be still a percentage, maybe 10%, which is unexplained genuinely. So what do we do in this group of unexplained patients? And this is the area where this whole controversy comes in about the close histocompatibility between the partners, causing immune response, causing an improper immune response, and the lack of antipaternal HLA, lymphocytotoxic antibodies, absence of circulating blocking factors, increase in natural killer cells. So all these unusual or different or difficult diagnoses come in the cases of unexplained infertility, unexplained RPL. So my question, should we be testing for the alloimmune causes of RPL and all the random, different, controversial treatments associated with it? What is our panel's expert opinion on this?
Let me tell you something about when we consider about the immunology science. I think so there is no point to measure the peripheral blood natural killer cell activity or that is uterine natural killer cell activity. Amount is not important. Important thing is that how they react against the stimuli is more important. So if you see something amount, I don't think so. This amount of uterine natural killer cells, specifically in uterus or peripheral blood natural killer cell, it is not giving any idea. Now the thing is that you can, for the counseling purpose, you can go ahead with the certain investigations which should involve Treg cells and TS17. That the ratio of Treg and TS17 is so important. The Treg cell is low. That means the ratio is very low. It understands that the protection inside the body is less and you need to manage the high level of the Treg cells. So I think so you should always include the Treg cells if you want to have a counseling. And the last part, I can say something that what Dr. Rishma, ma'am, I have some research which something going beyond, and that is you say something, it is not routinely. I am saying that when PGT was performed, the IVF was performed, the embryo was 3 times transferred, then all 3 times PGT embryo is recurrent pregnancy loss. And if the translocation is not there, now what to do in this type of the patient that naturally they have already have a 3 pregnancy
cases, yeah.
So these are the only group of the patients, which is very less. I don't think so. It's more than 2 to 5%. But after ART treatment and natural and everything is lost, and then I will go by the HLA testing. Why? Because it will give you the huge idea that whether the alleles are sharing, so antigen antibody reactions is really happening or not. Point number 1, that sharing of the antibody is there. So we can give them some, if the sharing of antibodies there, then we have to just go ahead with the LIT or not. That is the second thing. And the third thing, I can say something about the HLA-C receptor. So now I'm coming to the point that certain husband and wife means the couple HLA testing where C receptor combination is very lethal for pregnancy loss. And that is I'm going to publish. That is a very good thing that this combination is there. And these are the patients are 80% they are having a pregnancy loss. And here the maybe donor A, maybe a certain treatment is required for the counseling purpose. Or you may explain the patient that multiple single embryo transfer in your strategy when you are doing ART, which might help to the patient. Yes. Never transfer to embryo in ART when patient is having a recurrent pregnancy loss. This is what I'm coming to
that small group of patients where you can't find any problem, then you start doing, or you should not be doing, but many people do all these immunological tests, which are really not standardized: anti-nuclear antibody, lymphocyte cross-match, serum TNF alpha, natural killer cells in the uterine cavity, mixed lymphocyte culture, human HLA testing. So a whole lot of tests again, which runs into huge expenses for the patient. And then we have a whole spectrum of treatments which we start offering the patient, starting with a very simple progesterone to all kinds of treatments like IV immunoglobulins, intralipids, steroids, HCQ, and of course the aspirin, heparin combination with steroids. So how many of you are really using many of these therapies? And do you find them really useful?
Dr. Rishma, madam, my message is very clear that translocation is not there. 3 times single embryo with PGT tested transfer Previous natural 3 pregnancy loss followed by 3 PGT normal embryo transfers pregnancy loss are there. Then and then you can apply this HLA testings and everything. Beyond that, there is no role of HLA testing. That is what my message. And after that, if you don't find anything.
There's a very recent study from the Barisata group just come out, which said that in your 4th embryo transfer of a euploid blastocyst and in the 5th embryo transfer of a euploid blastocyst, pregnancy outcomes are similar to that of the first transfer. So which really tells you that do not give up. Go ahead and do a single 4th embryo transfer, 5th of a tested euploid blastocyst, and the results will be equally good like in your first embryo transfer. So I agree it's very hard to convince a patient that 4th embryo transfer, 5th embryo transfer, very hard. But these are scientific published lab studies. And so I agree with you to some extent, because cases where you don't have any knowledge, nothing is there, what do you do? And that is really where some of these things come into play. But I also want to underline that these are very, very rare cases. And the basic recommendations, which we are all now following because we are scientists and we have to follow scientific guidelines, that lymphocyte immunization therapy, the LIT therapy, should not be used. There is strong evidence for that, not a weak evidence, strong evidence that you should not use LIT therapy. IV immunoglobulin, and they've said this, repeated high doses of IV immunoglobulins very early in pregnancy may improve live birth in women with 4 or more unexplained RPL. So there may be some role for IVIG in very, very bad cases. Steroids are not recommended. Low-dose aspirin, heparin empirically is not recommended. Strong evidence for that. Intralipid therapy, not recommended. Strong evidence. Granulocyte colony stimulating factor, which actually is an FDA-approved product in USA for immunological problems. Strong evidence for not using this. And vaginal progesterone, the guidelines say, may improve live birth in patients with 3 or more pregnancy losses. So we have lots of recommendations.
Madam, in some cases, very bad cases, we have used HCQ, where immunological this thing. So HCQ 200 milligram twice daily, pre-conceptionally, 6 months. 6 months. So we have got good results with that. 6 months when we have used.
We have seen this has given a good result, positive, only in cases where there is some immunological problem, like arthritis or something else, myalgia, fibromyositis. So if they are there, then it is very good.
Own immunological issues like arthritis.
Then it is very good.
So those patients are
and in some cases we have used steroids, madam. I don't know, but it has helped. But actually,
that's the reason why I brought all this up, because yes, in practice, some people use. There are clinics running which are doing only lymphocyte therapy, LIT therapy. There are many clinics which are giving high doses of steroids. We all know the side effects on the mother and the baby of high dose steroids, whether it's cleft lip, palate, whether it's femur necrosis. So we all know the negative effects, but many patients are still giving it. And so all of these issues are there. I think you have to really weigh the pros and cons, look at the guidelines, and then, sort of balance out everything. So, but I want to really emphasize that none of these therapies are really proven or recommended at the present moment. What we should really do is go back to the good old tender loving care.
Yes.
Actually, now tender loving care has been defined, and I'm just saying to you that TLC is actually regular weekly medical and ultrasound examination and instructions to avoid heavy work, travel, and sexual activity. And you can see the difference. So specific advice, and there is a live birth rate of 36% in the control group, 85% in the tender loving care group. So I think that is something which we can safely advise our patients give TLC. And of course, at the end of the day, all of us get frustrated. Sometimes we recommend surrogacy, and sometimes we recommend all kinds of crazy things. But I just want to thank the panel for being so honest, from sharing their personal experiences and researches, and for telling us how frustrating this problem is, and how sometimes they reach out to empirical things to help us. So any last comments from anybody?
Madam, tender loving care really makes a difference, madam. I have seen cases and they come from so far off places just to meet us. The treatment is not much, which can be given there. But that tender loving care, that confidence, that belief, it makes a difference, madam.
It does. It does. All of us have seen that here. Great. So thank you. Thank you so much. And I hope this discussion has been useful. Thank you, Dr. MC Patel.
Thank
Thank you, Dr. Rishma Pai, madam, for moderating very interesting panel in a very interesting way. And all the big round of applause for all the panelists, making this panel very interesting and vibrant. So thank you all the panelists, and Rishma again for sparing time for me to make this webcon interesting. And
Our pleasure and privilege. Thank you, Dr. MC Patel. All the best.
Thank you, madam.
Thank you, Dr. Patel, for giving us this opportunity.
Thank you
very
Raju,
much.
madam. Yes.
Thank you, sir, for this opportunity.
Thank
and all
you.
the best,
Thank you,
sir.
Kasturi madam. Thank you.
Thank
Because all
you.
the panelists are
Thank
legend in their field, including Kasturi madam, Jayesh Amin, Rajul Tyagi, Mehul Damani, all the legends in their respective field, and they have justified my invitation to be panelist in this panel. Thank you all.
Thank you. Thank you.
Thank you so much. Thank you, madam.
Thank you, Patel sir, for allowing me to coordinate the session. Thank you, Rishma Mai. Rishma ma'am, it was a very fruitful discussion. And we've had a very good take-home messages from the panel discussion. And thank you all the panelists for joining us. I request Dr. Richa Ainani madam and Dr. Monica Gupta madam to please take over for the next session now.
Thank you so much for a wonderful panel discussion. It is very clinical and based on the clinical tips, ma'am. And thanks a lot, MC Patel sir, for giving me the opportunity for being in between such a sitting in between such stalwarts of infertility. Thank you so much, sir. Thank you so much.
Good afternoon, everyone. Now we are going to start with the third session. Thank you, Dr. Monica and Dr. Bhavik, for the conducting second session, and thank you, Webcon team, Alpesh sir, MC Patel sir, for giving us this opportunity. Our third session is on navigating legal and ethical and emotional maze. And our chairpersons are Asha Jain madam, Narendra Gujjar sir, and Dr. Archana Kumari madam. Please CV of Asha Jain madam. Asha Jain madam is a MBBS, MD, DNB, FICOG, and she is associated with so many groups. She has received Foxy Figo Cervical Cancer Elimination Initiative felicitation. Over to Dr. Richa for introduction of second.
Hello, everyone. Good morning. I'm very honored to and pleasure to welcome Dr. Narendra Gujjar sir, who is the next chairperson. He has received many prizes and awards for academic achievements. He's a practicing gynecologist at Ashirwad Hospital and Akash IVF Center since last 39 years. He has participated in many national and state conferences as speaker and with special interest in vaginal surgery and infertility. He's a professor and unit head for CPS DGO course in Navsari and has been the president and organizing chairperson for various societies. We welcome you, sir.
Our third chairperson is Archana Kumari madam. She is the East Zone Coordinator Quiz Committee, Founder Secretary of IFS Jharkhand Chapter, elected Executive Member of National ISOPAP. She was Organizing Secretary of Foxy East Zonal Conference with Yuva at Ranchi, Organizing Secretary of Mid-Term Annual Conference. She is the Organizing Secretary of 8th Annual Conference of RCOG. She has got a teaching experience of 18 years with 30 publications, 7 chapters in 5 funded research projects to her credit. Welcome you, ma'am.
Yeah, thank you. Thank you so much.
And I now request Archana madam to introduce our first speaker, none other than the organizer behind this webcon, Dr. MC Patel sir, for his first talk. Please put the CV of Dr. MC Patel sir. Archana ma'am, please introduce MC Patel, sir.
Any chairperson can take, no issue.
Yeah, can I, sir?
Yes, sir.
Oh,
Archana
yes.
ma'am, please.
Yeah, because
We are
it's an
requesting you.
honor to introduce a personality, a legendary personality like Dr. MC Patel, sir. Sir is actually I can't see his CV. It is not. I have logged in from mobile. Yeah, thank you so much for enlarging it. He's the consultant obstetrician at Hyderabad, has been the vice president of Foxy, and I know. Can you just little bit enlarge it, sir? Has been the chairperson of Ethics and Medico-legal Committee, 2011 and 13. He is the honorary secretary, State Organization of Gynecologists and Obstetrician of Gujarat. Sir is very actively involved with NMO, and we know sir is our legal expert at any moment of time. And I have heard to his presentation, he always says that you can have your card under your pillow and have a safe sleep. So sir is our safeguard for any medical legal aspect or any personal problem. He has always been a mentor and guide to every Foxian. So I welcome you, sir, for your talk.
Thank you, Arjuna, for kind word. If any chairperson has opening remark or straightway I have to go to the subject.
Narendra sir, you want to say something?
Yes, madam.
Yeah.
So to introduce Dr. MC Patel from the viewpoint of medico-legal, you can say that you are recognizing a drop in the ocean. And my best wishes are to Dr. MC Patel for the incoming election, President Foxy. I am sure that he will lead this association to the highest level. Thank you very much.
So let me allow to share my screen. Is it seen full screen?
Yes, sir.
Hello. And,
Yes, sir. Yes.
and I am audible.
Yes, sir.
So straightway to the subject. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. And before I go to the subject, it is my humble appeal. Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller society and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना. So please endorse my candidature for post of President this year. Election would be from 1st August to 10 August. Consider my seniority, sincerity, dedication, and easily availability to any Foxian friends in any medico-legal crisis. So navigating ART from legislation to clinical practice is the subject for today's discussion. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank Dr. Alpesh Gandhi in particular, I would say, because he has helped me a lot, not only for designing this webcon, but for execution of this webcon. He's always behind me, keeping me on toes, and with 3 successful webcon, surgical skill in OBGYN, high-risk pregnancy in OBGYN, and imaging science in OBGYN. This is our 4th efforts, and Dr. Alpesh Gandhi is always with me. Thank you, Alpesh Bhai, for all the help you have done. And I also thank all the faculties who have joined this webcon and all the chairpersons, coordinator, and conveners to this. And thank you to coordinators for this session also. Usually I start any of my talk with this question: is it worth discussing? If it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and we gynecologists rank first as far as medico-legal consequences are concerned. And these are the common allegations in our ART practice or in any of our practice. These are the common allegations nowadays: delayed in diagnosis, investigation or treatment, missed diagnosis, investigation or treatment, wrong diagnosis, unnecessary investigation. We know in ART practice we have to advise so many investigations, but there could be some allegation like this: it was unnecessary investigation, no proper consent. It is also one more area nowadays as far as litigation is concerned: staff not qualified, infrastructure issues, emergency services not rendered properly, communication failure, delayed in transfer. If at all for any emergency we have to transfer patient to higher center, then if at all it is a delay, then it could be one more allegation on our part. Complication in our ART practice, say for example OHSS, multiple gestational fetal reduction. There are so many areas we have to properly counsel and we have to deal with. And if at all any complications happens, then it becomes a area for litigation: possibility of infection, hemorrhage, injury to surrounding structure at the time of any procedure. If we injure any surrounding structure, this could also invite litigation. Morbidity, particularly maternal and fetal, I have mentioned after pregnancy with IVF, we have to be very careful, and in very rare situation, it ends into mortality, and it also becomes a very difficult condition to face. Overcharging is one more allegation nowadays is coming up. Tremendous expense against unexpected result. And we know, as far as our ART practice is concerned, we cannot give 100% guarantee, and naturally expense is there. So this could be one more allegation: tremendous expense against unexpected result. Ask for medical record and you have not provided. So as per guideline from Medical Council of India, we are under obligation to provide record of treatment given to the patient or any eligible person within 72 hours, and as per guideline from National Medical Commission, within 5 working days. And if we have not provided, then this could also be one more allegation at the time of facing litigation. Failure of patient to comply with scheduled follow-up. Many times we advise patient to come for follow-up or some procedure on that very particular day and time, but many times patient doesn't turn up. Of course, it becomes a contributory negligence on part of patient, but this is also one area as far as litigation part is concerned. Let us see few of the cases decided in different courts as far as ART treatments part is concerned. So when ART Act came into existence, before that, there was no act, there was no law governing ART practice. So whichever cases decided in different courts were precedent cases in succession deciding in all other cases. So in this very case, Kalyan Test Tube Baby Center versus Sandhya, it was misleading advertising in camp, no result, no money. And investigation and treatment. This patient reading that advertisement head to this hospital for ART treatment. She was investigated, she was treated, and rupees 90,000 was collected. But later in that very cycle, they told that endometrium is not good. So we postponed for embryo transfer, and they cancel embryo transfer. And patient asked for money back, but they had a argument that we have incurred some expense at the time of ovulation, induction, stimulation, etc. So they were ready to give amount after deducting the expense which incurred by hospital. But at the time of deciding this case, judgment was very clear, and court has very specifically mentioned those center must have incurred the cost in stimulation and pickup, etc. But once they had promised no result, no money, so they will have to give all the amount back, and judgment came in favor of patient. Let us see one more situation. Many a time we see this like of advertisement, money back if cycle fails. Is it ethical? As far as advertisement part is concerned, if first cycle fails, then second cycle will be free. Ethical as per NMC, or can they suspend license? So this is the very important issue and any legal issue. But it is clear in this, they have promised to give money back only or second cycle free only. So as such, legally this cannot be challenged. But if you have given guarantee for result, that I give 100% guarantee about result with my treatment, then it becomes a difficult one. And in one of the cases which happened in city of Mumbai only, one of our friend had given guarantee of result and her license from medical council was suspended for 5 years. So we can give result like this, no result, no money, fine, but we cannot give guarantee of 100% success. One more situation. Many times these are the allegation, अरे यार पैसे तो gonadotropin में ही है, and IVF consultants sell gonadotropin for a profit margin. These are common allegation nowadays. So very important part is it allowed? Can we dispense gonadotropin to our patient? Yes, it is not sale. Sale and dispense is different story. If we give injection or any other drugs from our hospital to our own patient, then it becomes dispensing and not selling. So it is allowed. But it is very clear. Doctor can legally dispense, but he cannot sell that very medicine to any other patient on prescription of other doctor. Of course, in other hospital, if at all they require, they can give medicine to other hospital also. But it is only on base of replacement. They will give it back. But they cannot sell. They can dispense for their own patient only. One more case scenario. In this case, ICSI with sperm derived from testicular biopsy for a couple with male factor. Husband had a azoospermia, and female factor, she had PCOS and multiple fibroid. So ICSI was done in this case with testicular biopsy, and 2 cycles were failed, but they were successful in 3rd cycle. Progeneva and natural progesterone prescribed for support, but in this case, pulmonary embolism happened and patient had a big problem. So case was filed, notice was served, and allegation was that we were advised complete bed rest by doctor, and that led to thromboembolic phenomena, and that led to pulmonary embolism. But it was denied by doctor. He never advised complete bed rest to that very patient. So this type of allegations are very common in our ART practice. Let us see one more situation. ART done and donor gametes used. Is it adultery? No. If consent of partners are taken, then it is not considered as a adultery. Let us see one more situation. Artificial insemination with donor without husband's consent. Can it be a ground for divorce or judicial separation? Yes, because in any donor program, whether it is AID or so, then a party involved, all the party involved should give consent. So in this situation, consent of husband is very much must. Let us see one more situation. It was case of artificial insemination with husband, and a pregnancy was there, but husband never had a intercourse willfully or because of impotency. Is it considered as a consummation of marriage? Can decree of nullity be granted in favor of wife for divorce under impotency? Yes, it is not consummated marriage because AIH was done by procedure, but it didn't prove that it was intercourse. And as far as decree of nullity is concerned, if it was proved that there was impotency and intercourse was not possible, then decree of nullity can also be passed. If we go like this, under Indian Evidence Act, child born within 280 days of dissolution of marriage, whether it is death of husband or divorce, then that child is considered as a legitimate child. But at the same time, If it is from stored sperm of husband, then this will not apply. Let us see one more situation. What happens if DNA of body doesn't match with genetic parents? It is a very common problem. Many times, if at all it is a mismatch or mix-up rather we say, then it invites litigation when commissioning couple comes to know that they are not biological father of that very child. DNA of surrogate baby doesn't match with genetic parents. In this situation, is indentured couple or commissioning couple still bound to accept baby or custody of baby? Because with a newer guideline and this ART Act and Surrogacy Act now, it is very clear as far as parenting certificate is concerned, one has to take it from affidavit from court that irrespective of quality and quantity of baby, they will take custody. But in this, it is not specified that in spite of this DNA mismatching, then also they will have to take custody. So in this situation, when DNA of surrogate baby doesn't match with genetic parents, they are free to deny custody of baby. But in this situation, when we go with contract, then we have to take one witness also. If custody is not taken by that very couple, then that guarantor will take custody of baby. And in this situation also, if guarantor is ready to give this baby for adoption to any proper person or in any organization, they take care of this type of children. So we have to deal with situation accordingly. Let us see one more situation. Death of an egg donor. This is also very rare, but if at all when it happens, it becomes very difficult to face the situation. What is the medical legal scenario in death of egg donor? What is the role of ART bank in such situation? Because ART bank is under obligation to screen egg donor and to supply egg donor to ART clinic. So main question comes, was selection of donor perfect? So as far as these certain points are concerned, in oocyte or sperm donation program, so in oocyte program, let us discuss first, any woman more than 23 years of age and less than 35 years of age can enter into this program, irrespective of her marital status and or history of pregnancy, because her motherhood should not be proved. If she is eligible by other means, then she can be entered in donor program. But she should be free from STD and genetic diseases, and she should be medically fit. Complication of procedure or anesthesia, if at all, at the time of this program, then we should be deal with accordingly. Otherwise, it may invite litigation. And all the measures taken in this situation when patient becomes serious or so, we have to prove that we took utmost care to save life of that very patient. A bank shall not supply sperm or oocyte of a single donor to more than one commissioning couple is also one provision. But an oocyte donor shall donate oocyte only once in her lifetime, not more than 7 oocytes shall be retrieved, was the original enactment. But with this amendment, now we can retrieve all the that is follicle, but we can utilize only 7 oocyte as far as embryo formation is concerned. Patient should be free from STD and genetic disease, just I mentioned. And for that, this is very compulsory under ART Act. HIV, HBsAg, HCV, VDRL, and any other investigation required, we have to investigate patient as far as donor program is concerned. So bank will screen all this and then only they will supply to the ART clinic. Is it legally correct if wife without husband's knowledge request for egg donation? No. In this situation, husband's consent is very much required. Let us see one more situation. Is it legally correct to use donor sperm with only husband's consent without wife's knowledge or vice versa? No. Again, it is very clear in any donor program, whether it is AID or any, then all the party involved should sign the document and consent should be taken from all the party. One more very interesting situation. Embryo develop, but before transfer, death of husband. Can wife use this embryo in future? So in this situation, at the time of taking consent, it should be very clearly mentioned that in event of death of husband, wife can utilize, then only she can use those embryo. Same way, if at all if death of wife, then can husband use this embryo in her friend or for second wife? But in this, it is a very funny situation. Even if consent is given by wife, in this situation, my husband can utilize this embryo. But for that, he will have to go with second marriage also. One more area, death of both before embryo transfer. If there is a death of both the partner, commissioning partner, then can father of husband claim embryo? So prior clarification at the time of consent is very much required. And can father of wife claim embryo? Same. So consent should be very clear. So at the time of taking consent in this type of program, we should be very vigilant as far as the counseling and consent is concerned. Let us see one more case. This is also a very interesting case. This couple had a 12 years of married life and they had no kid, and they came to know from advertisement that this clinic is providing treatment. They had been to this clinic. They offered them to go with surrogacy, and 15 lakhs was charge decided, which was paid by couple, but they never introduced surrogate to that very couple. And they told that surrogate will give birth baby in month of August 2020, and then baby will be handed over to them. However, in July 2020, both the doctors were arrested by Vizag City Police for a charge of trafficking children. And in this situation, both the doctors were arrested, but they got the bail. They were released on bail. And after they were out of custody, again that couple approached them to give money back, but they were not ready to give money back. And later on, ultimately that couple filed a case in Consumer Fora, and court was very clear, and court has given decision to return all the amount of 50 lakhs and compensation 1 lakhs and legal expense 10,000. So it is very clear carry home message with this type of cases. Never end up into any unethical practice as far as ART part is concerned. Let us see one more case. Girls visit ART bank with her mother to volunteer for ovum donation. This is real happen case in state of Tamil Nadu before ARTF. Age verified by Aadhaar card.
Please mute yourself.
She was screened as per provision of ART Act, and she was entered into this donor program. But after some time, police had been to the hospital that she was minor, and because minor cannot enter in a donor program, so case was filed against both the gynecologists. They were arrested, and at that time, Health Minister of Tamil Nadu order to seal all the hospital involved in this type of activity. So after this prosecution, etc., gynecologists were free from this bail, and case is still on. It is not decided still, but at the time of entering any person to any program, age verification is very much must, because minor cannot be entered into this type of program. They had produced Aadhaar card, but it was fake one. So whenever you collect any ID proof, it should be attested by a patient who have produced that certificate. Of course, as far as Aadhaar card is concerned, you can verify on date also whether it is true one or whether it is fake one. But we should be very careful.
Requesting the host to mute Dr. Archana Kumari, please. Please mute Dr. Archana Kumari, because she's in a hall and there's a lot of disturbance.
Whenever we are dealing with this vulnerable age group. If at all we have a little doubt that patient could be minor, we have not at all to entertain this type of patient entering into donor program. So In this case, it is the carry home message. Let us see one more situation. Oocyte and sperm donation part is concerned. As far as explanation is concerned, ART bank can supply donated sperm of a particular sperm donor only once to a particular ART clinic for a particular patient. But in this, it is mentioned that that very sample can be provided to that very couple and that very hospital only once. But nowhere it is mentioned in ART Act that male cannot donate more than once in his lifetime. So there is a possibility of interpretation. Say, for example, one sample of one sperm donor is supplied to bank for one couple, and for any reason that couple didn't get pregnancy, then can that donor, sperm donor, supply sample to another couple to the same hospital or another couple to another hospital? Still it is gray area, but interpretation is very clear that he cannot supply to the same hospital to the same couple more than once. So he can supply to other hospital or to other couple as far as sperm donation part is concerned. Let us see one more area. Can an egg donor bank supply egg donor to clinics located in different state? Yes, it can be allowed. Can woman unrelated to commissioning couple be a surrogate mother? Now with amendment, it can be, so it is yes. Can an unmarried woman donate eggs? Yes, she can if she is eligible by age and by screening program. Can an unmarried man donate sperm? Yes, again, if he is age wise and other criteria, if he is eligible, then he can. Can an egg donor bank be run by an educational or charitable trust? Yes, any non-medical person can also run a bank or clinic, but person working in that very bank or clinic, they should be qualified, and list of all the persons should be given to appropriate authority at the time of applying for the registration. And as far as ART bank is concerned, it is very specifically defined in the Act. Organization responsible for collection of gametes, storage of gametes, embryo, and supply of sperm, semen, oocyte donor, and surrogate mother to ART clinics and their patient. Can egg donor bank stimulate egg donor and conduct egg retrieval process? No. This is given to ART clinic only. So ART bank cannot do. Can egg donor bank advertise for recruiting egg donor? Yes, they are allowed. They can give advertisement inviting donor. Can an egg donor bank collect semen sample from level 1 and level 2 clinic? Yes, it is also allowed. They can collect sample from level 1, level 2 clinic also from any patient who are volunteered. Can egg donor bank supply stimulated donor to level 2 clinic? No. So in all this situation, which situation we saw and all the cases decided we saw, what to do and how to prevent. Naturally, center should be registered. Without registration of any center, one cannot do ART practice. No center can function without registration. And as far as foreseeability is concerned, so we have to anticipate certain complications. Say, for example, just we mentioned OHSS or so. So if we anticipate and if we are readily available to deal with the situation, we could be out of problem. But proper counseling is very much must as far as selection of patient, screening of patient, and counseling, including success rate, alternatives, and probable expense. We have to counsel patient as per standard guideline given by Supreme Court in case of Samira Kohli versus Prabha Manchanda, which was decided in 2008. And no rosy picture about result, no tall claim about result as far as our ART practice is concerned, because we cannot give any guarantee of result, because many a time we consider a result, a possibility of result like Aishwarya Rai, but it may turn like this at any time. So no rosy picture, no tall claim, because when you claim to be master, in eye of law, you are supposed to be master. So proper communication is very much must. And in this famous case of C. Jaipal Reddy versus Padmini Veluri, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign. But it is a very important document of your explanation, of your communication, of your counseling. So whatever you have counseled, whatever you have communicated to the patient, it is to be entered into consent paper, and then patient has to sign. And once patient and patient party signs the document, it becomes a documentation of your communication. So whatever you have communicated, it is documented. But records are always at your rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics. So by our record, we can prove that we have treated that very patient as per standard guideline, as per standard provisions of law, and as per standard ethics. So it should be easily acceptable in the court. And these are some different forms. I do not want to go into detail, but application for registration, that is form 1, application form registration ART bank, that is form 2, registration of certificate, and all the consent forms are given in different form, and it is available on a website also. You can download and you use in your day-to-day practice. Record for use of donor gametes, it is a very important part, and it is to be taken care by ART bank, with all the details of donor gamete should be entered into register, and then it is to be supplied to ART clinic. Same way for oocyte donor, same way oocyte and embryo record, and consent for donor of sperm, it is also in prescribed form only. Naturally, your patient should be well informed before entering into the program. So to conclude, we have to follow standard protocols, adequate supervision and monitoring during procedure and during any surgery or so, communication, counseling and proper consent, documentation and record keeping, foreseeability and anticipation, and we should be readily available to deal with the situation. Multi-speciality approach, from diagnosis with necessary investigation, qualified anesthesiologist, audit of our own case not to end up into the same problem in future. This gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many provisions in act, in law, in our favor. There are so many cases also decided in our favor. But if you do not know, then they won't be useful in our proceeding. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So to conclude, if you want to sleep like this, take tender care of your patient. Comply with the provision of ART Act when you are practicing ART, Surrogacy Act when you are practicing surrogacy, and pray your Almighty God before going to sleep, and keep my visiting card below your pillow. And if this works, it is yes, it is law of leopard behind innocent ART specialist, and see the role of medical legal counselor. So please do not hesitate to have a phone call to medical legal expert in any odd situation. So thank you very much. God bless you. Have a litigation-free medical practice. And again, it is my humble appeal with my promise, wherever you are, I will be there. Promise to reach unreached. Seeking your vote and support for post of President Foxy this year. Please support me, Dr. MC Patel. Thank you very much. With regard, salute to all. Please do not assume. Please ask any question, any query, if time and chairpersons permit. Thank you very much.
Thank you, sir. Thank you. You are always crisp, to the point, with a clear take-home message. Over to the chairpersons for the expert comments.
Sir, I cannot stop sharing something about you. I think, like, the talk which you have conducted today, it seems like you are the textbook of ART law. So, like, who else other than you in whole of India to support all ART specialists and all gynecologists? So the best person to be Foxy president in India. Thank you very much, sir.
Thank you, madam. Thank you, Siddharth. Yes, comment from Dr.
Madam,
Asha.
Narendra sir.
Hello.
Asha Jain, madam. Please.
Yes,
Asha
Jain.
I'm there now. So on the way to Chennai airport. Namaskar, MC Patel sir. Namaskar, Monica. Sorry for cutting your call at that time. So this is, sir, as usual, knows everything about the medico-legal aspects, and he also knows the loopholes in each law. that will help save us, because we understand only the word and he understands the spirit of the word. So I think the clear message that he has given: first, don't break the law. Number two, be ethical. Number three, in spite of everything, if you land in a problem, call me. So I think that is the take home message for today, and wish you all the best, sir. Thank you. Thank you for having me here. Thank you, Monica. Thank you, organizers. Namaskar.
Archana madam, Narendra sir, you want to say something?
Hello.
Yes,
Thank you,
yes,
Dr.
Narendra Gajar.
MC Patel, for a wonderful session exclusively for ART. And the most important messages you have given is don't give false promises. Money back has its own hazards, and do not give 100% guarantee for the success. Sale of the gonadotropins, you have very clearly clarified that a doctor can dispense, but he cannot sell. Major complications in infertility practices are not tolerated at all. Consent everywhere, parties involved is a must, and laboratory mix-up, we have to be very careful. Retrieval of more than 7 eggs was a little bit complicated thing, but you have cleared it. You can retrieve all, but you cannot use more than 7. Do not enter a minor in the program, and 1-to-1 for female, and no restriction for the male for the donation. And the very clear message is no unethical practice. Communication, counseling, documentation, and record keeping are the most important tools to prevent litigation. Thank you, Dr. MC Patel.
Thank you, Dr. Gajar.
Over to Dr. Richa for the next session.
Thank you, sir. Thank you. It was a wonderful and excellent talk, and with so many carry-home messages. I now request Dr. Narendra sir to please welcome another stalwart, that is Dr. Naina Patel, for the next session. Vasu, can we have the CV, please?
I'll stop the sharing.
Yes, ma'am.
Yes,
Yeah,
ma'am.
yes.
Hello.
Temporarily, you have to stop, and then you will be allowed. Yes, yes.
It's
Welcome,
a pleasure
Naina.
for me. Shall I introduce?
Oh, yes.
Hello. It's a
Yes,
pleasure
sir,
for
please.
me to introduce legend Dr. Naina Patel in the field of infertility, and especially her master field is surrogacy. She is a medical director of Akanksha Hospital in Anand. She is considered as a pioneer in the field of IVF and surrogacy. And to her credit, she has 1,731 surrogate babies born at her center. She was the president of SOGAV in 2010, founder president of Gujarat chapter ISAR. She has audited number of research papers, book chapters, and published and edited her own book, Advances in Assisted Reproductive Techniques. She has published and treated world's first case of thin endometrium by bone marrow derived cell therapy in CRM journal. So she has main interest in the research, especially regenerative medicine, gut microbiome, which I have also attended, ovarian and endometrial biomarkers, and PCOS. Naina Patel, please take your mic. Thank you.
Thank you so much, Dr. Gajar, for this wonderful introduction. And I thank Dr. MC Patel for having me over here. Excellent talk by you, sir, and excellent academician. And we wish you good luck. We want to see you there where you want to be. So with that, thanks to my moderators and chairperson, I start my talk today on the Surrogate Chronicle Stories, Hope and Resilience. So 2002, it was legalized in India, and till now we were following the 2010 bill until in 2015, when the guidelines came prohibiting. So 2012, there was medical visa for the foreigners and OCIs. And then 2015, they stopped the surrogacy for OCI PIO and to stop the import of the embryos. And then it was the Surrogacy Act, which was passed in 2021, implemented January 2022. Just before COVID, 22nd January 2020, we had a team of 80 people, union ministers, Rajya Sabha members, team from Gandhinagar, who had come to inspect the hospital when they were preparing the total act, and they wanted to understand the surrogate, what the surrogacy procedure is. They met the surrogates one-on-one. They met the infertile couples who were going through surrogacy. They saw how the surrogates' lives were being changed, and they also interacted and asked about the newborn baby. So the purpose of this new act was to regulate the practice and process of surrogacy so that there could not be any exploitation of anyone, and it goes in a smooth streamline. And the salient features of this act was that the central government has all the power to make the laws, but they had mentioned about the prescribed expenses, minimum qualifications of the personnel, storage of the gametes, how to apply for it to obtain a certificate, the insurance coverage of the surrogate mother, number of attempts, how many embryos to be put, and the consent forms also were done. The main act says that they want to regulate the surrogacy clinics and the procedures with the proper registration. And so they had come up with the national board and the state board of the surrogacy and the appropriate authority. And they have explicitly mentioned the offenses and the penalties. So this is the formation of the national board. We have somebody from Gujarat there, and the state board, where even I am member. And the role of appropriate authority is very, very crucial, because they can grant, suspend, consent, cancel the surrogacy clinic registration, enforce clinical standards, take legal actions if unauthorized surrogacy is found, supervise the act. They can also recommend rule modifications if they find something inappropriate. They will immediately act on any complaints by the couple or the surrogate mother, and consider and approve or deny relevant application. And they are the ones who will be granting certificate to the intending couple or the woman surrogate mother. So first and foremost, we need the registration of the surrogacy clinic, which is online as well as offline. With a hard copy, you have to pay an application fee of 2 lakh rupees. And this is the application form 3. They've also defined the equipment and the staff that is needed, and the minimum physical requirement what is needed for a surrogacy clinic. The inspection must be allowed anytime. National board, state board, or appropriate authority can come, and they can come without any prior notice, but they will take care of the safety of the stored gametes and embryos. And this is the final registration of surrogacy clinic which you will get, and you have to place it in a very conspicuous place in your clinic that you are registered to do surrogacy. Without this registration in your clinic, you cannot do surrogacy for anyone. So this was a very nice thing that a beautiful defined law came up. Now let us see, what does this law give you a hope, and what are the resiliences? I mean, when it came, it was like the one-liner I remember from Dawn. Okay, Dawn ko pakadna mushkil hi nahi, namumkin hai. But gradually, I'll tell you what comes up. So the hope is that it has become an organized sector. Nobody can say that in India, anything and everything can be done. You can do surrogacy at the drop of the hat. Then it will help in creating a data registry in India, so we know actual number of what surrogacy, how many babies born, etc. And definitely the quality will improve, because there is specific mention of the infrastructure, knowledge and skill of the persons, and the human resources. Moreover, recently, government also came up with the 6 months maternity leave for a couple getting a baby with surrogacy. So that female is entitled to that 6 months surrogacy leave. And the most crucial part, because surrogacy is not the first resort, it is the last resort. A woman may be trying for 10 years, 12 years, she gets adenomyosis, and now her uterus is not capable to carry, her ovary is not healthy, she needs donor egg. Or she is an MRKH patient with the husband having no sperms. So there, the donor gamete has now made it possible for such couples, and it was a very positive move in the Surrogacy Act. Also, transfer of gametes and embryos has been properly now explained, that how can apply for it, what is the procedure, and you get the permission from the national board and you can get this gametes transferred to the clinic where you want. Because right now, so many couples have a transferable job, or they want to move to their original place and get the embryos there. So this has been very nicely done. Another is the legal safety. Because of this law, the surrogate mother, the couple, the well-being of the baby, the staff, and the clinic are also well protected because we are following the Act. But in this Act, there are a lot of areas where still it needs to be amended. Indian couple OCI, PIO can do surrogacy. Married heterosexual couple can do it, but they are in live-in, they cannot do it. Single fathers not allowed. And single women can do it, but they have to be married once and become a widow or a divorcee. A single woman by choice who has not found a partner or who does not want to get married cannot avail surrogacy, and definitely that is a gray area. The age limit is another point which needs to be readdressed. Women 23 to 50, men 26 to 55. Also, the Aadhaar card is not 100% proof of age, as Dr. MC Patel just said. So what are we supposed to do? Now there is a woman who has come to us. Her 22-year-old son tragically died in an accident. Her uterus has been removed and she needs surrogacy. She doesn't have a child. But the problem is husband has completed 55 years and is running 56 years. We had to deny that couple for no fault, just because the husband was little overage. Another couple, there was a late marriage and the female is already 50 cross, running 51, but the husband is still 49. Still, they don't become eligible. Don't you think that these areas should be readdressed? And another is a medical indication, very, very crucial. Absent uterus surgically removed, very easy. But if multiple miscarriages, they need all the documents, or the POC was done, or 10, 12 miscarriages, or 5, 10 IVF failures. So this again is very difficult to convince and get a permission. So there also there should be something specifically defined that how we should consider a couple for medical indication. Another one is that if the couple has one child, now even adoption is allowed up to 3 children. A couple can have as many children naturally if they want. But an MRKH, we are allowed to transfer only one embryo in a surrogate, but she has extra embryos, she wants a second child. They cannot do it unless the child is either having a severe disability, mental, physical, or has a life-threatening disease. But even if they had a child through surrogacy or biologically adopted or naturally conceived one child, they cannot do surrogacy. So these are the problems, practical problems that the couples face as far as availing surrogacy in India. Now, who can be a surrogate mother? Understood 25 to 35 years, but many a times the women are really healthy even up to 40. Consent is required from the husband and the family. They cannot donate eggs and they can only become surrogate once. So if a 40-year couple is having a surrogate mother and 3 times the embryo transfer fails, the couple can change the surrogate for the next time with donor egg. But the surrogate who has been surrogate for 3 times with them can never be a surrogate again for any other couple. And altruistic surrogacy is one of the major concerns because we know that nothing comes free in this world. So how would you expect even your real sister to do it free for you? Want to just give her something in kind that, okay, you have done this for me. Not a single meal is available free anywhere. So how can a 9-month surrogacy can be called just altruistic to help someone? Here also, it needs to be specified and properly enacted that they can be compensated for working hours, etc., which makes it more easier for everyone to approach and which makes exploitation less. Now, the process itself is a long drawn. First stage is medical indication. Second is eligibility for the couple, eligibility of the surrogate. And then you go in front of the judicial magistrate for the court order. And we are doing it already, but sometimes the magistrate says, I need to understand, learn more. They give a date after 1 month. So it is anywhere between 4 to 6 months that it takes. And I don't want to go into detail of these forms, but these are the documents 1 to 20 that needs to be filled up. And this is the checklist for the eligibility certificate for the intending couple. All this I have written here. I'm not going one by one into the detail of all this, but important is ID card, their photographs, their birth certificate, matriculation certificate is also allowed. Then Aadhaar cards, marriage proof, if they are divorced, then the divorce deed, everything has to be properly in place. So these is the checklist for that. If they have a surviving child, what problem the child has, everything has to be given. And same for the surrogate mother, all these details, including affidavit of the couple, for the couple who is going to take the custody of the child, or in the case of surrogate mother, the relatives affidavit is also required. If they have children, the birth certificate of each and every child and the detailing is required. We cannot miss out. I have one surrogate who is approached with a couple, but that surrogate mother's second delivery was during COVID at home and does not have a birth certificate of the baby still. We cannot entertain such a surrogate. The couple said, this is relative, known to us. We said, no, you go get the certificate, then only we can enroll this lady as your surrogate. The number of affidavits, right from beginning, 1 to 8, genuine medical records to affidavit to be done. The surviving child or adopted, then purchase insurance, again affidavit, then the custody of the child in case of separation, then in case of death, who will take the custody of the child, undertaking by the nominee, then the affidavit of the couple regarding the creation of embryos, where it was done, which gametes were used, etc. And the affidavit by the surrogate mother and a relative. So these are the affidavits, and the expenses are medical expenses, cost related to medical procedures, expenses arising due to complications, maternal mortality, then the legal parental order, birth affidavit, travel, follow-up charges, and the well-being of surrogate. The couple can compensate directly to the surrogate. And the intended must have a comprehensive insurance for 36 months. Number of embryo, only one. If you are transferring more than one, then there should be explainable answers to that. No individual should promote or pursue surrogacy. They cannot advertise for it. They have to be explained both the parties about the potential side effects, consequences, written informed consent in appropriate language, and the surrogate mother has the right to withdraw her consent for surrogacy. So we had a couple person who was working in his store, his wife became a surrogate. The first transfer we did, the surrogate aborted at 12 weeks. It was triploidy 46 and 46XXX. And then the second time when the transfer time came, the surrogate says, I don't want to do it. I am withdrawing from this. So this is the withdrawal form. This is the medical termination form. And the custody passed by the court judicial magistrate is the certificate. This is the pre-birth affidavit. And then birth certificate was also there. And maintaining the records, it's 25 years. So imagine how much of records, and we have to prepare 3 files, one for us, one for the couple, one for the surrogate mother. So all these files with each and every document should be there with us at any given time, because the offenses and penalties are huge. You can understand that what they have said, 5 years imprisonment, 10 lakh rupees fine, which can go up to 25 lakhs also. The imprisonment can also be increased. And the most important, it is a cognizable, non-bailable and non-compoundable offense. So you don't get a chance to protect yourself first. You are arrested first, and then you have to give the explanation. And the hierarchy of the central, state, appropriate authority and national. We are at the mercy of appropriate authority, how they interpret the law at each and every step. So there is too much of official governance, and you can understand the red tapeism. The implementation is going on, but there are certain states which are devoid of the state boards also right now, and they are not functioning. They don't know what to do with their surrogacy patients. The court orders judiciary, but we know that now that act has come and we have to go by the act. But see the number of court cases that are going on in the local courts, high courts and Supreme Courts. That means it has got certain gray areas which needs to be addressed, so that so many FRIs are not done in the court, and the people will have a clear picture all over India what's happening. Practical problem, it's taking a long time. One couple had got their surrogate, everything went on. By the time we got the essentiality certificate, the surrogate got naturally pregnant and the whole process stopped. And now they are getting another surrogate mother and starting with the same process. So the process is very long. There should be a timeline given that the day it is decided and the files are submitted, within 90 days, 60 days, 45 days, they will get the permission. So it has increased the social, financial, emotional, psychological burden, and even a legal burden. For surrogate also, there is restriction on repeating if 3 transfers fail. And there are a lot of legal issues, lack of autonomy, and doctors also, the documentation, permissions, registrations, counseling, punishment, and the couples bargaining for the cost. But we are only charging for our procedures, pregnancy, delivery. The rest is all what is happening is through the legal department. And now I know the legal department also is charging extremely steep for surrogacy cases. Lawyers are having a good time because all the consents are taken and then they can charge. And then, so the surrogacy process literally starts in a lawyer's office and then comes to the medical part. To conclude, I will say that Surrogacy Act has been very well defined, but it has it has established a legal framework, ethical standards, rights, transparency, clear guidelines, minimizing the misunderstanding and disputes. But the restrictions on the age, couple with one child, that makes the couples really suffer. Pure altruistic, making it very, very difficult. Some of these points should be really addressed. Penalties are very harsh. They should be diluted. It is more regulated than empowering. And the final thing I will say that if the amendments are not done, underground surrogacy will flourish, and this will give the chance for real exploitation of all the people involved. So we need a little softer law. But yes, the law is welcomed. It's giving hope. And now that we have our surrogate pregnant and now going to be delivered, I can say that dawn ko pakadna mushkil hai, namumkin nahi. Thank you.
Thank you, ma'am, for the wonderful lecture. And from your dialogue, I can clearly say that you are the Shah Rukh Khan of surrogacy. It was a wonderful lecture. Do any chairmen want to say anything? Narendra sir, Asha ma'am, Archana ma'am. Yes, sir.
Hello. So dawn को पकड़ना मुश्किल है, नामुमकिन नहीं. But who is the dawn? As Dr. Naina Patel has very rightly said, that empowering this practice will gradually flourish the underground practice. Say, for example, in PNDT. So it's a burden from social point of view, financial, emotional, psychological, and legal burden. And lawyers will be earning more than the doctors under this act. This act is brought with a good intention of preventing unlawful practice, but it can cause more harassment to the genuine doctors. There are certain gray areas which he has very nicely narrated, especially as far as the age limit of a woman, 23 to 50. Am I audible?
Yes, sir.
So what about a lady who has completed 50 years and 2 days? So does she need the legally deprived because of only 2 days? And what about male also, 26 to 55 years? So these borderline areas need to be readdressed. Only one child, again a problem. Artistic surrogacy really needs some changes. And the worst thing is in no other law, you have to maintain record for 25 years. Maximum what we were understanding was 21 years for obstetric, but here 25 years. And imprisonment. Nowadays, every law is more focusing on imprisonment of doctor. Maybe it may be, say, 3041, where imprisonment is now final. Fine may be alternative. So again here, imprisonment for 10 years and 10 to 20 lakhs, really too big, very big amount. And the worst thing is that it's a cognizable, non-bailable, and the worst of all is a non-compoundable, where you cannot settle it outside the court. Means case will go on for 5 years, 10 years, and unless there is judgment, one cannot be acquitted. So in the end, I would like to say that we are at the mercy of the appropriate authority. Once again, thanks Dr. Naina-ben for a wonderful talk, and you have cleared almost all aspects of surrogacy. Thank you very much.
Thank you very much.
The lady dawn of surrogacy, who has put who has put India onto the map of the globe. Right? It was really, really wonderful listening to you, Dr. Naina. I would ask you one question. You say that Aadhaar card is not counted as a age proof. Then what else can be done?
That is what we are. That is what, because even the government has said that Aadhaar cannot be considered as a proof of age. But that is what we are doing right now.
Right now,
Passport, Aadhaar card, these are the most of the people have Aadhaar card, so we go by that.
So here, I think our president, Foxy, Dr. MC Patel will be able to guide us on this. Like if by chance, if something goes wrong with the age of the patient and Aadhaar card is not accepted, what else can be done? Because we are just like, as you rightly said, Dr. Naina, that we are just like charging a peanut for like services, and then we are like responsible for all these things. So I think Dr. MC Patel can guide us on that. Thank you, Dr. Naina, for enlightening us.
Thank you so much, Sheetal. Always nice to have you as a chair.
Thank you.
Thank you, everyone. I hand over the session to Dr. Monica, ma'am.
Now we are proceeding to the third talk, that is on the ethical and emotional complexity in ART by Dr. Himanshu Bhaveshi. I request Narendra sir to introduce Dr. Himanshu.
It's a pleasure for me to introduce Dr. Himanshu, who will be speaking on ethical and emotional complexities in ART. He has been awarded the most prestigious IMA award, that is Excellence in the Field of Medicine, and First Childbirth of India with Vitrified Frozen oocyte. He has written a comprehensive book on a practical guide to intrauterine insemination, and BFI has organized many conferences, CMEs, and workshops and teaching programs. There are many books to his credit, especially on patient awareness, and he has organized many patient awareness seminars and programs, including IVF Babies Meet in 2004. The founder president of INSTAR, that is Indian Society for Third-Party Assisted Reproduction Technique. So I invite Dr. Himanshu Bhaveshi to deliver his talk.
Thank you so much, Dr. Narendra, and all the best to MC Patel for, can you please allow me screen sharing here?
You can share, sir.
Okay. So the aspects which were discussed by Dr. MC Patel, and then of course by Dr. Naina Patel about the complexities and all of the can you see my share now? I mean screen?
Sir, we can't see.
No? Okay. Okay, Mr. Vasu, okay, enter scheme. No, but I don't think it's possible. Is there any problem at your end, Doctor?
No, sir. You want me to share, sir?
Okay, you may share, but then how will you change the slides then?
I'll follow your talk, sir. No worry.
Okay.
You can try once again. If not, I'll just open the PPT in your this thing and go to share screen.
PPT is open.
Go to share screen. entire screen you can select.
A green icon which you can see below of your
Entire screen doesn't work. I'm trying entire screen only.
After entire screen, directly you can you can open the PPT and put it in full screen, sir.
Can you see it now?
No, sir.
Okay, please, Vasu, you can start from your end so that we don't
Yes.
waste time here. Okay, please share the screen so that we can continue. So after wonderful talk of Dr. MC Patel and Naina Patel, this will be a talk on emotional and ethical issues in ART. The issues are so many that we can keep on discussing for the day or days also, because there are multiple things involved in the whole process. Every individual. Okay, what is happening? No, it shows that there is echo here.
There is echo here.
Hello.
Hello.
What is happening?
What is happening?
Are you
Am
from
I
Code
audible?
Am I
Devices?
audible?
No, I am not.
No, I am not logged in.
I think now it's okay.
Okay. I can
But
see you, Monica ma'am, but I don't see the screen here, so I don't know
Ah.
what is being presented.
Sir, Abhi,
So-
now the screen is not visible. Rahul, please share the screen.
Yes, yes, ma'am. Vasu sir is going to share the screen. I
Okay.
think, is it visible?
Yes, now it is visible.
Okay.
So ethical and emotional complexities in ART. As we have discussed, there are a lot of complexities in the process of ART. And that is why I'll be discussing first is emotional. Next slide, please. So the first question comes to the mind of a couple is why me? Everybody is conceiving, the less educated, more educated, less wealthy, more wealthy, less fit, more fit, whatever you call it. Everybody conceives and have a baby, and why I'm not having. And that is first place where the couple cannot accept that they are facing a problem in conceiving. Then they try to explain themselves that we have not tried seriously, we are not doing that, we have obesity, we are busy, we are stressed, we are not doing this, that, obesity. And that is where the problem comes in. So that is the first starting point. Next, please. The second thing always in the mind of a couple is natural conception only. They feel that any treatment is not natural and they want to have a natural pregnancy. So it's become difficult for them to accept that they are not having something which is naturally possible and they need to do something artificially. Next, please. Next, please. And then particularly when they go to a doctor and as a surprise something comes in like low AMH comes in, fibroids comes in, poor endometrium comes in, poor semen report comes in, and the chances of success are less. In that situation, it becomes very difficult for a couple to accept that why they are facing this problem. And then the whole reverse cycle starts in that what should we do? I am not a complete man, I'm not a complete woman, all those kind of things. But there are additional new age problems also, that the couples are married but they are not having intercourse. They come to you for fertility treatment even without having intercourse for a single time. They say we are not interested, we are not having regular intercourse, and then you need to counsel them for that as well. Next, please. Just like as I said that it comes up like fibroids or endometriosis or something like that, where you have to explain to the patient that you have to do this first or that first, you need surgery first or you need straight away IVF. It becomes such a big surprise for a couple that they don't accept, and then it becomes difficult for them to manage, and for them it is difficult to cope up with the emotional stress of the whole situation. Next, please.
Then what are the solutions? Now, solution for an emotional problem is very, very difficult because it is such an highly individualized thing. Every couple is different, every man and every woman is different, the situation of every individual couple is different. So solution in terms of straight away prescribing a medicine or giving a common advice, it not possible in this situation, and this requires lot of time and understanding, not only from the consultant but from the entire team. That is why it is very important that the whole team is sensitized to handle this type of situation. It demands lot of efforts and time from the whole team, which in unfortunately present time people don't have. And that is where it is becoming even more difficult for us to provide solution to the emotional stress of the couples. Next, please. The best solution, of course, is counseling, and the counseling is unlimited. What you will counsel is endless. And even the Act says that you should counsel the couple which is humanly possible. Now, what is humanly possible? You can understand. So, this kind of couples which we are facing emotional stress, they feel bad for anything and everything what happens. Even if a nurse takes a needle of 22 gauge instead of 24 gauge, they become upset. They become upset if their name is not called properly. They become upset if some privacy issue happens or anything, because they are already upset, and anything which triggers the whole thing. So we need to very carefully counsel each and every couple. Your counseling team also has to be very, very well prepared so that they understand the social, emotional, etc. aspects of the couple and counsel them accordingly. Next, please. Next, please. And the best way to cope up with the stress is, sorry, the previous one, is the support. The support from husband and family makes a big difference. And fortunately, in India, still family system exists, and there are advantages and disadvantages also. Some families are so supportive that the couple becomes very relaxed and the treatment goes on smoothly. And some families, the pressure of the family is so much that it adds up considerably to the emotional stress. And that is where, if we can ensure support of husband and family, it makes a big difference. So that is what about probably emotional aspect. Now we go to the ethical aspect, the whole thing. Next, please. Next, please. When we talk of ethical, next, please. One thing is very clear, and that Dr. MC Patel has very well highlighted. Legal is legal. So now ethical and legal must be separated very clearly. Whether you believe something is ethical or not is not important if it is not legally correct. So legally correct only can be practiced, and that is where ethical is comes next, legal comes first. So legal is legal. When we talk of other things, we talk of ethical things. Next, please. Next, please. Next slide, please. Okay. Now that is, no, sorry, previous one. No. Now that is the beauty, unethical in past is legal now. Like in ICMR guidelines, which we used to follow, the known egg donation and known sperm donation was not encouraged, or it was called as it has to be anonymous. At that time also, we used to feel that this is not a good practice, because if a sister wants to donate for her sister, what is wrong, what is bad about it? But it was, as per the guidelines, not a good practice, and that is where so many people believe ethically it is wrong. Now, today, with ART Act in place, it is perfectly legal to have a known donor donating for the couple. So, whether it was ethical or unethical, now it's a matter of past. It is legal now, so you can practice. But then again, it is up to you whether you would like to practice or not. It is your personal choice. Next, please. And that is where it comes, is that your ethical is always subjective. What I mean by subjective? You must be part of groups of gynecologists and IVF specialists of India on various forums. and you must be reading the debates going on different forums, and you see that, can you please mute? Somebody else is audible. Please mute. I think Vasu, you are
Yes, sir.
unmuted. So can you please mute yourself? So we were talking about the discussions going on various forums, and those forums, you must be seeing heated debates on what is ethical and what is not ethical. And that is where we need to understand that it is a matter of subjective thing. So when it is legal, we are bound to follow it. Like you drive on the left side of the road, you are legally okay. You drive on the right side of the road, you are not legally okay. But if you feel that this is correct or not correct, is not valid at that point. And that is where legal is legal, but ethical is subjective. Next, please. Now, what I mean by subjective is, I'll discuss in detail. There are certain things which are ethically wrong, and that is undisputed wrong. That is gamete donation without the knowledge of couple, which is still quite common practice going on. So, without the knowledge of couple, gamete donation is totally unethical. Gamete donation, because if you have taken the consent, you may be legally right, but ethically wrong. So, without the informed knowledge, it's not that consent I'm talking about. Consent and knowledge are different, because you ask the patients to sign a lot of consents. Patient is not able to read each and every consent. They sometimes even don't know what you are signing. And that is where what I am saying here is knowledge, a clear knowledge in the mind of couple, what she is doing. That is very important. Again, a very common situation, request for gamete donation by one partner, maybe female partner, maybe male partner, without the knowledge of another partner. And that is again not ethically correct. And last, and the partner will say that I'll get the consent or the sign of my spouse. So legally you may be right because you have the sign, you can claim that it was signed, but ethically it's wrong. At the same time, last moment donor embryo transfer. This is again a very common practice, that your embryos are not good. Let us put one OD embryo, one EMD embryo, something like that. And that also is not an ethically correct practice. Next, please. But sometimes, as I said, that ethical practice is a personal choice. Like what we see is there are two clear trends we see. Certain clinics promote self eggs, try to convince the patient that you should go for self eggs even if the success rate may be less. Whereas certain clinics or doctors personally feel that the patient has come to me for the results, and whatever it may be, gamete is not important, patient should become pregnant, and they encourage donor gametes. Even sometimes gynec friends request us that the patient is not affording, do donor eggs, but give him pregnancy. So this is something which is not a ethical thing, and I think personally, I don't prefer. Personally, it's a matter of choice that we should explain the patient the pros and cons and let the patient decide. Next, please. Previously, you must have heard even the senior most consultant that embryo donation from the leftover embryos of the patient was being practiced. Even patients, so many patients happily want to donate their embryos after they have their own child, but now it is legally not allowed, so it's legally not allowed. Ethically, you may like or you may not like, is completely out of question now. And similarly, egg sharing was also practiced before ART Act with the consent of the patient. Now it is not legally allowed. So whether ethically you like or not like, you cannot share the eggs of either the patient or a donor. Next, please. Now again, ethically, whether it is right or not, like you convince the patient that freeze-all is best. Now whether it is real or not is always a question mark. But it is your personal choice and you convince the patient. So whether it is ethically correct or not will remain a dilemma. Similarly, if you say that recombinant is the best and you blindly prescribe recombinant gonadotropin to each and every patient, whether that will be ethically correct or not will remain a dilemma. Next, please. Similarly, everybody on the dais claims, everybody on discussion forums claim, even the speakers claim on the dais that they prescribe this is useless, this is something like that, you only give this much. But when you see the prescriptions of the patient after embryo transfer, you will see that there is a combination and cocktail of drugs being prescribed, which may not be ethically correct. We should give only the drugs which are necessary for the patients and sufficient for the patients. Next, please. No, you went back. Next, please. Now, this is a biggest dilemma. IVF for all. Like when we discuss in the gynec forums or whenever we go for a presentation or a talk, and when we talk about that how frequently IVF should be offered to a couple. A couple comes to you with the wife's age is 35 years, they have tried for 3-4 years, not conceived. They of course have all the options, they have not tried much, so they can be treated as any other couple. But should you go for IVF or not? A borderline semen report, a borderline AMH report, a couple who is married for 5-7 years and not conceived, multiple other things. Or even sometimes a couple comes that we are tired of taking treatment, we have done this much and we want faster result. A couple coming from abroad does not have time, wants fast result. All these situations, IVF becomes a choice. Now, whether it is considered ethical or not, this dilemma remains. And that is where sometimes even IVF by demand or on demand, patient says that, no, doctor, I don't want to try IUI and all, I want to try IVF. Whether we are right in offering that or not is a big question mark. But personally, I feel that we have to customize, counsel, explain the patient advantages and disadvantages, the option the patient has, and if the patient still chooses IVF, there is nothing wrong in offering IVF to that patient. So that remains a debate, but those who are not offering IVF would always claim that this is too much, for a couple. People are promoting IVF left and right. People are promoting IVF for the couples who can otherwise also conceive. We may be right, and they also may be right, that maybe 30-40% of the couples who go for IVF might conceive or might have conceived naturally. But the fact is they are not conceiving and they want to conceive now in a given time frame. How will you help? And that is where, if we explain the patient the choices they have, the options they have, and allow them to make an informed choice, I think we are doing an ethically correct practice. Next, please. Now, biggest debate is add-ons in IVF. Now, it may be lab techniques like microfluidics, PGTA, laser-assisted hatching, IMSI, PICSI, whatever it is, or may it be in terms of medicines like micronutrients, antioxidants, gut flora regulators, and all other stuff. And it may be in terms of some procedures like ovarian PRP, subendometrial PRP, etc., etc. Now, all this so many times happens that they may not be 100% proven. But would you give it or not? And that is the biggest question. That debate is never ending. And in that case, you should be judicious. You should have reason to give. You should have genuine reason to give. You should have genuine belief or experience to understand that what you are giving, at least you are not doing any harm, and you are not wasting too much of money of the patient, and you are not risking the success of the patient. Maybe the patient may benefit little less or more, that may be a second question, but at least we are not doing any harm. We also do not give any unrealistic expectations to the couple. We tell them the truth and the possibilities, and then if we do it, probably that is right. Now, that is next, please. And that is where the biggest question will come, is evidence-based practice. Now, what is evidence-based practice? Evidence keeps on changing every day. And evidence not only keeps on changing, the guidelines also keeps on changing every day. Even there is no uniformity in guidelines of each and every body. ASHRAE, ASRM, or any body if you take, there may be difference of opinion in the guidelines as well. And there may be something which may be offering advantages but may not be statistically significant. All these situations, it becomes difficult for you to decide what you would do. Now, that is where I give an example of a case which is no one killed Jessica. Jessica was killed, but it was not proven who killed Jessica. And one fine day, it was proven that who killed Jessica. So, what is important for us is that we cannot be blindly following the evidence. We have to use our own sense of evaluating the evidence and the suggestions and the practices followed, because first comes in the idea, then comes as a thought, you refine the idea, then you experiment, then you collect your own experience, and then you do the testing. So if you just practice evidence based practice blindly, you are not doing anything but blindly following the world, and you are not using your own senses. So I would not say that we have to blindly follow the evidence based practice, but at the same time we cannot close our eyes to the evidence what we have. Next, please. And that is where the last, sorry for the spelling mistake, the last message what I would like to give is, we have to be ethical, dil se. What is important for is that what our heart says is most important. And we have to be genuinely ethical, not just to show off, not just to please someone, not just to be happy or pretend happy. We really should be happy from our own heart that what we are doing good for the couple, we are doing in the best interest of the couple, we are doing the best justice to the couple who has put faith in us, and we should do that practice. And that is the message I would like to give here. Thank you so much for your patient hearing and participation. All the best to Dr. MC Patel for your election.
Thank you, sir. That was an
Thank
excellent
you,
talk.
Himanshu bhai.
Thank you, sir. I request chairpersons to give the expert comments.
Monica, you can conclude and proceed with further session.
I request Richa to conclude the session.
Oh, yes.
Thank you so much. Thank you all the speakers and the chairpersons. It was a very informative session, and I'm honored to hand over to the next coordinators, Dr. Akash Gajjar and Dr. Pratibha Baldawa, to coordinate the next session, please. Thank you.
Thank you so much, Dr. Richa. Am I audible?
Yes,
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 ma'am.
you are audible.
Yes, yes. Okay, so we welcome all of you all to the next session, which is Hormonal Harmony. The entire CME from the morning has been very informative, and it has given us many insights. We now take you forward to the session 5th, which is Hormonal Harmony. For that, I invite the chairpersons, Dr. Kalpana B and Dr. Sujal Munshi. Can I have their CVs on the board, please?
Dr. Kalpana is not available. She had some problem, so she had a call to me. She will not join. So you can go accordingly.
Yes. Dr. Sujal Munshi, sir, is a consulting gynecologist and obstetrician at Munshi Group of Hospitals. He's a consultant endoscopic surgeon at Pulse Women's Hospital, a visiting faculty and consultant gynecologist at Genetic Studies Zoology Department, Gujarat University. He's also a visiting consultant at... He is a lifetime member of Ahmedabad Association, OBGY, and a member of KMA. Welcome you, Munshi.
Thank you for a kind introduction. If we can have, should we proceed with the session? Yes.
Yes, yes. Yeah. Please introduce our first speaker, Dr. Sunja Malik.
The audiovisual team, if you can just highlight the short CV of Madam. Dr. Sonia Manik Madam does not require an introduction. Various key positions, including Child Advocacy Committee in 2018, Infertility Committee, FOXY, past President, Indian Fertility Society, Indian Menopausal Society, and the list goes on. Madam has a lot of training and teaching sessions we can see in the slides, and some very prestigious awards, including IMA Kanak Goyal Award, Lifetime Achievement Award in 2015, Best Dr. PC PNDT Cell, Delhi, and Indian Fertility Society Lifetime Achievement Awards. Madam, we welcome you to this platform and kindly grace the occasion with your speech.
Thank you very much, Dr. Sujal. Thank you, first of all, Dr. Patel. Many congratulations to you for continuously holding these webinars without losing your patience and actually imparting so much of knowledge to everybody across the country. You are so inclusive in your webinars. You're taking people from everywhere, and that is the most important thing over here. In this webinar also, you have involved so many of us, and that goes to your credit to a large extent. I thank my two moderators, Pratibha and Akash, and of course, Sujal over here. Thank you very much for having me here. I'm not going to waste any more time because we are already running very late. I go on to my slides. I hope you can see my slides. I'm going to put it on slideshow. So first of all, let me wish you a very happy Guru Purnima today. Most important for us to learn all the time, and that is exactly what is being taught to us today. And then I also extend my happiness to tell you all that we have the World IVF Day also approaching very soon on the 25th of May. With all these wonderful days coming and telling us what we should be doing, let me just start with what Dr. Patel has given me. Fading fertility. I thought it was a very interesting topic to talk about, fading fertility, decoding the ovarian insufficiency. So let us take a little look at what is happening, and we should understand that actually only organ which dies during an individual's lifetime. There is no other organ that stops functioning during a lifetime of an individual. And actually, as is said here, Anderson said that ovarian aging is considered as a pacemaker for female body aging because it starts the whole thing. And let us now look at the state of aging across the world. We are so alarmed because there is not only aging happening in the women, which we are all aware of. As menopause hits us around the age of 50, we know that there is a decline in the ovarian function. But what is also happening is the male factor, which is also aging. The counts in 1973 were the tune of 101 million, and they have now fallen to 49 million. So as a whole, there is a lot of fall in the reserve of gametes across nations. It's a worldwide global phenomena. This is not just hitting us. This is actually happening all across the countries. And if you can see over here, the global fertility rate has fallen from 5.5 to 1 point something today. As you can see in this slide, 1950 it was 6.1, and now it has fallen to the tune of 1.01. So therefore, what we are looking at now is that there is a huge fall in the birth rate. The classic example of that is China, which is also a populous country like ours. And in 1979, China introduced the one-child policy. In 2002, they introduced the family planning law. But in 2013, they allowed the couples to have a second child if they had only one parent. And in 2015, they reversed the law. Why? Because there was a fall in the population. And now with all this, they are seeing somewhat balancing of their birth rate. So it is very important for us to understand that it is not just fertility which is hitting a couple, it is actually hitting the nation. And look at the fertility rates in India now. The Indian scenario is that the fertility rate declined to from 5.9 in 1950 to 2.1 in 24. And the global decline is also to the same tune. This was a very interesting study which was done in 2016, which told us that the total fertility rate decreased according to the education of the woman. So basically, when there was no schooling, it was 3.6 and 3.1 also in 2015 and 16. However, with a little bit of education in the women, it fell to 2.2. And now with more than 12 years of education, the fertility rate has fallen to 1.7. So there is a lot of shrinkage in the fertility even in India. And that is what we must be aware of. Let me just talk about these few definitions. What is replacement level fertility? The total fertility rate is the replacement level fertility, wherein the population remains static. It does not fall or it does not rise. So, and this is supposed to be 2.1. The total fertility rate, incidentally, is the total number of children a woman can have during her lifetime. Highest fertility rates are found in countries like Africa, and for 2021, the highest total fertility rate can be found in Niger, Angola, Democratic Republic of Congo. And the lowest fertility rates, incidentally, are in Southeast Asia, besides Europe, wherein you find have a fertility rate of 1.1, which we have also achieved in states like Sikkim. So we are also going into the same kind of a situation where our fertility rate is falling. And this is what was now found out. But look at this rate in NFSH 5. In the urban areas, it is 1.6, and in the rural areas, it is 2.1. Bihar, Meghalaya, etc., these states are still above the TFR. So therefore, we are basically kind of trying to balance ourselves, but it is varying from state to state. Predictions that Lancet has made is that by 2015, 3/4 of the world will not have enough fertility rates to sustain a population. And in by 2100, 97% of the countries would have a fallen fertility rate. Also, this would mean that most of the African countries would be more populous and the others are going to be dependent upon them. So this is basically shown in this population pyramid, where you find that the pyramid shifts. The youth population is reduced. We are still all right. We have balanced our youth with our old age. And so we are all right. But if there is no youth left, then the economy of the country suffers very badly. And you know that you don't have any workforce. So with all this happening, there is a matter of concern, and it is not only a personal problem. It is not only a problem of doctors. It is a problem of all the people in the country. And we must understand that declining fertility rates are they are different. For the urban population, it is more or less the lifestyle factors which are causing a decline, especially late marriages, which I haven't mentioned over here, and education of the women, as I had described earlier. But these are the other reasons that we know as doctors and we are very concerned about. In the rural area, it is essentially the genital infections, the fertilizers and pesticides which are responsible for this. Now, menopause also occurs 5 years in advance in the Caucasians. This is what we know. So therefore, there is a reason to really understand and try and find out what is happening to us and why this premature ovarian insufficiency is happening. What can we do to avert this? So essentially, it is a clinical syndrome which is defined by the loss of ovarian activity before the age of 40. And it is characterized by menstrual disturbances and raised gonadotropin and low estradiol levels. Premature ovarian insufficiency is a term which should be used, and we should not use terms like premature menopause, because the connotation of menopause is very, very traumatic or emotionally disturbing to a person who wants to have a child. So basically, if an elevated level is 25 or more on two occasions, then it is insufficiency. But if it is 40, then it is premature ovarian failure, and we can really do nothing much about it. And then, what are the causes of this particular entity? Is it any different from what we have seen in the just now enumerated to you? So there are genetic risk factors where there is a family history of menopause, Turner syndrome, Fragile X syndrome, FSH polymorphism, which I have described here. There are 2 polymorphs which are basically responsible for this, and high endogenous serum concentrations and a long follicular phase length suggest that the patient may be having a problem with such as FSH polymorphism. And so in these patients, you need more exogenous FSH to cause a ovulation to happen. Endometriosis is becoming rampant, and it is basically because of the inflammation around in the tissues, also the compression of the surrounding tissues, that basically a person is rendered infertile and has premature ovarian failure. Infections are very well known to us, tuberculosis and PID. All this can lead to premature ovarian insufficiency. Obesity is gaining ground. We are finding that many people in our country are now obese, whether it is men or women, and in both of them there is a problem. In women, there is altered follicular environment, and higher dose of gonadotropin stimulation and longer treatment is required in such women. Smoking, on the other hand, it increases the ROS levels and it is harmful for both men and women. Medication, prolonged HPO suppression, such as with OCPs, ATT, metformin, these are known to cause a problem with the ovarian function. Uterine artery embolism also, when it is not given to the target organ, can cause hypoxic ovarian damage. Environmental toxins, as we all know, air pollution, water and soil pollution, everything is taking a toll on our ovarian and semen function. Today, we are talking only of ovarian insufficiency. So then coming to the fact that we are having this group of patients, the people who are coming to us for some kind of a help to get pregnant are either young who want children, but they are normal, or they are young who have a declining ovarian reserve, and they are old but desire children but cannot have them. So basically, we have to understand how we are going to decipher the cause in these patients and what we are going to do to help these patients. In order to diagnose premature ovarian insufficiency, we all know that we have hormonal biomarkers like FSH, inhibin B, anti-Mullerian hormone. Anti-Mullerian hormone is now the most fashionable hormone which is being practiced nearly by everybody, whether it is a GP or a gynecologist or a super specialist. Of course, all these have their own pros and cons. The functional biomarkers are the antral follicle count, and then you have genetic biomarkers and dynamic tests. In addition to this, we have the ultrasound, which is also a dynamic test and helps us majorly by defining what is basically, as I have told you over here, the antral follicle count. Now, when you have diagnosed the patient as having premature ovarian insufficiency, you categorize these women into the 4 Poseidon groups. This Poseidon group was started in 2016, and it actually divides the patients into 4 groups: the younger patients and the older patients, less than 35 and more than 35. So group 1 is less than 35 with adequate ovarian reserve. Everything is normal, but then you suddenly get a surprise. This is unexpected poor response. When you stimulate these patients, you find that there is very little response coming from them. Similarly, in the group 2, you have the older patients, more than 35, with adequate ovarian response parameters. However, they still get a poor optimal response when you are stimulating them. Group 3, on the other hand, are young patients with showing poor ovarian reserve parameters when we are trying to test them. So this is group 3. And in group 4, so this is expected poor response in group 3 and 4. Group 4 patients are old and with poor ovarian reserve. So this is one of the worst groups, basically, where we have very little means to help them. But even in group 3, you may find a problem. And of course, these 2 are coming as sudden surprises to us. They're seemingly normal, but then when you stimulate them, you find that they are not responding. So what are the options that we have for treating these women who have a challenge of premature ovarian insufficiency? You either proceed with your own gametes with altered protocols, or you give them donor gametes, or you tell them to go and adopt a child. Or you may even halt or reverse this premature ovarian insufficiency. So let us look at all these options and see what we can do. So these are some of the new protocols which we are using now to stimulate these poor responders, or these people who really seemingly do not seem to be responding very well to stimulation. Either you use a natural cycle and you target a single follicle, and then you go ahead and do either an IUI or an IVF in them, or you can do a minimal stimulation cycle where you stimulate with clomiphene and HMG, and then you give a GnRH agonist trigger or an HCG trigger, and then you collect the eggs. These are basically to target 5 to 7 follicles for younger patients, good responders, and PCO patients also. But yes, we are using this protocol also for poor responders. Similarly, the mild stimulation protocols using clomiphene and gonadotropin, or letrozole and gonadotropin with the GnRH antagonist protocol. So these are low stimulation protocols which we are now using to be able to have or collect eggs in these patients who are seemingly poor responders. Then came this very exciting idea of dual stimulation, because we got to know that in a given ovulatory cycle, there are more than one follicular phase, one phase of follicles coming up. So therefore, there were 2 or 3 even times that the follicles get stimulated in one menstrual cycle. And taking a cue from that, from these multiple phases of waves of folliculogenesis, we started doing these double stimulations. So what you do is you stimulate as you do with HMG or FSH, and then you give a GnRH agonist trigger and collect the eggs. And after 3 or 4 days, you again start the second stimulation within the same cycle, and then do a second OPU within the same cycle. This is one way of collecting same double number of eggs within one cycle, menstrual cycle for a patient. So in this, of course, you have to freeze all of the eggs because the luteal phase is already been utilized and you don't know, you cannot transfer them. So oocyte collection was another brilliant idea where you are minimally stimulating or modified natural protocol you're using. And then you give either give letrozole, HMG, antagonist, and HCG trigger, or you can even use clomiphene instead of that. And then you use do an OPU and you do the oocyte freezing. So you do multiple such cycles. You keep on giving these cycles one after the other and keep on collecting 1 or 2 oocytes that you get from these patients. So these are for the very old patients. And then when you have multiple cycles, you do an ICSI and do an embryo transfer after doing a PGTA, explaining to the patient that you may be having a problem with the genetics of your eggs. So they may be mostly aneuploidies, and hence it is recommended that we also do the testing. So these are 2 very nice, exciting innovations which we have now for dealing with such patients. Now, how can we halt ovarian aging? We have non-surgical methods and surgical methods. What is xenotherapies? Xenotherapies are basically drugs or molecules which are used for delaying or reversing age-associated infertility. They have been assessed in early animal studies, but in humans also we have some clinical studies of these. Some positive effects have been related to the prevention of follicular atresia as well as improvement in oocyte quality. So therefore, this is basically done through oxidative stress reduction. And hence, you see these xenotherapeutic agents over here. Rapamycin is one. NAD and precursors are also there. But what we have been using is resveratrol. As we know, this is the outer layer of the grape or the grape seed oil, which is being used. This improves the telomerase activity and length and decreases the ROS level. Melatonin also has been used to improve the oocyte quality, as we all know, and also coenzyme Q10 and NAC. So all these are known to delay the the menopause and enhance the fertility in patients who require them. So some of these are now being used quite frequently by the doctors. What is the effect of the gut? What is the effect? This is a very exciting area which has now come up, the gut microbiome. And any drug which we are using will, of course, affect our microbiome. So there have been studies to see what is the effect of these drugs that I've just mentioned to you on the microbiome of the woman. So this resveratrol actually affects these gut microbiota, and therefore, although the egg laying, there is a reduction in the egg laying capacity of the hen, but the levels of E2, etc. are increased, and the ovarian weight and primary follicular genesis is also increased. Oocyte quality is better. So hence, this does not have a detrimental effect on the microbiome. Similarly, melatonin and rapamycin and MNN are also known to affect the microbiome, and probably it is said that it is due to its effect on the microbiome that it is actually enhancing what we are finding in the ovarian function. Again, the fecal microbiome transplant. This is a very interesting thing that has come up now, used in many diseases, for instance, diabetes. And basically, the feces of a normal person is actually transferred into a recipient gut. And then it improves all these cytokines and all these places. And then it can reverse menopause by causing pro-osteoclastic cytokines, decreases them. Osteoclastic biomarkers also decrease in, and osteoporosis improves. So this is just one part of it, but follicle loss and ovarian fibrosis is also decreased by just reversing this. So therefore, microbiome function has become a very big thing in ovarian function and reversal of ovarian function. What are the biological therapies that we are now practicing? These are, of course, experimental protocols. But we have platelet-rich plasma, or PRP, as we know. the exome therapy, in vitro activation, stem cell therapy, microRNA, and mitochondrial targeting therapies. Now, these are some of the new therapies for prolonging reproductive potential. Ovarian rejuvenation through PRP and bone marrow stem cells, which is becoming very popular, and many of the IVF specialists are using it. Oocyte cryopreservation also is being practiced widely now. Ovarian tissue cryopreservation is also there in the country, but not to a such certain large extent. Ovarian activation and artificial ovary formation. What is platelet-rich plasma? This procedure utilizes the platelet injections to stimulate non-hormonal production and restore fertility in women who are suffering from deficiency in hormones also, as well as the number of oocytes that they have. So basically what it is doing is that when the platelets degranulate and they release cytokines, these cytokines are, they are basically, they activate the ovarian germ cell stem lines and therefore produce help in promoting follicular genesis in the dormant primordial follicles that are present over here. So essentially, they have these growth factors and they also have the angiogenesis factor. So both of these together are going to cause rejuvenation of the dormant follicles over here and hence increasing the ovarian function. So this is a very common method which is being used now, not only for the ovaries, but it is also used to rejuvenate the endometrium. What are the pros and cons? I just want to elaborate 2 minutes on this. Basically, there is no standardization of the methodology for making PRP. There is no set protocol for timing the injection, no protocol for frequency and numbers of PRP, and there is no protocol for assessing its results. So therefore, we are just in the beginning of this procedure. It seems to be doing well, but we are not sure whether we are doing the right thing or not because there are no set protocols. However, when you're looking at the pros and cons, the good clinical practice guidelines like ASHRAE add-on working group of 2023 said that there is no harm that has been reported, even if there is not sufficient data to say that it enhances ovarian function, but it has no harm. So maybe with more utilization, we may be able to get something. So existing studies also suggest that there are no side effects and notable complications to this. PRP also acts as an antimicrobial agent, and that is why now the contraindication of using it in inflammation is been withdrawn because it is supposed to be an antimicrobial agent. Studies also affirm that PRP growth factors exhibit non-mutagenic characteristics. So the concern about its being cancerogenic or having stimulated these cells is also not there anymore. So largely these are basically telling us that it's a very safe procedure, but of course we require many more studies. However, the next exciting thing is stem cell therapy. And as you can see over here, stem cells can be derived from many sources. The bone marrow stem cells, which is very, very common. The umbilical cord stem cells also, which are being used. Adipose tissue derived stromal cells. The menstrual blood derived stem cells, and most commonly the ones which we are using are the bone marrow stem cells. Basically, this also uses the principle of secreting growth factors and transcription factors, basically, and therefore they are also stimulating the intracellular pathways for the growth of the cells, thereby promoting cell proliferation and angiogenesis. And also it decreases the apoptosis and inflammation. So on one hand, you are decreasing the apoptosis and inflammation, and on the other hand, you are increasing the proliferation and angiogenesis, thereby promoting new and healthier tissue. So here is one such procedure which you can see over here. The stem cells are being injected into the ovary, and then they've studied the estrogen levels, the FSH levels, the ovarian size, and the LH in these patients, and they found that the estrogen levels steadily increased by 6 months, and the FSH levels also start to decrease by the 6 months and keep on decreasing till 12 months. Similarly, the ovarian tissue size also increases after a considerable number of months, that is about 9 to 12 months, and the LH also shows an increase. So all in all, bone marrow stem cells are known to increase all these parameters and thereby function well as rejuvenating the ovary. This is a very nice study which is from Bangladesh, which also said they studied about 250 women and they found these parameters showing a difference in the third cycle. So that is why now most of us are trying to do at least three cycles of either PRP or bone marrow stem cells in order to see any effect in these patients. What about fertility preservation? Now, this is something that has come up really, really well. The awareness is increasing. We have fertility preservation in two kinds of patients, either the ones who are suffering from cancer, because cancer now has a very good survival rate, or in patients who are wanting to postpone either their pregnancies or they haven't found a partner, they are not married, and so they want to preserve their fertility. Also in cases of endometriosis, where we are actually bothered about the fertility of the person. So oocyte freezing is done if the patient is unmarried. Sperm freezing is done again if the person is unmarried, and mostly sperm freezing is requested in patients who are suffering from cancers. Embryo freezing is also done when the patient is married and wants to freeze her eggs. So all these things can be done at will whenever the person wants to come to us. Then a very exciting thing happened in 2015-16, where Anderson et al. Published their paper on the novel use of follicular pool to postpone menopause and delay osteoporosis, wherein they used these primordial cells which were actually taken out of the body, and ovarian tissue was cryopreserved. After that, once the ovarian tissue was thawed, they isolated the follicles and then did an auto-transplantation of those follicles to find that the ovarian function was resumed. Similar thing was later on done by other workers also. And in this paper of 2015, they actually talked about the advantages and disadvantages of transplantation of ovarian tissue. Of course, the advantages are many, because basically this tissue hormone therapy actually creates a more physiological steroid hormone profile, and hence gives a better effect as far as fertility and menopausal hormones are concerned. Oocytes from the ovarian tissue are preserved at a younger age, and therefore there is a very low risk of aneuploidy in these oocytes. And the transplanted tissue also allowed spontaneous pregnancy and does not require IVF all the time. However, this is all a surgical procedure, and definitely it is expensive and traumatic to the person. Removal and transplantation are both surgical procedures, and therefore they have their own risks. However, the other exciting thing was ovarian activation, wherein we realized that there are these molecules which are actually suppressing the ovary or activating the ovary, where primordial follicle activation is required. So suppression of FOXO3A and P27 plus activation of MTOT or C1 actually cause the follicles to grow in the way we wanted. And this is what has been utilized in order to do an activation of the ovarian tissue. So the procedure is to remove the ovary by laparoscopic surgery by using minimal cautery and hemostasis. And then once these ovarian cortices are removed, we look at them by removing the medulla from them, and then we only use the cortex and try and see whether there is any follicles growing in them. So histological analysis of these small bits of cortex are very, very important, and these are made ready for use. After that, there is two methods to do it. The conventional in vitro activation involves the stimulation of these by the molecules that I talked about in the earlier slide, or the activating molecule and the suppression. So those are actually put into this culture media. It is actually grown for 48 hours, and then a transplant is done in a second surgery. A second laparoscopy is done, and it is put into the ovarian fossa. So finally, then the follicles are grown by giving hormones, and then the oocyte is retrieved as we do in the normal patient, and ICSI is done. So this is a laborious process wherein two laparoscopies are involved, but it is said to give better results. However, in the drug-free in vitro activation, single laparoscopic removal of the ovarian tissue is done. The cortex is removed and it is fragmented into small bits, histologically seen whether follicles are present or not. And in the same sitting, it is actually grafted into the broad ligament, very close to the ovary, hoping that new vessels would grow in it. And finally, when the ovary starts to function, an ICSI is performed. The first paper on free IVA has been written by Dr. Nalini Mahajan in a patient of endometriosis. The patient started to get periods again, but unfortunately, there was no pregnancy in this patient. Earlier reports have been from 2001. Like I said, this was the first report of ovary, the woman's ovary, which was taken out from her body and transplanted later on into the arm of the woman, where follicles started to grow and a pregnancy was reported. Similarly, in 2015, like I showed you, there were many people who started reporting these things, the use of ovarian follicles, and they transplanted them and started making, getting ovarian function in them. So therefore, this is a very, very hopeful kind of a advance for all of us, because there are so many women who have already preserved their ovarian tissue for cancer reasons, but they have not used them, or they may have preserved it for social reasons also, but have not used it. They can later be used to prolong their menopause, or they can be used if fertility is desired at a later age. The last part of this is the creation of an artificial ovary. This is actually done in patients who are suffering from cancer, where the same steps are used as for activation. However, there is a lot of washing done over there to remove the malignant cells, and then the ovarian tissue is actually frozen. It is encapsulated in a matrix where it is supposed to be protected from being, it is protected from the cancer or the cancer lines. And then later on, when the patient is cancer-free, this is again transplanted. So this encapsulated follicles serve like an ovary, artificial ovary, and this is what is being promoted now in patients who are young and have suffering from breast cancer or any other cancer. So after remission, we wash them properly, enclose them in a matrix, and then put them back. So ovarian function preservation in young breast cancer patients has become a very important thing for us, because we need to give them that hope and basically take them forward as far as their fertility is concerned. So either it could be done by medical gonadoprotection, wherein you suspend the ovaries upwards, or you suppress the gonadotrophy, the formation of follicles, by giving them GnRH agonists, or you do an oocyte and embryo cryopreservation, or you do an ovarian tissue cryopreservation, or an artificial ovary formation. Hence, we have lots of methods now to activate or reactivate function within the ovary if the patient is going into premature ovarian insufficiency or failure. So over the years, we have realized that as the lifespan has increased, estrogen has many functions beyond the reproductive tract, and that is, it is also affecting our CVS, our CNS, bones, etc. And aging first takes place in the ovary and then in the reproductive system. So therefore, this is the system which is enabling us to study what is happening to the human body, especially of the females, and thereby helping them to preserve their ovarian function. So very exciting developments have taken place, but of course we have unanswered questions, because we do not know what is the effect of these methods on the breast and the uterus and development of cancer in these areas. We also do not know how many of us would want to have our periods forever, and how many of us would have, how long would this procedure have its effect on us? So all these questions are still unanswered, and we are really in that exciting phase of development where we are seeing these new things happening to us. So with this, I end my talk by this very poignant saying by this male gynecologist: you have to prepare the couples to the idea that they may not be able to have children. Our work is similar to the work of an oncologist. I've seen death in the ART context. It is the death of women, of the couple, of self-esteem, of self-image. It is a different type of death, but we are still similar. It is still similar. So basically, we all have to realize that this problem, it does not end with the couple itself, but it actually belongs to all of us. And as workers in reproductive health, it is our duty that we help all these people to conceive and to have a family in whatever way we can, whether it is by surrogacy, as Nana had said, whether it is by using donor eggs, as Dr. Bhaveshi had told us, or whether it is by using these new techniques that I'm talking to you about. But definitely, we all have to help all of them. I thank you very much for being here with me today. I hope I have not exceeded my time. Thank you so much.
And thank you, ma'am, for very elaborate session. We had a lot of insightful information on this. So with permission of co-chairperson, I will proceed to introduce our next speaker. If you can show the slide, please. Similarly, Dr. Sujata Kar also does not require any introduction to this august audience. Practicing gynecologist for more than 28 years, some very pioneer work in field of fertility and endoscopy. I am fortunate to work in the August organization of IAG with Dr. Sujata Kar, and I wish a lot of success in Madam's tenure as president of ISAR in coming near future. Ma'am, kindly guide us with your knowledge.
Thank you so much, Sujal. I'll just share my screen. So before I start, I must thank MC Patel sir for giving me this opportunity and also to give me a very nice topic, something which I have prepared lately. So it gives me great, satisfaction to talk about this topic, which is the huge impact of environment and stress on human fertility and health. So today I'll be talking about number one, how big the problem is, then lifestyle and fertility, a vicious cycle. Can stress really impact and reduce fertility? What are the endocrine disrupting chemicals and how they affect fertility, and our role as reproductive specialists? So first, how big is the problem? So it certainly is a huge problem if we understand that we are constantly bombarded with environmental contaminants. They are there in food, water, air, cosmetics, clothes. They are there everywhere. And we literally have nowhere to hide from the impact of endocrine disruptors and environmental contaminants. Other than the environment, and the endocrine disrupting chemicals in our environment, our lifestyle is further aggravating. And therefore, we are seeing an epidemic of gynecological conditions like PCOS, metabolic syndrome, and obesity. Obesity then again impacts all aspects of reproduction. And we now stand third in global ranking in the epidemic of obesity. It has a complex relationship. I'm not going to, go into the details, but the interaction between pituitary gland, pancreas, and ovary results in a changed hormonal secretion pattern. Basically, to put it very simplistically, increase in the number of fat cells leads to increase in leptin and insulin levels, and a differential increase in LH but not in FSH. Hyperinsulinemia, on the other hand, reduces SHBG levels and thus amplifies the ovarian androgen production, and that stimulates a partial development of follicles and arrests it. That secretes supranormal normal levels of testosterone, and that leads to arrest of ovulation and reduced fertility and also reduced progesterone levels. In a recent study, which everybody is aware of, there was a drastic statement made by this study that showed that there is a 50% decline in male fertility over last 40 years between 1973 to 2011. This was a sweeping study, and this massive decline in male fertility, it was suggested that could be because of improper lifestyle factors such as smoking, alcohol, high temperature, radiation, which can negatively impact other than the other environmental factors. So we know that cigarette toxins, let's look at the impact of some of the factors of lifestyle, for example, smoking. We know that active and passive smoking both hamper sexual health and reproductive health throughout the reproductive life of both men and women and compromises the ability to have children. Smoking more and for longer time increases the risk. So an ex-smoker is still having risks for reduced fertility and risks for other health hazards. Cigarette toxins disrupt in female, the likely mechanism is they can disrupt corpus luteum formation and implantation of the embryo. In the same breath, mobile phone use literature has suggested that mobile phone use can alter sperm parameters, particularly motility and morphology, and increase the oxidative stress. Moreover, these abnormalities seem to have a direct correlation with the duration of mobile phone use, and therefore the importance of screen time, which has come up in such a big way these days, and people have started understanding the importance. Carrying out a prospective randomized study to do these things are really, to prove these things are really difficult. but it is necessary before any technology or a new technology is so deeply implemented in our lives, or we adopt it so deeply and so widely. It is necessary that they need to be evaluated for at least 20 years before their safety can be established. Now, alcohol also, moderate drinking can also increase fertility problems and miscarriages in women, and increase sperm DNA fragmentation in men. And some surveys have shown that 30% of men and 19% of affected by fertility problems, they report that they are drinking alcohol. Now, even though smoking has dipped by 10% in India, in the last 2 years, the number of women smokers has gone up. This is actually very concerning, because overall worldwide, we know that smoking has gone down since the years that people have understood that smoking is extremely harmful for various kinds of cancers and otherwise also. Now we have started to understand its impact on reproduction and on its impact on the quality of gametes. However, it is very disheartening to note that in India, the number of female tobacco smokers is going up, and India now has the third highest number of female tobacco users in the world. We have an estimated of 12 million female consumers of tobacco, and it comes second only to USA. So over the years, this is a stat that shows that how over the years female smokers have increased in our country. And even more concerning is the fact that alcohol consumption amongst Indian women has increased. So this was a WHO report that said more women are drinking, and women are drinking more. A new survey on alcohol consumption pattern among the women in Delhi has revealed, and it has shown that over the last 1 decade or so, about a 38 to 40% increase in women who have started to drink alcohol. Another very important lifestyle factor is sleep habits. So is it possible that poor sleep habits can impact your fertility? So if you will actually think about it, we are living through the most chronically sleep-deprived generation in human history. The current millennials and the Gen Zs, they believe in staying awake the night. It's a normal habit for them. To stay awake late in the night, and the early morning people are going down by the day. And so does it impact? Yes, it can impact fertility, apart from many diseases that it can cause. I mean, I don't need to go into the details: hypertension, heart attack, weight gain, and obesity. One of the major contributors is bad sleep hygiene, depression and anxiety. All these in a vicious circle can impact fertility by various mechanisms. Now, stress. We know that infertility causes stress. There's no doubt about it. That's known. I mean, we understand that. But does stress cause reduced fertility? That is a question that needs to be answered, with a more robust evidence. However, it has been shown that elevated levels of cortisol, which is also known as the stress hormone, leads to a 2.7 times greater chance of miscarriage within the first 3 weeks after conception in comparison with women with low cortisol levels. So cortisol production in the body rises as a response to psychological, immunological, and other stresses, suggesting that it serves as a marker signaling the female body that it's not in the best state for reproduction. So yes, it is possible that it is certainly possible that anxiety, depression, stress can lead to reduced pregnancy rates, or even reduced fertility amongst both men and women. How it can reduce fertility is some mechanisms. You can it can make one sleep more or sleep too little, get into emotional eating, binge eating, which again is very common, and not allow enough time to eat properly or eat the right food, not find enough time to exercise, drink one or too many alcoholic drinks, smoking. If you're not a smoker, start smoking again. Drink too much coffee, especially if you are sleep deprived, and lose interest in having sex or being intimate with your partners. So that was one part of my talk, which said about lifestyle, how lifestyle factors can affect human fertility. The next comes to endocrine disrupting chemicals and fertility. So what are endocrine disrupting chemicals? EDCs, as they are known, are hormonally active, synthetic or natural compounds that can interfere with the normal activity of the endocrine system or tissue, most notably the reproductive endocrine axis. So it can basically affect the entire axis, starting from pituitary, hypothalamus, pineal, parathyroid, adrenal, testes in female, ovaries, pancreas, thyroid, etc. And where do you find them? You literally find them everywhere. They are ingredients in most household products and materials, in various solvents, in industrial ingredients, in pharmaceuticals, in metals or heavy metals that are used in household things, in pesticides. Now, primary sources are natural and man-made substances, like I mentioned, in various chemicals used in agriculture, industrial waste, phytochemicals, pharmaceuticals, consumer products. The route in which we may be exposed to EDCs are transdermal, inhalational, ingestion, even transplacental. Metabolic targets of these EDCs, usually they can affect all the glands of our body, the endocrine glands. However, the target tissues are adipose tissues, pancreas, skeletal, brain, and liver. Physiological effects, pathophysiological effects, obesity, insulin resistance, diabetes, dyslipidemia, hypertension, etc. And what are the commonest chemicals? There's a huge list. To name some of the most common ones are polychlorinated biphenyls, perfluoroalkyline substances, polybrominated diphenyl ethers, bisphenol A, pesticides, and heavy metals. Magnitude of the problem is unmeasurable. In fact, as of 2016, more than 65,000 chemical substances are listed by the US environmental protection agencies. Approximately 3,000 of these chemicals have annual production and importation above 1 million pounds. Approximately 250 chemicals are on biomonitoring data for years for the risk of causing cancers and other problems. Now, another important aspect that we need to understand that how big the problems of environmental contaminants and EDCs are, that they rise up the food chain. For example, if the DDT concentration in water or in the water that we consume, or even in the sea water or salt water or otherwise, DDT is, let's say, to the tune of 0.000003 parts per million, which would basically mean it's negligible. But when you look at the planktons and phytoplanktons in the sea, the DDT concentration becomes 0.04 parts per million. If you look at the small fish which eats these planktons, the concentration becomes 0.5 parts per million. The larger fish have 2 parts per million, and the fish-eating birds have 25 parts per million. And so, therefore, the humans that are eating this fish, the DDT concentration is going to be very, very high. So this is what it means, that the concentration of the contaminants, pesticides, it rises up in the food chain as you go up higher and higher in the food chain. The next bigger problem is that the next generation is already born pre-polluted. So we are likely to affect the next generation as well, because chemical exposure during pregnancy can cross the placenta and can accumulate in the fetus. Shockingly, a recent study identified free BPA present in 62% of breast milk samples in the United States. And so the worst part is the next generation is going to be born already polluted. And it can have transgenerational and delayed effects, just like diethyl stilbestrol tragedy, where we know that the daughters of pregnant women who took diethyl stilbestrol were found to have higher risk of infertility, poor pregnancy outcomes, breast cancer, whereas sons of these women had more chances of hypostasia. So overall data shows the potential roles of EDCs on male and female. fertility. And so, like I mentioned, you can ingest it, inhale it by dermal contact, and the window of susceptibility is huge. Like anything can be impacted. Blastocyst, the fetus, the embryo may be impacted, the infant, adolescent, childhood, postnatal, prenatal, periconceptional, and maternal and paternal exposures. So one can get, there's a huge window where one is susceptible to get affected by these contaminants. The mechanism of action can be either direct or indirect. So endocrine disrupting agent can directly act by attaching to the receptor of a hormone and then behave like that particular hormone. So in direct hormonal disruption, chemically similar molecule, it enters the organ, causes alteration in cellular function, cell division, etc., etc. DNA repair, mitochondrial function may be affected. It can alter the abnormal, result in abnormal tissue growth and tissue function that can result in various kind of cancers, can lead to tissue necrosis. Indirect impact requires a metabolic conversion into an active form, which then interferes with the endogenous hormone function in very high concentration. Altered receptor affinity, altered serum binding protein hormone synthesis, metabolism, etc. The effect of EDCs, so the way it can affect is it can mimic hormones, it can block hormonal action, or it can trigger an inappropriate hormonal activity. And the impact may be immediate or delayed or late or transgenerational. The final impact may ultimately be in females, obesity, endometriosis, PCOS, infertility, poor pregnancy outcome, diabetes, cancers. In men, reduced fertility and cancers. In fetus or in next generation, it can result in IUGR, epigenetic changes, mutations leading to many diseases, cancers, fertility, etc. in the next generation. So rising female subfertility, BPA is the commonest EDC. BPA significantly is associated with testosterone and androstenedione, two androgen hormones that are elevated in PCOS. BPA levels are associated with significantly lower antral follicle count, and there is rising concern that BPAs can actually accelerate follicular loss and accelerate reproductive aging, and also can directly increase androgen production from the theca cell. There are now many reports and publications that tell us that environmental contaminants, typically BPA, bisphenol A, bisphenol B, is probably related to the rising cases of endometriosis across the globe. And in this study, which is a very recent study on environmental factors and declining human fertility, it was hypothesized that reproductive health problems are largely and to a large extent related to exposure to chemicals that originate directly or indirectly from fossil fuels. So which means the smoke, the coal that is being burned, the petroleum fuel, etc., etc. Also, those smoke can also have a lot of harmful chemicals. And another study which said air pollution and its role in infertility, and that showed that quality of gametes, embryo development potential, miscarriage rate, hormonal disturbances, oxidative stress, DNA and epigenetic alteration are various methods by which air pollution can negatively impact both female and male gametogenesis. This was one publication in a very good journal, Frontiers in Cell and Developmental Biology, which myself and my group have published recently. Human sperm proteome reveals the effect of environmental bone seminal polyaromatic hydrocarbons, exosomes, in the etiology of idiopathic male factor fertility. We showed that polyaromatic hydrocarbons that can affect could be a factor in idiopathic male factor infertility, and therefore it was postulated that along with seminograms and other biological markers, an analysis of the seminal levels of environmental toxins, such as polyaromatic hydrocarbons in general and benzopyrene in particular, may help in proper management of idiopathic male infertility. We are all aware that we are actually in search of real markers of male fertility, which really is not there yet. And finding these different tests also may be one of the ways to improve our diagnosis of male factor infertility. So these are various chemicals and how they are used, where they're used, and how they may impact fertility and reproduction. I'm not going to go into the details, just to show you that they are there everywhere. Non-stick food cookware is now understood to be one of the major, factors. And then we have flame retardants in furnitures, electronics, plastics, packaging, cosmetics, multiple various methods by which you may be exposed to health hazard. Then also, I want to draw your attention to some typical occupational hazards that have additional risk of exposure to toxic chemicals for them. For example, women who are employed as cosmetologists and manicurists are exposed to high levels of volatile solvents, formaldehyde, methacrylates, acetone, toluene, plasticizers, etc., and other toxic substances. Pregnant women who work as cashiers had the highest urinary BPA concentration. So cashiers have that, in which they print out their bills, that has a lot of chemical contaminations, which is likely to contain BPA. Women in the nail and hair care industry were at highest risk of adverse birth outcome. Farm workers and their families are also at higher risk of exposure to pesticides and potential adverse effect over reproduction and developmental abnormalities. Heavy metals like mercury, lead, etc., can cause abnormal exposure. So to come towards the last part of my presentation, what is our role as clinician? Why we are supposed, what can we do? How we can do our bit to minimize this effect? We are mostly because we are uniquely geared to intervene to prevent harm before and during pregnancy, which is a critical window of human development. Women will come to us before they plan pregnancy. Women will come to us when they are planning pregnancy or when they are in their early pregnancy. So create awareness amongst peers, colleagues, and patients is one of the most important things that we can do. So to be able to do that, we must be well equipped with knowledge about the toxic environmental agents that are endemic and to their specific geographical areas. Intervene as early as possible before conception and during pregnancy, taking an exposure history, especially occupational exposures when we are dealing with our patients, providing anticipatory guidance on how to make healthier choices and avoid toxic exposures at home, in the community, and at work, and reporting identified hazards. For the governments and policymakers, communication across scientific disciplines and among scientists, healthcare providers, health-affected groups, and the public, as well as efforts in research, education, and policy, are key to reducing the adverse impact of environmental contaminants. The governments are waking up, there is no doubt. They have started informing people about the harmful effects of the environmental contaminants that they're eating and exposing themselves to every day. They're making people aware about to read what you're eating, etc. But much more effect is required, and we need legislation also, intervention also at the food, packaging area and even food delivery systems. So for the patients and for the public, they need to understand a couple of things. Try to reduce any chemicals from households, be aware of and be a critical consumer, use less fossil fuel, eat fresh, green, organic, and local, use glass, steel, ceramic, aluminum, get rid of toxins from body, sweat it out, exercise, go minimalistic on cosmetics. I think that is one big message to the women consumers out there. So thank you very much for your kind hearing. This was a fabulous, saying that I found, which said that if you really think the environment is less important than the economy, because it's all about the economy, people like KFCs, McDonald's, Cokes, they are the big MNCs, they're all about economics. If we think that economy is more important than the environment, try holding your breath while you count your money. So I found this a very interesting saying. Thank you very much. Thank you very much.
Thank you, ma'am, for a very insightful discussion. With this, we end our session here, and I would ask organizers to proceed. Thank you, and thank you, MC Patel, sir, for this opportunity. Thank you.
Thank you very much,
so
Dr.
much.
Mytri. Thank you, Dr. Sujata Kar and Dr. Sonia Malik for enhancing our knowledge on this fading fertility. It was so amazing. So now from female infertility, now let us go to our next topic, that is male reproductive puzzle. And I would invite Dr. Monica Pathak and Dr. Rachna Jaju, the coordinator for the next session, to proceed with the session. And I would request all speakers that let us strictly stick our timing to 20 minutes, as we are already running late by minimum 1 hour plus, and we have so many topics to discuss. So please take care for 20 minutes. Thank you very much. Over to chairperson and coordinators of next session. Do we have Dr. Monica Pathak and Dr. Rachna Jaju?
Ma'am, I'm there.
Yeah,
Dr.
please proceed with the session number 5.
Yeah, we proceed with the session number 5, the male reproductive puzzle. And for that, we have chairpersons for today, Dr. Kalyan Barmade sir and Dr. Sanjay Gandhi sir. Can we have their CV? Dr. Kalyan Barmade, he needs no introduction. He's the chairperson of Public Awareness Committee, FOXY, Executive Council Member, IAG, Executive Council Member, ISAR, Executive Council Member, AMOX, and convener for Save the Uterus Mission, FOXY, 2019 and 2020. He was past president of Latur OBGYN Society. We welcome you, sir. Can we have CV of Dr. Sanjay Gandhi? Sir has huge experience in infertility practice. He is member of ISAR, IAGE, and he is an IVF specialist, laparoscopic surgeon, and he has done total 600 IVF cases. So we welcome you, Dr. Sanjay sir. Can we have the CV of next speaker? I would request the chairpersons to introduce our speaker.
Rachna ma'am, maybe you can introduce the speaker, ma'am.
Okay, sure. Can I have the CV of Dr. Nagori sir then? He's director at Dr. Chaitanya Nagori sir. He's director at Dr. Nagori's Institute for Infertility and IVF. He's co-director, Ian Donald Inter-University School of Medical Ultrasound, Ahmedabad branch, India. He's pioneer in ART exclusively since last 27 years. He has achieved first pregnancy after endometrial regeneration by stem cells in a patient with Asherman syndrome. He received Best Award at 18th World Congress of Ultrasound on OBGYN Chicago in 2008. He has authorized several books and many chapters. More than 10,000 pregnancies in long-term infertility has been achieved by sir, and he has received Gujarat Gynec Excellence Award in Yuva ISAR. Over to you, Dr. Chaitanya sir.
Hello.
Yes, sir, you're audible, sir.
Yes, sir.
Thank you very much for the kind information. Now I'll be discussing the current normative parameters of semen analysis and the male genital tract ultrasound. So, all of us know that more than about 40 to 50% of the infertility is only or partly due to the male factor. And semen analysis is still the gold standard for evaluation of the male infertility. This is the only branch of medicine where the investigation is first and history taking is afterwards. Here, if you do the semen analysis and if the patient has no complaint, there is no need to further evaluate the patient. While in all other branches, we take the history first and then we go for the investigation. Normal reference values for 1999, the count was 20 million, 50% motility and 14% morphology. Then in 2010, it came to 20 million, went to 15 million count, 50% motility now reached to 32% and 15% morphology. Then it was in 2010 considered as 4%. And now from 2010, that was the fifth edition, and then the 2021, the sixth edition. There are no much changes. Much changes are on the motility only that we'll discuss, but otherwise, more or less, the count, morphology, they are more or less the same. There is no much change in it. Now, extended examination. In this sixth edition, there are extended examination of the semen has been discussed, and it has been said that the use of multiparametric scoring for the semen morphological defect, sperm DNA fragmentation has been discussed a lot in sixth edition, and the role of computerized assisted analysis of the semen has been discussed. But all these three things are debatable at present. Processing of the human semen, this criteria may be useful for the diagnosis or the research purpose, and extended examination may be useful in improving the characteristics of the fertile and infertile man. Now, multiparametric sperm assessment to improve the efficacy and consistency of the basic analysis of the sperm morphology is to complete a multiparametric assessment of morphology. But here the most important part is that the basic analysis should be performed correctly. Otherwise, all your indices will be wrong. And that's why do a basic analysis perfectly, go for the indices, and then you can evaluate the fertility of the patient. Now, in DNA fragmentation, it may indicate the paternal DNA anomaly transmitted to the progeny. It increases the miscarriage rate, decreases pregnancy and live birth rate in IVF, but still it is controversial because of lack of standardization and poor sensitivity and specificity and lack of evidence for effective intervention to prognosis. For cutoff also, the variables are too large, and that's why at present you cannot say that the DNA fragmentation should be included in the examination, in the routine examination. Now, FSH treatment can reduce the sperm degradation, DNA fragmentation after 3 months of the treatment. A lot of antioxidants are used, but still there is no clear-cut conclusion whether it can improve the DNA fragmentation. Varicocele ligation decreases the SDF and increases the chances of pregnancy. People advocate always the testicular sperm, particularly when DNA fragmentation is high, but it is not evaluated through against the short abstinence and the lifestyle changes, and that have not been evaluated for the testicular sperm. So even at present, the DNA fragmentation test has got a doubtful role, and second, the testicular sperm itself has got a doubtful role at present. Rather than it is better to try the FSH and the varicocele ligation if it is present. Sperm selection may help, but more evidence is required. Use of media for sperm preparation, magnetic activated cell resorting, and IMSI, but they have also not been proved to be perfect as far as the sperm selection is concerned. And microfluidic is similar to the swim-up technique what we routinely use. And that's why all these extended things have got a doubtful role in the routine examination. According to ASRM, AFSN, and American Urological Association, sperm degradation product, particularly sperm degradation is found in failed IUI, IVF, ICSI, RPL, advanced paternal age, diabetes, and lower genital tract. You should investigate for it. It's a male age dependent. So higher the age of the male, then chances of STF is very common. Female age is the key factor as the oocyte can correctly repair it. So, younger the female, even if the age of the patient is higher, the male patient is higher, the female age can, oocyte can correct the repair. Otherwise, it may cause the deleterious mutations load, and that is the hypothesis that has been put forward, that it may cause the deleterious mutation load. That's why younger age will be much useful for getting a pregnancy. Now, regarding CASA, evidence is insufficient for its routine use and also its efficacy against the expert manual analysis. It is unable to obtain the sperm count and motility up to the level of the trained staff. This is a very important statement because you are spending lakhs of rupees for the CASA and still it has not been proved that it is better than the trained staff. It cannot differentiate between the agglutinated and aggregated sperms. It can be added, but it cannot replace, and that's why it will be a luxury to have the CASA rather than it can replace the trained staff. It is useful for the motility analysis, particularly the hyperactivated sperm. So the CASA will be useful to differentiate between the rapidly actively motile sperm and the sluggishly motile sperm. Penetration and migration through the cervical mucus will be possible with the hyperactivated motility. And to detach from the endosalpingeal epithelium, it can replace the calcium imaging and molecular biology. Then CASMA, computerized assisted morphological assessment, has not proved to be better than manual assessment. So even for knowing the morphology, CASA is not much useful. Flagellar movement may be more useful, particularly CASA motile. That may be useful. So particularly CASA will be very useful to you to decide about the motility disorders. Rapid progressive motility can be differentiated from the slow progressive motility. Now it is considered to be better to report the total sperm per ejaculate rather than the sperm concentration per ml, because we all are in the habit of telling what is the sperm count is in terms of per ml. But this is the reflection of an average testicular sperm production and what is available at the site of fertilization. And that is why the total sperm per ejaculate should always be given the preference rather than per ml. Now, in role of ultrasound, it can have a scrotal, transrectal, and the penile ultrasound, a systemic and logical evaluation of the infertile male by ultrasound helps to distinguish between the correctable and non-correctable anomalies. Scrotal ultrasound, normal finding testis, they are homogeneous echogenic ovoid, mediastinum testis, it is found in the center, bilateral symmetry, normal volume is between 12 to 15 ml, and size decreases as the age advances of the patient. In a epididymis homogeneous, mildly hyperechoic to the testis, coma-separate. On lateral aspect of the testis, it is found it is 10 to 12 millimeter in diameter and has the head, body, and the tail that is present. Now, in testicular anomalies, you get either atrophic cryptorchidism, neoplasm, orchitis, microlithiasis, testicular infarct, and testicular trauma can be diagnosed with the simple ultrasound. And atrophy can be because of inflammation, ischemia, trauma, torsion, cirrhosis, estrogen therapy, or many a times nowadays the body building programs that youngsters are taking anabolic steroids, and that causes the atrophy of the testes. Hypopituitary disorders and aging, that is common. Now, these are all the secondary causes that occur afterwards, but these are the primary causes of testicular atrophy, that is Klinefelter syndrome, Y microchromosome deletion, and cryptorchidism. Now, if you look at the ultrasound, the atrophic testis will be small and hypoechoic. Localized area of the altered echogenicity will be found. Fairly decreased flow on the color Doppler, and epididymis will be normal. In an acute orchitis, this is a picture of acute orchitis where you can show the hypoechogenicity and hypervascularity. So in between you can get the hypoechoic areas and vascularity will be increased in acute orchitis. And epididymal cyst, this is a very common finding that you get, and particularly when it is presses the epididymis, sometimes the count is very low when epididymal cysts are present. The most common finding that we get is the varicocele. It is a pathological dilatation of the vein of the pampiniform plexus in spermatic cord and leads to the reversal of the blood flow in internal spermatic and the cremasteric vein. In 40% of the men with infertility is present, but in 70% of the men with secondary infertility. So, one of the commonest cause of secondary infertility is the varicocele. In 13 to 15% with the normal fertility, it may be present. 50% of the men with the varicocele benefit after the surgery. So, the dictum is that if the semen analysis is abnormal and the varicocele is of the grade 2 or grade 3, it should be operated. But if the semen analysis is normal, then don't jump for surgery. A patient may conceive either spontaneously or with the help of the IUI or ART. More common in the left side, that is 85% can be bilateral, and only right side is not common at all. It is mostly secondary, either because of the enlarged liver, hydronephrosis, abdominal tumors, or even after the age of 40 years. So only right side should be investigated for the other causes rather than there are some other causes in the abdomen. Cluster of dilated veins, a single vein of more than 3 millimeter diagnoses the varicocele. Most commonly, it is adjacent to the or the proximal to the upper pole of the testis and head of the epididymis, and when large may extend posterior and lateral to the testis. Examine at rest, and then after increasing the intra-abdominal pressure, that is the Valsalva, can be done on the patient. Here you can see that the grade 1, grade 2, grade 3, grade 4 and grade 5, and out of this grade 2 particularly supratesticular vessels more than 3 millimeter is found, grade 2, and grade 3 is more than 3 millimeter, and particularly peritesticular vessels dilatation with further dilatation on Valsalva and testicular hypertrophy. So these are common. Grade 2 and grade 3 will be very important. Here you can see grade 1 vein dilated up to 2.5 and a fill up with the only Valsalva. You can see the grade 2, that is vein of 3 millimeter or more at rest, and dilate further and fill up to the lower testes on the Valsalva, and grade 3 dilated veins show flow at the rest and fill up further up to the mid testes or the Valsalva. So you can differentiate when you can find this grade 2 and grade 3, these are the patients who will be benefited by surgery. Now the last is transrectal ultrasound, that is you can do prostate, seminal vesicle, vas deferens and ejaculatory ducts. Transrectal ultrasound is very useful in azoospermic patient, and particularly when the semen volume is low. Semen volume more than 1 ml, but when the vas is absent, then also you can go for transrectal. Enlarged epididymis with multiple cystic space, abnormal digital rectal examination, and to differentiate surgically correctable lesions from the rest, we do transrectal examination. This is the diagrammatic figure that when you do a transrectal examination, how it looks. Here you can see that the seminal vesicle is long, and the prostate that you can see in the first picture. Second picture, here you can see the prostate. Third, here you can see the long seminal vesicles are formed. Here you can see the ejaculatory ducts can be very easily seen, and you can see the vas deferens also. So with the help of an ultrasound, you can see all the things very clearly. Now, the last thing remains is the penile erectile dysfunction assessment. Intrapenile injection, that is piperine or phentolamine, can be given. And this is a simple, quick and inexpensive method of distinguishing between psychological and vasculogenic cause of importance. And second is the history. You just ask the patient whether the night erections are present or not. Then you can differentiate between the psychogenic and the vasculogenic causes of the importance. In an ultrasound, 2 corpora cavernosa and 1 corpora spongiosa is seen, and particularly central cavernosal artery in the cavernosa with the echogenic wall is also seen. Assessment of the cavernosal artery diameter is also important. Plex, fibrosis, calcification, hematoma, and the tumor can be diagnosed with this ultrasound. Now here the Doppler, particularly when there is an erectile problem or the erectile and ejaculatory problem, then the cavernosal artery Doppler will be very useful. Here there are different things. One, it is when it is flaccid, high resistance, monophasic flow is seen. Latent, that is the largest diameter, increased systolic and diastolic flow, rounded systolic PIP. Tumescence, increased flow in the sinusoid, increased pressure, decreased diastolic flow. So particularly when the erection occurs, then the diastolic flow decreases, and late tumescent, it is almost the diastolic flow is absent, and you can see a sharp systolic flow can be seen with an increased velocity can be found. This is the full erection where the absent diastolic flow with the narrowed systolic waveform and the maximum systolic velocity. Rigid erection, narrowest cavernosal diameter, narrow and decreased systolic peak. So, and then comes the detumescence. Pharmacological erection can be gained by the papaverine or the various drugs which are available, and you can try the pharmacological, and it can be useful for the therapy also. Tourniquet, if applied, may be removed in the 2 minutes after the injection. Examination is done every 5 minutes till 30 minutes. Risk of priapism, that is, it may last for more than 4 hours. Erection may last than 4 hours. And here you can aspirate of 20 ml of the blood and 20 microgram of phentolamine hydrochloride can be given diluted in the normal saline. Cavernosal artery diameter less than 75%, that is dilatation is abnormal. PSV in cavernosal artery is 35 centimeter per second is normal. Difference more than 10 centimeter per second is abnormal. Then EDV in cavernosal arteries should be seen. Blood flow in cavernosal artery velocity multiplied by cross-sectional area indicates the compliance. These are not much important, but at least you can do a therapeutic test and the test on these also. Penile blood flow index, blood flow acceleration, and systolic rise time. This will be important for judging whether there is a defect in the erections or not. And that can be found out with these Doppler parameters. Now, this venous insufficiency, this is very important because ability to generate but unable to maintain the erection. Normal arterial PSV with the weak erection, difficult to diagnose the venous insufficiency in the patient with arterial insufficiency. Persistent diastolic flow of 5 centimeters per second in the cavernous arteries. Persistent dorsal vein flow beyond early transition phase, 100% sensitivity in 84%. So whenever there is a venous insufficiency, I think this can be operated very well and the patient can be all right. But it is always difficult to diagnose, particularly when arterial insufficiency is there. Angiography, if vascular surgery is planned, that is, the cavernography can be done and penile arteriography can be done, and you can know the diameter of the vessels as well as you can know in traumatic cases for revascularization surgery to visualize the pudendal and the penile artery. So angiography can be done of the vessels and it can be useful for the surgery also. So semen analysis is the primary test. DNA fragmentation test is controversial. CASA cannot replace the manual examination by the expert. Scrotal Doppler is important for the diagnosis of varicocele. Transrectal examination is useful to identify surgically correctable azoospermia, and penile Doppler is useful for erectile dysfunction. Thank you very much.
Thank you very much, sir. It was indeed a wonderful lecture. All the insights given were very precise and crisp. Thank you so much.
So now we have Dr. Shivani Sachdev, a good friend of mine. She will be enlightening us with her talk. May I request Rachna to introduce Dr. Shivani?
Dr. Shivani Sachdev, madam. She is MD DNB MRCOG, director at SCI IVF Hospital, ex-clinical research fellow, Imperial College, NHS Trust, featured in Limca Book of Records. She's founder secretary of Delhi chapter of ISAR, General Secretary, INSTAR, General Secretary, Delhi State Chapter of ISPAT, ex-Vice President, Delhi Gynec Forum, Vice Chairperson of Women's Doctor Wing, IMA South Delhi, number of publications more than 10. She has received special awards and recognition. Rashtra Gaurav Samman in 2015, Rashtra Ratan Samman from Minister of Women and Child Welfare, Government of New Delhi. It is with great honor I introduced Dr. Shivani Gaur ma'am, and ma'am, please go ahead with your talk.
Yeah, Rachna, thank you very much for that very warm introduction. And at the outset, I want to give a big thank you to Dr. MC Patel, sir. His web series, Happy Learning, is a huge brand name by itself in the country. So I want to give him huge congratulations for that and best wishes for his elections, which are upcoming. So my topic today is all about diet and male infertility. Right. So at the outset, there is this saying, Sun Tzu, the art of war, that victorious warriors win first and then go to war, whereas defeated warriors go to war first and then seek to win. And this has a very, very deeper meaning, which is very applicable to our talk today, that if you correct your diet and lifestyle, you have literally taken steps to win the war first before even entering into it. So as per our ISAR, infertility is affecting 10 to 14% of population, and stress, obesity, and diet, our lifestyle factors, are the prime factors for higher percentages of infertility, which is happening now. It affects men and women almost equally. We all know that diet can seriously affect pregnancy. This is because eggs and sperm both need certain nutrients for their proper growth, which can be fulfilled with the right food. Fetus requires nutritional supplements to grow without birth defects. Not only that, due to a lot of hormonal imbalances and environmental factors, we can correct all of this with the right diet. Idiopathic male infertility is diagnosed when we have altered semen characteristics without any identifiable cause and absence of female factor. So what is the influence on diet, on fertility, and what are these implications for public health? So this was published in the journal Frontiers in Public Health, and what it saw was that if there is a high intake of sugar, saturated fats, and other lifestyle factors like BMI less than 20 or more than 30 with physical inactivity, it causes poor fertility outcomes, more time to conception, less spontaneous ovulation, reduced semen quality, morphology, motility, concentration, and less success rates, less live birth rates. Now, in infertility, dietary intervention has a role in several factors, both female and male factor. So if we look at a systematic review and meta-analysis, which looked at the impact of preconception lifestyle on fertility, obstetric, fetal, anthropometric, and metabolic outcomes in men and women, what was found was that the only significant outcome is increase in the natural pregnancy rate if we target population which are primarily overweight or obese, both men and women. So with reduction of weight, we can increase the natural pregnancy rate. They did not find any difference between clinical pregnancy, complication, live birth, preterm, neonatal mortality, or anxiety. Pre-pregnancy role of fast food. This was a paper published in Human Reproduction. And what this said was lower intakes of fruit and higher intakes of fast food are both associated with increase in time to pregnancy and infertility. And the absolute difference is 0.6 to 0.9 months in time to conceive and 4 to 8% for infertility. In fact, they did a very deep dive into fast food consumption and the time to pregnancy. So if there is no fast food consumption, the decrease, what they found was that
the risk of time to pregnancy and infertility reduced by almost 20 to 40%. Similarly, fruit consumption frequency. If fruits are consumed less than 1 to 3 times per month, you have almost a 30% higher chance of being infertile when you compare it to fruits being consumed 1 to 3 times per day. So the goal of our dietary advice is to optimize fertility, weight, and ultimately the partner's obstetric and fetal outcomes. There are a lot of evidence which supports that preconception diet, both for men and women, can have an effect on the fetus as well, because there are multiple lines of evidence which support the concept that complications of pregnancy emerge from disorders which have origin in early pregnancy at the time of implantation and placentation. So the period around the conception is the critical one to mediate the parental influence on the next generation's health. From the maturation of gametes, early embryonic development, parental lifestyle can adversely influence the long-term risk of cardiovascular, metabolic, immunological, and neurological morbidities. So in paternal obesity and undernutrition, we have reduced sperm motility, increased DNA damage, altered sperm epigenome and RNA profile, seminal plasma composition, reduced embryo potential, epigenetic reprogramming, endocrine misregulation, and postnatal cardiometabolic risks. So the question comes, the patient will come and ask, is there a fertility diet? What should I do about my diet? So this concept of fertility diet was first suggested from the Nurses' Health Study, which began in 1976, and it grew to include 238,000 female nurses. And this showed that dietary modification in women can increase ovulation and improve the chance of getting pregnant. For both men and women, this fertility diet was proposed by NHS. High intake of folic acid. So this is both in men and women. Low intake of trans fat, greater intake monounsaturated fat. Now what they emphasized was lower intake of animal protein. So they were very focused on more of a vegetarian diet, being more related to good fertility. High intake of high fiber, low glycemic carbohydrates, and greater preference for high fat dairy and non-heme iron. So mostly what is found in plant food. And this was a paper which was published to show the impact of lifestyle modification, diet, and vitamin supplementation on natural fertility. So on the left-hand side, you have all the parameters, and on the right-hand side, you have the odds ratio and relative risk. So the highest impact factors are the BMI. The weight is the highest impact factor. The second highest impact factor is consumption of alcohol, where high alcohol consumption has a negative effect. The third factor is more than 5 cups of coffee per day. More than 500 milligram of coffee is associated with reduced fertility. And red meat. So high consumption of red meat is also associated with relative risk of infertility. So the new fertility diet, what was proposed, is more of a Mediterranean diet, where 225 men recruited in cross-sectional study with the dietary questionnaire. So men who had the lowest tertile med dietary score had 2.86 times higher likelihood of having an abnormal sperm concentration, count, and motility. So what is this Mediterranean diet? There is another study in fertility sterility where they looked at embryo cleavage and kinetics. Also, this was better when you have more of a Mediterranean diet with olive oil based and omega-3 fatty acid based diet. Mediterranean diet consists of low GI food, high protein so that you reduce hyperinsulinemia and decrease the testosterone levels, healthy fats, and vegetables and fruits, iron, micronutrients, folates, and antioxidants. So this is a classic Mediterranean diet where low GI, we will mean jawar, chana, ragi, amarnath, millets, bajra. This kind of atta should be used, avocados, flax seeds, olive oil are excellent. Beans, lentil, potato, whole grain, brown rice, quinoa, oats, many kinds of fruits and vegetables, and whole grain or brown pasta. In fact, if you compare the dietary fats, it is the flax seeds which have the highest omega-3 content, followed by canola oil and soybean oil. Even flaxseed and safflower oil, sunflower oil, corn oil are supposed to be still acceptable and healthy. So this is the diet pyramid where it is emphasized that you should have a meal of variety of colors. That means it's like a rainbow colored diet where you should have at least 1 to 2 fruits per day, at least 2 vegetable serving per day, and at least 2 servings of whole meal, either wheat or dough or some millets. Every day you should take milk and dairy, only 3 to 4 servings of oil, some nuts, seeds, herbs, spices. Poultry should be in lower, and red meat and processed meat, fish, chips, bread, pasta, white rice are absolutely to be avoided or taken only once in a week. And always choose organic foods, because many products have hormone pesticides linked to hormonal imbalances, and organic food really means that food which is grown without any synthetic fertilizers, sewage. You may all know sometimes sewage gets mixed in the sludge where the vegetables are grown. So it should be free from sewage, free from pesticide, genetic modification, ionizing radiation. And the farm animals are raised without growth hormones, without antibiotics, and without a non-organic feed. And these are the natural sources of antioxidants that we find in our food, where spinach and green vegetables are the best sources of beta-carotene. Vitamin E, best source would be olives and nuts. Selenium, Brazil nuts. Vitamin C, the most important, where we know lemon, lime, kiwi fruits. Flavonoids like blackberries, onion, tofu. And omega-3 fatty acids like salmon and other fishes. Of course, carrots, garlic, tomatoes, peppers, all of these we know are excellent sources of natural antioxidants. So these are the micronutrients which are extremely important in the periconception period, which include zinc, copper, iron, antioxidants, vitamin A, vitamin B12, B6, and folate. So a supplement which has all of these is going to be really one of the best options to give our patients who are planning to conceive. And if we talk about natural sources, what I do is I just take a printout of this picture and I give it to patients. And you know, when you see this picture in front of your eyes, and I tell them keep it in your file, take a look at it frequently. So when they see this repeatedly, unconsciously somewhere in the mind, they start making these healthy choices. And many patients I have seen that when they come for, after a month or after 15 days, they have already lost 1 or 2 kilos of weight. So it is up to us to give them that little push and motivation and give a beautiful chart so that they are motivated to lose weight and be healthy. And you know that this is going to have a direct impact on the success rate. Dietary patterns, food and nutrients in male infertility. Here we have a systematic review where they looked at nutritional modifications. So main thing that was focused was reduce the intake of caffeine, consumption of red meat and processed meat should be reduced, and we should have higher intake of vegetables and dietary fiber. So these were all the modifications which were suggested to these patients. DNA damage of the sperm by oxidative stress. Now we all know, as Dr. Sujata has also pointed out, we have smoking, PCBs, organophosphorus, lead, bisphenol A, testicular heat. So a patient should avoid cycling with tight pants, sauna, avoid using laptop on the closed legs, and don't store mobile phone in the trouser pockets. Weight loss through a diet and exercise. All organophosphorus, like avoiding pesticide exposure, especially for the rural area population, that markedly increases the sperm quality, it reduces the DNA fragmentation index, and of course the most strong is smoking. So any reduction in smoking is going to improve the DNA fragmentation index. And these are the main antioxidants which have a role in sperm function, which is lycopene, carotenoids, omega-3 fatty acids, L-carnitine, and zinc, and vitamin C, vitamin E, and selenium. Especially vitamin C and vitamin E are the cheapest and the best antioxidants which are available to boost the sperm quality. In fact, vitamin C, the concentration in seminal plasma is 10 times higher than in the blood. So this should tell you about its high antioxidant potency. And vitamin E, fat soluble, lipid peroxidation, selenium, normal testicular development, spermatogenesis, and deficiency leads to atrophy of the seminiferous tubule, defective motility, and morphology. So these are the natural supplements that we should advise our patient, that is papaya, bell pepper, strawberry, broccoli, pineapple, kiwi, oranges, kale, cauliflower, and with vitamin E we have spinach, sunflower seeds, almond, asparagus, bell peppers. In zinc, again spinach, shiitake mushrooms, original mushrooms, sesame seeds, pumpkin seeds, oats, and selenium mostly the fishes, all the fishes that are available. And towards the end of the talk, I just want to say that any diet is incomplete unless you also advise them that patients should have healthy BMI and should have some level of physical activity or exercise per day. And when we talk about this, we should remember that as Asians, our BMI is not the same as WHO. Our normal range is only up to 22.9, and the overweight starts from 23 to 24.9, and then at 25 it is obesity. Now, the influence of male and female body mass index on live birth nationwide register study, both of them are combinedly negatively affecting live birth rate and IVF success rate. So a preconception weight loss will improve the sperm count, morphology, increase the testosterone levels, and it will reduce the pregnancy complications. So, dear friends, let thy food be thy medicine, and let thy medicine be thy food. Thank you, everybody, for a very patient hearing.
Thank you, Dr. Shivani, for this insightful lecture. We can use this knowledge for counseling our patients, and it will definitely help them. Thank you.
Thank you. Well, it is so nice to see you after so long. At least thanks to Dr. MC Patel, we are meeting virtually.
Yeah, so now I think we should meet frequently in upcoming conferences. So now we are going ahead with the next, that is understanding endometriosis and the endometrium. I would request our coordinators, Dr. Sapna Kaswan and Dr. Manisha Moteria, to take on further the conference. May I ask Dr. Sapna Kaswan? Is she there?
Ma'am, Dr. Manisha Moteria, ma'am, not available.
Okay. And how about Dr. Sapna?
And we have to go with little change. First lecture would be from Dr. Pesi, because he is stuck up in some emergency, so he will complete and stay, then he will go. So do this.
Yeah.
If coordinator are not there, Sital, you can take over, no issue.
Yes. So like if we have our chairpersons, Dr. Raman B. Patel or Dr. Megha Sastry, I would invite them. Is Dr. Raman B. Patel there?
Even if they are not there also, you can
Great.
manage.
Yeah. Now
No
we have Dr. Fessy Luis. He'll be talking about infertility after endometriosis surgery. So Dr. Kashwan is there. Dr. Sapna, can you just introduce our speaker, Dr. Fessy Luis?
Yeah, ma'am. Good afternoon, everyone. Can I have Sir's, yeah. Sir needs no introduction. Dr. Fessy Luis is here and will be talking about endometriosis. Sir has a great lineage of holding very good positions as a chairperson, as a secretary, and is a big name in our faculty. Sir is presently working at Amrita Institute of Medical Sciences, Cochin, Kerala, and had been the Foxy Vice President between 2021 to 2022. Can we have Sir? Dr. Fessy Lewis. This session will be talking about endometriosis.
Dr. Fessy?
This
Hello.
session is actually about understanding endometriosis and the endometrium. We have three speakers, Abha Majumdar ma'am, Dr. Parul Kotadwala, and Fessy Lewis sir. Can we have any of the speakers, or are we going forward with Dr. Fessy Lewis?
Yes, I can start. I'm Dr. Abha
Okay.
Majumdar and I can start.
Yes. Yes, ma'am.
Can I have ma'am's CV? Can I have ma'am's CV?
I don't know whether you have it or not. I never sent it.
नहीं
Ma'am,
नहीं
please
7
have it here. वो क्या कहते हैं नाम ही काफी है. I would have just said that.
We
That
have
would have been
CV.
much
This is a
better.
very, very old CV. This is like very old. So don't
And you
have to
looking
pick
young. You
anything.
looking young.
If Fessy is there?
But I think I'll do
No,
my
sir.
lecture if you want, because I really have to leave by 4 o'clock.
Okay,
And
ma'am. We have. We'll be
I am
starting.
also available. Okay.
We have a handshake of all three of them. We'll start with the session. If everyone allows, we'll start with the session with Abha Majumdar ma'am, and she'll be talking about thin endometrium. What more can we do?
yeah, just tell me if my slide share is working, please. I am starting my slide share. Can you see my slide? Not yet. Share, okay.
Hello.
See my screen?
Then you had been introduced and you didn't start. No, because that's what I told to call 5 minutes back. I had to side my car and on my laptop and to the no issue. So now Abha madam is going to be here, and just after Abha madam, you will be there. So be ready. Let me say I'm driving. That's why I called you before starting. Then you didn't take the phone. Okay. No issue. Talking about 20 minutes.
Fessy, can I start? Fessy, you will finish your driving by the time I finish. So don't worry. I'm just seeing whether you can see my screen or not. Can you see my screen?
Yes, ma'am.
I would request the organizers to please kindly help ma'am in screen sharing.
No, you'd have to unmute me. Am I unmuted?
Ma'am, you are audible. You are audible. No worry. Just change the slide. No, again you are muted. Ma'am,
Okay.
you have.
Now, am I audible now?
Perfect, ma'am.
Okay, so can you see my slide also? But I can't
Yes, ma'am. Yes, ma'am.
see. I can't see. I can't see my
Can you
screen.
just stop and reshare, ma'am? Otherwise.
Yeah, I'll just do that. Stop share and then I'll reshare. Okay. Slide share. And this is the one I need to share. And something is not working.
You have to just open the PPT first and then share the screen.
Okay, let me see. I will just open the PPT first. I did open it. Wait, let me just do something about it. Sometimes this Zoom meeting really gives you a heart attack, which it is giving me at the moment. I don't know what to do. Now I can see the share option and I can see my screen and I can see this. But the moment now participants can see my application. Okay. So can you see the screen now?
Yes, ma'am. Yes, ma'am. Perfect.
So happy Guru Purnima to everyone. I mean, all my students are my gurus and my gurus are my gurus. So on this auspicious day, I thank my guru for their guidance. And I also wish everyone in advance the World IVF Day, which is coming very soon. And I dedicate this day to our patients who give us a chance to practice on them. Thin endometrium is the topic which I have asked to speak on. And well, there was nothing known like thin endometrium ever before. Asherman was described once upon a time in the 1800s, but the development of all this happened with the development of ultrasound. And the first page of the most famous paper in obstetric ultrasound, the journey started in 1958 by Ian Donald, where investigation of abdominal masses was done by pulsed ultrasound. And then came transvaginal sonography, and Aloka and Ked's technique developed commercial transvaginal transducers in the mid-1960s. And then happened the birth of the super baby in 1978, whose birthday we are going to celebrate 3 days later. The concern for thin endometrium only came up then. What is the purpose of endometrial growth and receptivity? It is all targeted towards achieving only one ultimate function, which is implantation of embryo, which occurs within the window of implantation, which is a self-limited period of endometrial receptivity spanning between 19th and 23rd day of a 28-day menstrual cycle. That means embryo implantation happens between these 3 to 4 days. Now, implantation failure, how does it happen? It could be a defective seed, which means embryo, defective soil, which means endometrium, or there could be miscellaneous factors preventing implantation. But what I am going to talk about is defective soil. And in defective soil, there are so many reasons which could make the soil defective, like local causes in the uterus and endometrium, adenomyosis, submucous, intramural, fibroid, septum, synechia, endometritis. It could be altered expression of adhesive molecules, and it could be thin and thick endometrium. My topic is thin endometrium. Now, theories why thin endometrium impairs implantation. We are only worried about endometrium because it disrupts a very important function of human race, which is implantation. The functional layer of the endometrium, if it is thin, what happens? You can see the functional layer here, and this is the basal layer. If the functional layer becomes thin, there is more blood flow. There is higher oxygen tension, which alters HOXA10 alpha-5 beta-3 integrins and increases the reactive oxygen species over there. And for successful implantation to occur, the embryo requires a relative hypoxic endometrium. After ovulation, that is why there is constriction of the spiral arterioles, so that the blood flow reduces to the endometrium and to the capillary network, and which reduces oxygen tension, which facilitates implantation. So there is an increase in VEGF, HOXA10, and alpha-5 beta-3 integrins. There is a decrease in ROS, and hence thin endometrium is of concern to us. There are two factors I want you to understand very clearly: implantation failure and thin endometrium. You have to remember that an absolutely normal-looking endometrium with good thickness may fail to implant an embryo, and that constitutes recurrent implantation failure, whereas a thin endometrium can also implant an embryo, though less frequently. So when do we call an endometrium thin? At the height of proliferative phase in an ovulatory cycle with maximal estrogen exposure, if endometrium is lower than 7 millimeter and does not show a triple line characteristic, it is generally felt that the endometrium is thin and might interfere in optimal implantation. So what is the building stone for the architecture of the proliferative phase? It is rising estradiol levels. And if you see, this is the premenstrual part, the menstrual part, and here the endometrium goes on building up because of the estrogen, and the arterioles are so much straighter, which become very coiled later on. From where does this estradiol come? Well, endogenous estradiol comes, which is natural, and it comes in natural ovulatory cycles. Anyone who ovulates will have this. Otherwise, someone who doesn't ovulate, we stimulate their cycle, and we, whether it is clomiphene, tamoxifen, letrozole, gonadotropins, all of them, as promote ovulation, will also promote the genesis of endogenous estradiol. If there is no natural ovulatory cycle, there is no stimulated cycle leading to ovulation, then exogenous estradiol can also build the endometrium, and it could be oral estradiol valerate, now hemisuccinate, and so many more preparations which have come, vaginal estradiol valerate again, and dermal estradiol gels, which are given to the patient, and on a daily application, they go on building up the endometrium. What are the causes of thin endometrium? Well, if we look at thin endometrium, then we will find that some are inherited causes like congenital uterine anomalies, hypogonadotropic hypogonadism, and advanced maternal age. Whereas in acquired, you have a whole list of things starting from Asherman, and also talking about surgical post-DNC ablation, aggressive myomectomy, tuberculosis, sometimes clomiphene citrate, chemo, radio, premature ovarian insufficiency, all that can lead to thin endometrium. And then the third line is idiopathic, where we don't find anything, neither inherited nor acquired, and yet the endometrium is thin. So modalities to diagnose, of course, ultrasound is the gold standard to diagnose all thin endometriums, whether it is 2D, 3D, we look at volume, or we look at Doppler flows. Having said that, like in all branches of medicine, we need to treat something. One is when we know the cause, and one when we don't know the cause. So if we find an offender, then we have only surgical treatment and medical treatment, like in all other branches. If offender is not found, then we try to improve uterine blood flow or stimulate endometrial cell colony growth. So if we find offender, what is it? If it is surgical treatment, what are the offenders which can be treated surgically? Well, assessment of Mullerian anomalies, resection of septum, visual demonstration of synechia resection, snipping off of endometrial fibrosis, and then endometritis, cavity distortion, and we can resurrect it. If there is a foreign body, we can remove it. If there is a submucous myoma polyp, that can be removed. In medical treatment, what do we do? It is generally endometrial infections which can be treated. There could be non-specific endometritis where we can use doxy, erythromycin, or it could be specific endometritis like endometrial tuberculosis where we have to give them proper anti-tuberculous treatment. Having said that, there is a whole group of patients where we don't find an offender. If you don't find an offender, what do we use to improve uterine blood flow, to boost endometrial development? Well, what all has been proposed is low-dose aspirin, vaginal sildenafil, or triglycerine trinitrate skin patches. They all produce nitrous oxide, and this in smooth muscle causes dilatation of uterine blood vessels. Pentoxifylline or high-dose vitamin E acts as an antifibrotic agent and again causes vasodilatation. L-arginine and again glycerine trinitrate has vasodilatory effects and increases blood flow. What drugs do we use to boost endometrial cell proliferation? First, we were talking about vasodilatation, and now we're talking about drugs to boost endometrial cell proliferation. Well, it could be, I've just given a list of 5, which are being used interchangeably in various centers: GCSF, local or parenteral, human chorionic gonadotropin intrauterine, tamoxifen, platelet-rich plasma, and stem cell therapy. GCSF is the first one which I have written. Well, in 2013, there was a pilot study of granulocyte colony stimulating factor in the treatment of unresponsive thin endometrium, which was resistant to standard therapy, and slow intrauterine perfusion on the day of HCG and repeat on the day of OCR may offer an effective last resort treatment for thin resistant endometrium. However, there were a lot of questions with GCSF, and that is why it could never become very popular. How does GCSF thicken the endometrium within such a short time interval that you give it on the day of HCG, OCR, and by the time you're ready to transfer your embryo, the endometrium is thickened? Whether the treatment protocol which we are using is maximal to determine which delivery route, whether subcutaneous or intrauterine, for the drug is superior. Will more frequent administration, maybe daily, have a superior benefit? Will MCSF or GM-CSF have better effectiveness? So there were MCFS is mononuclear CSF. So these were the unanswered questions. So yet this is a drug treatment which has not gained popularity. Then we come to the second one, human chorionic gonadotropin. How does this act to improve thin endometrium? Well, the theory says that modulates endometrial stromal cell receptivity to interleukin-1, which also triggers angiogenesis to induce major molecular changes that are essential for embryo implantation. And this was one study in 2012, then came another study in 2013, where follicular HCG endometrial priming for IVF patient experiencing resistant thin endometrium. But then after that, what happened? That low-dose HCG during proliferative phase may adversely affect endometrial receptivity in oocyte recipients. This was seen, and hence this also never gained popularity. Then came in tamoxifen, and the article was published as new uses of an old drug. And they said a successful pregnancy in recurrent thin endometrium in patients of thin endometrium, tamoxifen treatment may be successful alternative method of action. And what is the method of action? Proliferative action of endometrium by modulating estrogen biosynthesis and metabolism locally in the endometrial cells. And it also upregulates expression of Ki67 and IGF-1, which are markers of proliferation. So these were the methods, and we all know that tamoxifen does lead to thicker endometriums, yet it could never gain popularity because it did not increase the implantation factor. Then has come in PRP, platelet-rich plasma, which is the favorite of everyone. I see every center, a little thin endometrium, and they, because it's very easy to make, it can be made in one's own center. A lot of use, and I would say misuse of this drug is happening, because whatever we say, we are introducing a blood product to the uterine cavity. And if good antibiotic cover is not given, it can sometimes lead to endometritis. So this is platelet-rich whole blood extract, having removed red and white blood cells, high concentrations of growth factors, activated platelet released by their alpha granules, high concentration of VEGF, TGF-B, and PDGF. So PRP is prepared from autologous blood by centrifugation and infusion of 0.1 to 1 ml PRP into the uterine cavity on the 10th day of HRT cycle. Well, people I've seen doing it on alternate days, on a daily basis. I mean, there is no standardization of technique for this. So then comes the most important powerful tool, which is still being investigated and is in the research domain, is stem cells. And if you see, the stem cells could be obtained from mesenchymal derived stem cells, or they could be bone marrow derived or human amniotic epithelial cells. We are deriving our, we have had a pilot study approved for 10 patients through ICMR, and we've got a grant for that. And that is how our research cell is making mesenchymal derived stem cells from umbilical cord of newborn babies. Here, this is not, I mean, these are not differentiated. So any cord can be used for this, and from the cord, they derive the mesenchymal stem cells. So look at the thickness of endometrium, which could go up because growth factor goes up, and this is how we find the endometrial cells becoming thicker. So, well, this is still under research. Everyone is researching. We are also researching on this, and we'll be able to give definitive answers only when the research is over. Let me bring you some evidence. This is evidence from 2018 published in Human Reproduction, which is one of the highest impact journal in the fertility world today. And this was a retrospective cohort analysis, autologous and donor fresh and frozen thaw IVF ET cycles. 24,000 fresh and 20,000 frozen thaw IVF ET cycles results were compiled. And what did they find? Clinical pregnancy rate and live birth rate decreased significantly for each millimeter below 8 millimeter in fresh IVF cycles and below 7 millimeter in FET cycles. In any case, if in a fresh IVF cycle we find the endometrium 8 millimeter, then in the FET cycle we look at the endometrial targeting 1 millimeter less than what it was in the fresh cycle. So here also they've given that after below 8 in a fresh IVF ET cycle and below 7, there is a significant drop in pregnancy rates, but pregnancies do happen. And another thing that was for IVF cycles, fresh and frozen transfer, this is for IUI. Endometrial thickness in women undergoing IUI with ovarian stimulation. How thick is too thin? This is a systematic review and meta-analysis in which 1,563 articles were taken up, 23 were included, and 3,846 women data of them were looked into via 17 RCTs and 6 cohort studies. What did they see? No evidence of difference in endometrial thickness between women who conceived and women who did not conceive, number one. So whether your endometrial thickness was very good or it was just optimum or it was even below normal, if she had no pathology in her uterus, there was no difference. Clomiphene citrate had a significantly thinner endometrial thickness than treatment with gonadotropins, but there was no evidence of difference in endometrial thickness when comparing clomiphene with letrozole. This is what I have seen. I've tried letrozole in a lot of patients, but those who have a thin endometrium continue to have thin endometrium. And no evidence of association between endometrial thickness and pregnancy rates during IUI ovarian stimulation cycles, and therefore cancelling IUI cycles because of thin endometrium may negatively affect clinical care. So please do not cancel IUI cycles because the endometrium is thin in that cycle. Go ahead and you will still get pregnancies. Having said that, this is published in RBMO, and this is 2019 data, which summarizes that if you, this is low to moderate evidence. In a fresh embryo transfer, there's nothing to say, but frozen thawed embryo transfer says estradiol administration adjustments increase the dose, increase the duration. Then unclear effect in frozen thawed cycle is of HCG, sildenafil, pentoxifylline, tocopherol, platelet-rich plasma. It's very unclear whether they produce anything good. Similarly, in a fresh embryo transfer cycle, whether GnRH agonist during luteal phase or GCSF infusion helps is unclear. And then no evidence of benefit is with sildenafil citrate in fresh embryo transfer and in frozen with aspirin and GCSF. So GCSF, aspirin, sildenafil are totally out. Rest all is unclear effect. And the only drug which has some effect is estradiol administration in frozen thawed cycle. And in fresh embryo transfer, it is the natural estrogen which is being made has the highest effect. So my take-home message is hysteroscopy is a must in persistent thin endometrium. Even a virtual hysteroscopy by a 3D ultrasound shows normal cavity. Offender found, treat appropriately. If you don't find the offender, all drugs intending to increase blood flow or cause proliferation of endometrial cells may be tried in desperate situations, but with uncertain outcome. At present, development of stem cell therapy may be the only scientific way of regenerating atrophic endometrium. What is most important is avoid iatrogenic complication. This is of utmost importance. Thank you very much. Future research is, well, stem cells are now in future research. There exist biomaterials such as nanostructure, lipid carriers, hydrogels, scaffolds, which are capable of promoting stem cell drug delivery and thus improving the outcomes of stem cell therapy. What we are doing is through the hysteroscope with a ovum pickup needle, we are injecting the stem cell into the subendometrial part of the uterus at 4 sites and seeing how it works. Then HABOT is mild hypoxic therapy which is being given to endometrium in hope that it might increase the endometrium. Bioengineered endometrium is trying to be made, and I'm sure with AI coming into use, it will help. And microfluidics is also in the future somewhere. So having said this, thank you very much for having me to talk to you about thin endometrium and exploring all avenues. Now, this is all finished. You can take all this from RBMO, which is the Canadian Fertility and Urology Society, which has given us very clear guidelines about what to consider and what not to consider. So they say everything has a weak effect, except the strong effect is that every 1 millimeter less endometrium has a negative impact on happening of a pregnancy. And this is our own Dr. Nagori, whose paper was published. I thought my talk would go incomplete if I do not show this. Endometrial regeneration using autologous adult stem cells followed by conception in vitro fertilization in a patient of severe Asherman syndrome. So I hope there is more to this, and we will all be able to achieve more pregnancies if we can learn the proper way of endometrial regeneration. Thank you very much.
Thank you very much, Abha ma'am. Can we go forward with the next speaker, please?
Yes.
The next speaker is Dr. Fessy Lewis. Sir would be talking about infertility after endometriosis surgery, balancing the risks and rewards. Over to you, sir.
Yes. Good evening to you all. Sorry, Parul sir, because I'm traveling. That's why. So I think my allotted topic is infertility after. Can you hear me?
Yes, sir, we can.
Okay.
Yes, you are audible.
Yes, sir. Infertility after endometriosis surgery, balancing risk and rewards. I think Parul sir will be talking little bit of the more of theoretical aspect. So let me start. What is endometriosis? It is within the uterus condition. That is the word meaning. It is the one second. So it is the endometriosis is endometriosis is endometrium including both endometrial glands and stroma in ectopic location. And the prevalence is in infertile patient, it is some studies from 10 to 22%. As you all know, right on the MBBS time, causes of infertility, anatomy, tubal occlusion, disorders, follicular growth, and ovulatory dysfunction. And endometrial receptivity is definitely decreased, and increased prostaglandins affect the tubal motility and folliculogenesis and corpus luteal function. And alteration in the peritoneal fluid and inflammatory cytokines is also found to be reason. And abnormal systemic immune response and also dyspareunia is one of the reason for endometriosis causing infertility. And the different classification is there: minimal, mild, moderate, and severe is there. And minimal to mild, there is no clear-cut established role in infertility. And moderate to severe disease, definitely there is role of infertility is established, and definitely there is no controversy in whether to we intervene or not. And coming to the treatment, there is medical, surgical, and ART are there. And all the just before going to the surgical methods, you have to see that medical management is very effective in treating the symptoms of endometriosis before conception, and pre-treatment with these agents does not improve fecundity, and hence their implementation will only delay the attempts at conception in infertility patients. This is one study, a Cochrane database, little old, 2007, that tell that comparing ovulation suppression versus placebo for endometriosis reports no evidence of benefit on pregnancy outcomes in endometriosis with infertility. And this is another study which came in 2012, tell that fertility, whereas the medical therapy is effective for relieving the pain associated endometriosis, but there is no evidence that medical treatment of endometriosis improves the fertility. So surgery, what the aim of the surgery is, one is curative, and also the conservative. So if there is hydrosalping, cyst reduction, and pelvic collection, that is the conservative surgical role in endometriosis. And surgical treatment, basically, it is the removal of the endometrium by aspiration or cystectomy, removal of the endometrial implants by fulguration or excision, and removal of adhesions to restore the normal anatomy, and removal of deep rectovaginal and rectosigmoid endometriomas to relieve the symptoms and the associated pain associated with that. So how do you do that? There is always this laparotomy, sir, but laparoscopy. But laparoscopy is considered as the gold standard for infertility, because we can not only diagnose, but the treatment of endometriosis by also can be done the same sitting. Removal of adhesions caused by the disease also can be corrected with that. And the other advantages with laparoscopy is better visualization, less tissue trauma, smaller incisions, speeder post-operative recovery, less post-operative adhesions, and results are equivalent or better to than laparotomy in normally. But there is a role for laparotomy only in advanced cases, because when there is dense pelvic adhesions involving ureter, bowel, and uterine vessels, and for whom fertility conservation is not necessary. So the aim of surgery in endometriosis with infertility is to restore the normal anatomy by removing the endometrium and removing the implants, and hydrolysis by dissection, cutting, and cauterization using either electric cautery or laser, and complete hemostasis should be attained. And minimal dead tissue and raw materials, raw area must be left behind as far as possible to prevent the re-adhesion formation. And also, we must also look into the risk of the surgery, like injury to the tubes and ovary, injury to the vital organs, and bleeding, infection, and fibrosis, which can lead to more severe adhesion. So the first surgery is the best surgery. And also damage to the ovary by direct cauterization of the ovary or the follicle, or the removing the cysts while removing the cysts and cauterization. Also injury to the blood supply to the ovaries by when we use coagulation of the inferior pelvic or the ovarian ligaments, which can lead to ovarian and less decreased ovarian function, total loss of ovarian function also in if you are not careful. And peritoneal endometriosis, we can do the excision, coagulation using the unipolar or bipolar electro instruments, and if facilities by using the vaporization by the laser, which is more specific, but it is very costly, and very, very few centers has that. So here, this case has got, you can see the minimal or mild endometriosis. There is no clear-cut guidance if you are seeing like mild endometriotic lesion like this, whether you have to tackle is that. But as a whole, I personally believe that if there is mild endometriotic lesions, if you incidentally find during laparoscopy, we have to coagulate that so that the disease will not progress into severe adhesions, severe lesions afterwards. And also, if there is distorting the anatomy, we have to go for the restore the normal tubo-ovarian anatomy as far as possible, and pouch of Douglas clearance must be done as far as possible in the first sitting. Here, I usually do a combination of the blunt dissection, cautery, and the sharp dissection of the scissors. You can see here the tubes are adherent to the ovary, and the bowel is also pulled up. So pouch of Douglas must be clearance must be done as far as possible in the first sitting, because repeat addition when the re-adhesion formation, the plane of cleavage will be difficult, and the raw area must be coagulated as far as possible to get a normal clearance. And always after that, you must clean the scar tissue, and by using the saline irrigation, and any bleeding areas has to be coagulation. And what I usually use is the manipulator, which is automatic, which clearly snugly fit in the uterine cavity. So the pouch of Douglas clearance is very easily attained. You can see when you use a manipulator carefully, we can get the plane is more easily attained, and we can get the pouch of Douglas clearance. This is very important in the infertile patients where the ovum pickup usually occur from the free tube from the pouch of Douglas. So, and at the end, we must try to restore the anatomy as far as possible. So, if there is endometrioma, which usually result as deposit on the surface of the ovary, which cause invagination of the cortex with adhesion over the surface, which result in encapsulated cyst. And there is a classification for endometrium, which is mild, moderate, and severe. And here, whether to drain the endometrium or excise or coagulate using bipolar electros instruments, I usually go for excision of the cyst wall. Only the ovarian reserve is less and the patient is for ART, then go for just drainage of the endometrioma. And the superficial ovarian lesions has to be vaporized. Usually ovarian endometrioma less than 3 centimeters has to be aspirated, irrigated, and inspected, and cystectomy has to be done. And based on the current evidence, ovarian cystectomy appears to be the method of choice. So if you see a endometrioma like this, the incision is made on the anti-mesenteric border. So that will help to less interfere with the vascularity of the ovary. After that, we have to enucleate the cyst wall. At one point, sometimes the cyst wall may be densely adherent to the ovarian normal tissue. Then you must not be adamant that we will be doing the complete cystectomy. We have to coagulate and remove and cut the tissue. And at the end, we have to look into any bleeding areas by thorough irrigation. Only those areas has to be coagulated so that we will attain hemostasis as far as possible. And if it is a bilateral endometrioma, we have to always think about the reduced ovarian reserve. And in elderly patients, or if the ovarian reserve is less, then you have to look for the IMH and make sure the decision according to it. If the IMH is less, and if you can retrieve good oocyte from one ovary, it is better to go for ART. But if the bilateral endometrioma is there with the reduced ovarian reserve, and if you are planning for IVF, and if you cannot retrieve oocyte by seeing the normal tissue, then laparoscopy and just drainage of the cyst wall is advised. So precautions must be complete adhesiolysis by laparoscopy in first sitting, complete hemostasis, method to prevent adhesion, careful use of energy devices near the ovarian ligament and inferior ligament. The methods to prevent adhesion, there are a lot of things has been tried, but not has been found to be 100% effective. The curative surgeries to remove the endometrioma, destroy or remove the endometrial implants and nodules, and adhesiolysis. And surgery in endometriosis should be attempted only if the couple can stay together immediately after the surgery, because post-operative and also if there is associated male factor, also it has to be corrected. And after the surgery, the aim is depending on the age, how the surgical result is, that whether there is any other associated factors affecting the infertility. So highest pregnancy rate is in the first year following the surgery. And if you can see depending on the severity, how we can correct, that depends on the result after the surgery. But there is no role for post-operative, immediate post-operative medical treatment, because when you give that period, the ovulation will not take place. And Cochrane data clearly tells that post-operative medical role is only if the patient is for IVF, and if going for immediately going for that for suppression after the surgery. So the stages of the endometriosis, what the routine IFS staging, the main problem is that suppose if the pouch of Douglas is obliterated, it is straight away 40 points. It is severe form, but the tubes may be free. But for infertility, the main drawback is limitation of IFS staging is it has got poor correlation with pregnancy rate. So what unanimously followed is endometriotic fertility index. What the aim of what the principle of the endometrial fertility index is, what we look for the least functional terms, functional score. That means at the end of the surgery, what function you can expect from the fallopian tube, embryo, ovary from each side. If you can expect normal function, it is 4 points. If the absent or non-functional is grade 0. And this, along with that other factors, IFS factors, and age and infertility years and prior pregnancy has been together going for the endometriotic fertility index. If the score is high, we can wait for a few years. If the score is less, then we must not wait too long. We must go for an ART procedure at the earliest. And role of second surgery in IVF compared to the IVF is preferred. That is, all the studies have proved that there is no role for second surgery in infertility compared to the IVF. And if there is associated lesions like hydrosalpinx, we have to tackle. That is a role for the supportive surgical therapy in endometriosis patients with infertility. So if there is a minimal adhesion at the fimbria, we can do the addusolysis and relieve the hydrosalpinx. That is addusolysis. Or if there is initially people have tried vaginal aspiration and antibiotics, but the recurrence rate is high and the failure rate is high, so it is no longer advised. And salpingostomy can be done, but the chance of ectopic pregnancy is high. And the salpingectomy, also people have tried to remove the hydrosalpinx. But the problem is that when you do the salpingectomy, we must be careful in using the cautery as away from the ovary so that the ovarian vascularity is not affected. And especially in patients with severely damaged hydrosalpinx or severe adhesions, it is not possible. So in those patients, this advice is to go for a proximal tubal ligation and debulking of the hydrosalpinx from the uterine cavity, especially in patients with raised FSH, low ovarian reserve. But still in those patients, even if you're going for IVF, there is high chance if there is a dense hydrosalpinx, it can affect the ovum pickup. In those patients, we can go for proximal tubal ligation and go for a salpingostomy to relieve the hydrosalpinx before going for ovum pickup. And it is definitely found that if you go for a salpingectomy, it is affecting the ovarian reserve. This is one study which came in 2006 clearly telling that even IVF pregnancy rate is less if the patient has undergone salpingectomy for hydrosalpinx compared to the proximal tubal ligation. So before concluding, the endometriosis, according to SHA 2002 latest guidelines, laparoscopy is no longer the diagnostic gold standard, and it is now recommended in patients with negative imaging results where empirical treatment was unsuccessful or inappropriate. That means it is not the diagnostic gold standard, but definitely treatment-wise, it is it has got a role. And extended administration of GnRH agonist prior to ART treatment to improve live birth rate in infertile women with endometriosis. That ultra-long protocol is no longer recommended due to unclear benefit. And endometriosis fertility index was added as a step in the treatment as it can support the decision making for most appropriate option to achieve pregnancy after surgery. And this is according to the latest SHA guidelines. And the surgery, after that, we have to, in infertility with endometriosis, we can, depending upon the clearance, we can wait for spontaneous conception or go for MA, that is medical assisted reproduction. That is in the patients undergoing surgery. But if the ovarian reserve is less, directly you can go for medical assisted reproduction. But there is definitely no role for hormonal treatment with the patients with endometriosis with infertility. So definitely there is a role for surgery in the patients with infertility, and depending upon the correction, how we can wait or whether we can go for a IVF procedure. And if there is associated surgery, supportive surgery can be given if there is hydrosalpinx, large endometrioma, where we can retrieve the oocyte. So to conclude, there is no role for medical management infertility associated with endometriosis except for ART, and laparoscopy is the preferred method of surgery. Risk of major complications to be balanced. Surgery results are less in severe cases. IVF preferred to second surgery, direct IVF instead of surgery in selected cases, and treat hydrosalpinx even before ART, and pre-treatment with the GnRH agonist improves result in IVF ICSI. Initially, it was told for prolonged suppression before ovum pickup. Now it is prolonged suppression before embryo transfer. And thank you for patient hearing.
Thank you very much, sir. Can we go forward with the next lecture from Parul sir? Can I have Parul sir's TV, please? like all the stalwarts in this session, I think Parul sir also doesn't require an introduction. Sir is a very famous endoscopic surgeon and a gynecologist. Presently, sir is based at Zydus Hospital, Ahmedabad. Sir has held various positions as a chairman of ICOG, vice president of ISOPARC. He's been president and chairperson of all the very famous association in our field. I'll now call upon Parul sir to please start forward with his lecture. Sir will be talking about endometriosis and infertility, approaches and beyond.
Okay. Hello, am I audible?
Yes, sir.
I am not permitted to share my slide. Can you do something?
Sir, I'll request.
You can, sir.
Because that message came that you can't. That is why I got. Is it
All the
visible?
traffic jams, sir, the traffic jams were because of Fessie Lewis, sir, you know.
No, it's
Sir,
okay, but is this visible?
yes, it's visible for us. I hope it's for everyone.
Okay, well, good.
Yes, sir. Thank you, sir.
Well, thank you very much. It is indeed a pleasure to participate in programs, and I thank Dr. M.C. Patel and Dr. Alpesh Gandhi for conceptualizing this program. I wish Dr. M.C. Patel all the best for his endeavors in his elections. Today, I will share with you endometriosis and infertility approaches and beyond. That is the title. So, if you look at the chronology, perhaps this should have preceded the surgical management. But as Dr. Fessie was tied up with something else, he has preceded me. I personally am a surgeon and always favor a surgery. But let us look at the current status about endometriosis and infertility. I have not purposefully put up any of the videos because I thought Dr. Fessie will take care of those. Now, some time back, there was a big debate going on. I think there is something wrong with my presentation. Why the slides are jumping? Okay. In the fertility sterility issue of 2018, the editors mentioned this. The pros and cons of surgical management have now been debated for almost 15 years, but the debate rages on still in 2018, calling for a fertile battle on this topic between world experts in the field in an attempt to solve this clinical conundrum for healthcare practitioners. And this was the fertile battle where 8 expert endoscopic surgeons and 8 fertility specialists put in their opinions. So I would just like to highlight that aspect that we still do not have an answer. So we have to individualize for our own patients. But we should also look at the data published and what is happening globally. Now, when we think of endometriosis, how endometrioma impacts fertility, let us think about that. It impacts the ovary, the oocyte quality, ovulation, ovarian reserve, and ovarian aging. All of this happen when there is ovary involved in endometriosis. In fact, there was a beautiful paper which has shown that ovarian aging happens in endometriosis if you do not treat them. So these ovaries age faster compared to normal ovaries. The peritoneal milieu is altered by ROS, reactive oxidative stress, by iron toxicity, iron release from the blood, inflammation and angiogenesis. Anatomical alterations in form of additions and tubo-ovarian relationship getting disturbed, embryo quality, fertilization ability, ovarian response to drugs altered. So all this also happen in endometriosis, and some people feel that endometrium, the implantation issue and poor growth, also is an issue of endometriosis. However, this is being debated. Now, this number 2 and 3 can be corrected by surgery, and 2 and 3, in fact, can be bypassed by the IVF people. Now, how treatment works in IVF, unexplained accelerated mode, multiple OVA recruitment. Is there a role of IUI? I think it is more after surgery than direct. It bypasses the fallopian tube and bypasses the peritoneal cavity. So those are 2 plus points. But problem is that today, if it has not worked, tomorrow patient is helpless. So it has to work. If it doesn't, then again she has to think about alternatives. Surgery, it helps in both diagnosis and therapy simultaneously. Of course, laparoscopy is always better than a laparotomy. It removes the pathology. It also brings about anatomical correction and restores the normalcy in the abdominal cavity. So those are plus points with surgery. The only big problem is recurrence. So unless you do your surgery well, and in spite of doing the best possible surgery, recurrences are there, and hence we are worried. And recurrences are always worse than the primary situation. So how do we approach a case of endometriosis? We need, first of all, to have a very early diagnosis and then a decision about how to handle that diagnosis. And we all have seen that diagnosis is often very confounded and delayed. A subfertile woman with a history of menstrual pain and normal clinical examination, in absence of positive ultrasound for endometriotic cyst, provides a big dilemma for most gynecologists. Whether to, and interestingly, 60% or 70% of endometriosis is surface type of endometriosis, where ultrasound will not show you any cyst. Clinically, you may feel the nodularity of uterosacral, but it is very uncommon. Most of the time it is missed. And this is where we are really confused what to advise our patient. The advice for laparoscopy is not confident enough from our side. And patient is always reluctant for invasive procedure in absence of firm recommendation. And this leads to delaying diagnosis. This particular paper published from Norway showed that delay of 3 to 11 years between onset of pain and diagnosis. This large survey in Europe, what they found was 65% of women with endometriosis were first misdiagnosed with another condition, that is 2 out of 3. And 46% had to see 5 doctors or more before they were correctly diagnosed. And this results into average delay of 8 years between onset of symptoms and diagnosis. So how can we make early diagnosis? One is, of course, presumptive diagnosis, dysmenorrhea. Unfortunately, in our society, menstruation is equated with pain. If there is no pain, then also it is considered something abnormal. So all the pain, unless pain is very severe, generally it is accepted as a way of life and people do not approach a medical practitioner. Then unexplained infertility, where you can suspect that probably she might have endometriosis. Clinically, although we do mention the nodular uterosacral on per vaginal examination and those things, painful per vaginal examination, the fallacy rate is high. Ultrasound and MRI both can pick up the cyst, but unfortunately, the surface lesion, which is much more common, cannot be picked up by these modalities. People have tried various biomarkers, but as of today, none of them. They are all in research setting. There were 2 beautiful studies where they conducted histopatho examination with spatial staining for nerve fibers in menstrual blood, and that they suggested as a very accurate diagnosis, but others have not been able to replicate those findings. So in spite of everything, if you want to make a diagnosis, as of today, laparoscopy is still the gold standard. However, many a times people go for presumptive diagnosis and keep treating the patient when patient does not want fertility soon. Okay, I think one biopsy, if you have put in a scope and you find many endometriotic foci visibly, you should take at least one biopsy. Now, non-surgical diagnosis, people have been trying hard, and the Society of Endometriosis and Uterine Disorders from Europe have developed this particular protocol, non-surgical diagnosis of endometriosis based on clinical history, which would include family history, medical history, and gynecological history. Then symptoms, physical examination, and imaging by ultrasound and MRI. And they claim that their pickup rate of endometriosis accurately is around 90%. However, we need to have more studies from other people to replicate those findings. That brings us to another part, decision making. Surgery or not, of course, this is a big issue. But then, when we strongly suspect, say, endometriosis, then also whether to do surgery or not, and in what form, then following points make our decision. Age of the patient. Younger the age, we tend to avoid the surgery. The reason is simple. We are worried about recurrence. Especially those who are not yet ready for a pregnancy, we tend to avoid a surgery, because if by the time she is ready for pregnancy and recurrence happens, it will be a big problem. Associated pain. Pain is the biggest factor for which patients undergo surgery. If pain is interfering in their daily life or their daily work, then one may require a surgery. Associated conditions, septum or myoma, these two conditions alter the uterine contractility and lead to more retrograde menses and higher rates of endometriosis. Almost 30 to 50% coexistence of endometriosis is seen with a case of septum or a fibroid, intramural or submucous one. The size of the lesion, most of the studies have shown that more than 4 centimeter size of endometrioma, you need to remove it with a surgery. Laterality, bilateral endometrioma, Fessy has touched upon that, is a case where we have to be very cautious. There is almost no scope for repeat surgery, and even at the first surgery, unless you do it well, there is significant reduction in the ovarian reserve in these cases. So one should think of preserving the oocytes before we end up in a surgery. Location in ovary. Many times one would feel that although it is a small endometrioma, the ovum pickup is going to be difficult because the cyst comes in path of your needle. Then also one may require a surgery before opting for an IVF. And of course, patient's preference is always there. Spontaneous pregnancy is significantly high in a case of surgery. Post-surgery, there is significantly high chance of spontaneous pregnancy compared to no surgery. But yes, if IVF is opted for, then one may think of IVF as the first choice. And in failure of IVF, one may opt for a surgery. So the same society of, SUDE, endometriosis and uterine disorders, have developed a management protocol also. And here, through their clinical examination and various non-surgical options, they have diagnosed a possible endometriosis. Then the next question comes, immediate desire for pregnancy. If there is no immediate desire for pregnancy and we have to think of fertility preservation, then we shift patient to long-term medical therapy in form of Dynogest and other things. And if it works well, we can go on for long-term medical therapy till she is ready for pregnancy. If we find drug resistance, the lesion is progressing or no pain relief, then of course surgery will be an option. Again, one has to think here about fertility preservation. If medical treatment patient is on and now she is desirous of pregnancy, again she is moving on to either surgery or ART. And this decision, surgery or ART, as I discussed before, will be depending on those factors and personal desire of the patient. Now the question comes of fertility preservation for medical treatment. There is a big question mark. Does medical treatment preserve fertility? We do not know as of today. It is postulated that surgery reduces the ovarian reserve. So non-surgery means preservation of ovarian reserve. But we do not have any data as of today that medical therapy preserves the ovarian reserve. So that is a big question mark in managing endometriosis. My slide. Then in an endeavor to make our decisions easy, endometriosis fertility index has been designed by various institutions, and Dr. Facey did touch upon that. These are various scores given, and then another aspect was identified least function score at conclusion of surgery. This is for post-surgery judgment about what should be done, whether patient should be allowed spontaneous fertility or jump onto the IVF. So all these various scores are there, and they are only to make us a decision making a little bit easy, but ultimately we will have to be individualized. One word on pain of endometriosis. See, we all know that endometriosis is a painful condition, but there are three types of pain. In the beginning, it is nociceptive pain of the endometriosis, and which is in form of dysmenorrhea or clinical cyclical lower abdominal pain. Now, if we do not treat this, after a while, this pain changes its structure, and over time, the nociplastic processes which lower the pain threshold along the spinal hyperalgesia and pelvic floor dysfunction, which often results into dysuria, dyschezia, dyspareunia, and chronic pelvic pain. So the pain which was localized changes and it becomes reflexive. The nerves are now involved. And then if we do not treat that also, then it becomes a neurogenic inflammation. Inflammatory processes and innervation within the lesion lead to that, and which can cause hormone independent acyclical lower abdominal pain. So pain of endometriosis should not be neglected. If you neglect it over many years, then what will happen? It will end up in these types of pain, which will not be even cured by routine analgesics. And so we will have a patient who would be complaining chronically of various pains, which you cannot locate, identify its location. So pain should be treated early and properly. I don't know why my slides are not. So then one thing which has been debated a lot is the ovarian reserve and ovarian damage. The disease itself also damages the ovary and leads to poor ovarian reserve. So even if you do not treat, say, ovarian endometrioma for 2-3 years, gradually the reserve is going to decline and ovarian aging is also going to take place. So we have to check and balance the surgery versus conservative if pregnancy is not achieved. Pregnancy, once you are looking at, then of course you need to do things quickly and you have to jump onto either surgery or an IVF. Now, ACOG committee opinion summary is this, that in normal population, women with low AMH achieve similar pregnancy rates compared to those with normal or high AMH. This is a profound statement. We all are doing AMH right and left in all our fertility patients. But what is its clinical value is questionable. The best indirect marker for fertility is number of primordial follicles. And AMH correctly predicts number of follicles or oocytes after whatever treatment is initiated. But it cannot predict the embryo quality and subsequent pregnancy. So my just major point was that early diagnosis and intervention may be beneficial in women with endometrioma to protect their ovarian function. Otherwise, untreated ovary also gradually will lose its ovarian reserve. And there was a discussion about in a large endometrioma that rather than removing the entire cyst wall, we have a sandwich therapy. We remove part of it and the middle part we leave behind near the base to preserve damage to the ovary. But combined technique is not associated with better preservation of ovarian reserve as it was hypothesized. It was thought of as a logical thinking, but in absence of additional evidence from literature, traditional excision techniques may still be considered the gold standard approach for surgical treatment of endometrioma. And there are other studies also on this. One of the largest series on this topic, 65 patients continued with 6 months of follow-up after surgery. Decrease in AMH was more severe when endometriomas were bilateral or more than 5 centimeters. Initial serum AMH level was significantly higher in patients with large endometrioma, and this was because of stimulation of surrounding cortex leading to recruitment of follicles. And that study showed, I showed the conclusion before the study itself. Another large study has shown ovarian reserve evaluated with antral follicle count is not reduced after surgical treatment. So if you look at the ovarian reserve by AFC, it is the same. Based on present findings, surgery of an endometrioma may be considered safer for ovarian reserve than previously thought. This study has shown that AMH level temporarily decrease after laparoscopic cystectomy, but with complete recovery of preoperative AMH value at 12 months. So do not subject your patient to AMH soon after surgery. Otherwise, you will find that there is significant reduction in ovarian reserve, which is not true. You wait for a while and it comes back to significantly higher level. Another article published in Fertility Sterility, the decrease in the serum AMH level caused by cystectomy can recover. Our results suggest that removal of cortex might be involved in decreasing the ovarian reserve just after surgery, and that a continuous decrease of ovarian reserve after cystectomy might be attributed to other mechanisms and not the surgery. So I will not go into the detail of surgery and what are the nitty-gritty of surgery because I think Dr. Facey has covered those. Nuances of surgery, I will jump upon. One word on adhesions. Endometriosis causes massive adhesions and one has to take care of this. Otherwise, they are a big cause of both infertility as well as pain. So in nutshell, what should we do? There are people favoring IVF, there are people favoring surgery. So when you look at the surgery, there are pros and cons. It depends on surgeon's skill. So endometriosis surgery, I believe, should require a special training and certification, and only few who are really experienced should undertake these surgeries. Surgery ends up with lesser cost compared to IVF. Possible surgical complications one has to take in account. The impact to ovarian reserve and risk of premature ovarian failure has to be kept in mind. Incomplete surgery and recurrences are possible, and this may delay ART. So cost, I believe, is lesser in India for the surgery compared to IVF. It may be different abroad. As against that, in IVF, what happens? The disease keeps on progressing. You are not stopping the disease. Increase in the inflammatory reaction and oxidative stress continues. Difficult oocyte retrieval is a possibility. Risk of cycle cancellation is possible. Follicular fluid contamination sometimes with the blood is another issue. Endometrioma infection is very common if you puncture by mistake the ovarian cyst. Undiagnosed occult malignancy may spread. Risk of rupture with subsequent chemical peritonitis is another possible problem, and pregnancy-related complication. So, main indication for ART and IVF are tubal impairment, male factor. If it is there, of course, there is no role of surgery. Low EFI, failure of other treatments, or unexplained subfertility. As against that, main indication for surgery, those in blue are main indications. Presence of pain, age of patient, size of cyst, unilateral, and other pathology like fibroid or septum. The black ones are negatives for surgery, history of previous surgery for endometriosis, poor ovarian reserve beforehand, estimated EFI low, and bilateral disease. So in a conclusion, I would say that make your decision with a balanced mind. Look at the size of endometrioma, look at associated pain or in the size, unilateral or bilateral. Look at the age of the patient and perform surgery only when patient is very ready for a childbearing so that you give her the best possible results. Keep in mind the possibility of recurrence. And I would share here this much that Fesi was saying there is no role of post-operative hormonal therapy. I would give it if pregnancy is not planned soon after to prevent recurrence or at least reduce the recurrence. Always think of oocyte and embryo freezing, especially in advanced age as well as those in massive diseases there. If low AMH or reduced enteral follicle count, the best option to my mind is one cycle of stimulation. Pick up embryo, make embryos, freeze them, perform the surgery, and then perform the embryo transfer. Thank you very much for patient listening. Hello, I hope I was audible all through.
A very nice talk.
It was perfect, sir.
Yeah.
Yeah, it was wonderful listening to the surgical aspect of endometriosis. So now we are going ahead with our next topic. It is about advanced female investigations and procedures. May I invite the coordinators for this session, Dr. Aditi Rathod, Dr. Anand Bagde, and Dr. Kajal Mangukia to take over.
Hello, good afternoon, ma'am.
Good afternoon.
How are you, ma'am?
Yeah, good. Nice to see all our friends today in this web conference. I really appreciate Dr. MC Patel sir to host this web conference so that we are all meeting and we are enriching our knowledge also.
Same here, ma'am. Same here.
So please take on further.
Yes, I would. Yes. Thank you, ma'am. Thank you.
Good evening, all.
Hello, good evening. Yes, I would like to invite the chairpersons for our next session. Dr. Aditi, I can invite Dr. Pratik sir, and then you can invite Dr. Ojaswini ma'am. Yes, can I have the CVs of our chairpersons, please? Yes, I would like to invite Dr. Pratik Tambe sir. We all know him. We don't need much introduction. He has been an ART consultant and gynec endoscopic surgeon practicing at Ashirwad IVF Clinic, Mumbai. He has been a governing council member for ICOG as well as ICRM. He was a patron and managing council member at Mumbai Obs Gynec Society. And he has also been a past chairperson at Foxy Endocrinology Committee and AMOGS Endocrinology Committee. He has been a recipient of 34 MOGS, AMOGS.
I think that's enough. Let's focus on the
yes.
Don't spend too much time introducing us.
Yes. Thank you, sir.
I appreciate Dr. Pratik and Dr. Anand. Actually, we are already more than 1 hour late, so we would go fast. Right, and to our speakers also, if you can just make it from 20 minutes to 15 minutes, if you can make it, that would be really, really great. I would appreciate that. Thank you.
Yes, Doctor. Thank you, ma'am.
So could you share Ojaswini ma'am's slide? Good evening, all.
Rahul, next slide.
Please share the slide.
Just give us a minute, ma'am.
So good evening, all, and I'm very more than happy to be a part of this marathon on infertility. And thank you, Patel sir, for giving me the chance to be here. And Dr. Ojaswini Patel is Professor cum Project Officer, PPC Department of Obs and Gynae, Vimsar, Burla. And she has been affiliated to with Foxy, ISAR, IH, ISOPAB and IMA. She has been ex-executive member, ex-East Zone Chairperson, ISOPAB. She has been a coordinator, ISOPAB, Burla, Sambalpur chapters in Burla Obs and Gynae Society. She is the Vice President, National ISOPAB 2024 to 25. And at present, she is President, Burla Obs and Gynae Society. She has many awards to her credit, including 4 gold medals and Best Graduate in MBBS.
That's not what.
Best,
Thank you, madam.
Thank you. And she has many publications to her merit. Welcome, ma'am.
Thank you.
And I would request the chairpersons to introduce our speakers.
So good evening, everybody. Let me begin by thanking Dr. MC Patel, sir. Congratulations to the entire team behind this marathon effort. I'm actually in Indore for a physical event and I've just finished. So hopefully my network is okay and you can see and hear me. I'd like to introduce the first speaker of the session, Dr. Sudha Prasad. I've had the pleasure and the privilege of working with Madam when I was the Foxy Endocrinology Committee Chairperson. She was the Vice President of Foxy at that point of time. She's also served as the President of IFS, and she is very much up to date as far as the nuances of ovarian stimulation are concerned, which is actually her topic for today. The stimulation protocols to optimize results in normal responders. Requesting Madam to please go ahead.
Thank you, Dr. Prateek. I would like to share my screen.
Yes, ma'am. Please go ahead.
Nice seeing you. Okay. So good evening to all of you. It's nice to be here and thank you very much for making me in this marathon web seminar. And I congratulate Dr. MC Patel and all the best for his future endeavor. So I'm going to speak on stimulation protocol to optimize result in normoresponder. Question comes, which is the normal responder? They are usually less than 40 years of age. They have the regular menstruation and the normal basal FSH must be there. And once you give the stimulation, they should have a normal response to the gonadotropin. So what is the aim of our IVF? There should not be maximum number of oocyte, maximum number of embryos. The aim is to provide a live birth and take home baby, a healthy baby to the patient. And of course, the safety and comfort of the patient must be kept in mind. So the aiming to maximum number of oocyte, but adequate number of mature, good quality oocyte must be there when you plan a patient for the ovarian stimulation. So now the paradigm has been shifted. Initially, we used to think that maximum number of eggs should be there, and then only we will choose which one is M1 and which one is M2. But now our aim is to have the maximum number of M2 oocytes, so more fertilization, more embryo formation, and finally we should have a good implantation. So what is the optimal ovarian response? There should be 10 to 15 oocytes is the optimal. If it is less than 9, chances are there it will be a poor response if the ovarian reserve is good. And of course, we don't want more than 15. So this is the reason we have to make an individualized dosing based on ovarian response for the good prediction. To achieve, we need the 10 to 15 oocytes. We want to have the single embryo transfer, and there should be a maximum number of blastocysts are there, then they should be beatified. And of course, we have to eliminate the OHSS. So one can give the triggering and or we can have the freeze-all mechanism. So their protocol should be very simple and the patient-friendly. then only the patient will be very much comfortable and the clinician will be having the better chance of implantation. What is the best of the normal responder, agonist or antagonist protocol? Which gonadotropin to be used? Starting dose should be how much? Which trigger, fresh transfer, or will you like to have the segmented transfer? Luteal support, which one you are going to give? And of course, avoiding cycle cancellation if chances are there for the OHSS. So which protocol? The GnRH agonist protocols, once upon a time, every center used to do. And it is, of course, ideal for if the patient is less than 35, there is mild endometriosis, fibroid uterus, and if we give we do the surgery which we have learned in this endometriotic session, that give the depot GnRH, then do the long agonist, and then do the oocyte retrieval. So there were the many different kind, like ultra short protocol, where you have to give the small ultra short GnRH agonist, and if we are giving the previous skill, the GnRH agonist, and then you start the stimulation. So depending upon the patient's participation, once you do the counseling and you see the profile of the patient, then you have to decide what kind of protocol you are going to give. There are the agonist depot and the antagonist protocol also, where you give the GnRH agonist and then you start the stimulation, and then you give the antagonist as the follicle becomes the 14 millimeter in size, and then you have to do the oocyte collection. The GnRH antagonist protocol is more patient friendly, and it is increasing. I believe nearly 95 to 96% clinics are doing the antagonist protocol, because there is less ovarian suppression, lesser duration of the stimulation, lesser overall gonadotropin use, and of course there are chances that one can give the SCG trigger or agonist dual agonist trigger or dual trigger, and pregnancy rate are nearly same as an agonist protocol, and chances of course of the OHSS is quite less in these protocol. So GnRH antagonist protocol, we call the patient, and on the second or third day we start, and then we start the gonadotropin. As soon as it becomes the 14 millimeter, then we give the antagonist, like cetrorelix has been given. There are the different kind of protocol. Either you give the fixed protocol. On day 6, you give 3 milligram of cetrorelix, or a flexible when it becomes the 14 millimeter size of the follicle, because we don't want the want to lose these follicles. And this is the era of evidence-based practice. So we really need that what kind of protocol has to be given. And we have seen that in this systemic review, more than 6,000 patients were there, and it has been seen that the more and more clinicians are opting for the antagonist cycle. So question comes, which gonadotropin, whether the recombinant or the urinary FSH. So it has been preferred that the younger normal responders are there, but there is a variability of ovarian response in the norms. So question comes that you have to really see the previous record, and you see the effect. The urinary and the recombinant FSH are equally effective. The only thing, there is batch to batch variability, and probably sometimes the urinary may not be effective, and then you have to drop the cycle. Then Cochrane review even has taken the consideration of 42 trials, and we have seen that the clinical choice of gonadotropin should depend upon the availability, the convenience, and the cost and the previous patient record. We have to look everything, and then we have to give the choice to the patient whether she wants the recombinant or the urinary. We can try with that. There are the International Journal Fertility and Sterility. It assesses that the HMG stimulation appears to be associated with the lower rate of OHSS and decrease the costing requirements. So HMG again. So once you see the effect of HMG and the recombinant FSH, both are giving the same effectivity as far as the implantation and the pregnancy rate is concerned. We have done the study at Maulana Azad Medical College, and we found that agonist and antagonist, you can see here, both are statistically significant. So both are comparable. So this can be seen that whether you give the agonist or antagonist protocol, effect will be the same. So one can conclude that the FSH, recombinant or urinary, HMG, both are having their own merits. So you have to decide the gonadotropin to start and tailor the protocol depending upon the availability, the clinician experience, patient response, and of course, we have to look the pocket of the patient. Affordability is must. So how will you decide that how much dose should be given for the normal responder? If the patient is young, I always start with the 150 to 200 IU, not more than this, and this dose is quite good and very effective. If the patient is older, then you can give 225 to 300, but don't go beyond 300 to start with at all. If the patient is having the low LH, hypogonadotropic, or patient is elderly, then start with HMG, not the FSH. We have to give the HMG 225 to 350 IU for the stimulation. Optimal dose, if the first cycle, what dose has to be given? There are the different studies, and it has been shown by different factors that one can consider the age, BMI, previous response of the stimulation, the AFC, AMH, and the basal FS. These are the predictor of the ovarian response. And of course, we have to see whether the patient has endometriosis, the history of surgery, history of tuberculosis or PID, then we have to change the protocol according to the requirement. So there are the various algorithms. Normograms are there. Of course, we should not forget our clinical experience. We should not keep on thinking that this is the nomogram and this is the only requirement for the patient. We have to look for this. This is the nomogram where you can see the 30 years old patient had the 3.4 nanogram is the AMH, where the FSH was nearly the 4 IU, and we have to just join the line, and we are saying that 152 FSH to be started, and in this patient 150 IU was started, and it has shown the very good response. There are the different researchers also has done the different kind of study, and they found the predictive normogram for gonadotropin starting dose. One can add the BMI also. We should not forget BMI. If the BMI is more, naturally you have to give the more gonadotropin. So the sum of these numbers is located on the total point axis, and a line is drawn downward to the OS, and the gonadotropin starting dose comes out. So one has to compare the BMI, AMH, and the AFC. How will you monitor? Monitoring has to be done by the TVS follicular serial of follicular monitoring, and the E2 monitoring also can be added. Generally, normally the many clinics are not adding, but once you find that the 1 or 2 follicle or there are many follicles, so one should do the E2 monitoring also. The gonadotropin doses can be titrated, and the medication is modified based on above. Antagonist protocol, antagonist started when at least 1 follicle becomes 14, and the trigger can be given when 2 follicles are there more than 17 millimeter. So which trigger is important? There are the various triggers are there, like SCG trigger, the GnRH agonist, recombinant LH can be given, or we can add the low dose SCG with the GnRH agonist, which is called dual trigger, and kisspeptin also can be tried for this. The SCG is having the recombinant HCG or the urinary. I prefer the recombinant as HCG 250 microgram SC because it is pre-filled series. At the mid of the night, the patient takes very easily, and it is very, very comfortable to the patient. The OPU will can be done 34 to 36 hours after this shot. And if you give the HCG, there is a long life, the lutetropic effect will be there, and more E2, more progesterone and LH suppression may be there, chances of OHSS is there, and it may affect the oocyte quality. So GnRH agonist trigger is another one where it can be given in antagonist ART protocol. The trigger for donor oocyte cycle, high risk of OHSS, and of course where you want to do the segmented cycle. So it can be given subcutaneously. The various preparation of GnRH agonist is there. I prefer triptorelin 0.2 milligrams subcutaneously and before 34 to 36 hours of the oocyte retrieval. But there are the disadvantages that luteal phase defect will be there. The poor fresh ET, if you want to do the fresh ET, or more early pregnancy losses may be there with GnRH agonist trigger. So dual trigger is also ideal. The GnRH agonist or single dose HCG can be also given. And of course, there are the benefits, but you have to see the severe neutrolysis which is encountered by the GnRH agonist. So you have to keep in mind whether you are going to do the fresh transfer or you are going to freeze all strategy. Luteal support, there are the various progesterone are available. HCG also can be given, estrogen, progesterone. If you give HCG, chances are there the patient can have the secondary OHSS. And GnRH agonist and the progesterone various progesterone are available in a different routes of the progesterone, but intramuscular in oil is very, very painful. So everybody prefers, I believe, that the vaginal gel or vaginal tablets in 400 milligram twice daily or 3 times a day is more than enough. It can be given, and we can add little HCG if you want, then the 1000 to 2500 units on day 3, day 6, and the day 9 after the HCG trigger can be given, unless otherwise you have to look whether the patient can go in OHSS or not. GnRH agonist with the progesterone, it can be given. GnRH agonist single injection also can be given. Leuprolide on the day 6 of the ICSI, and it gives the better chance of the ongoing pregnancy. It has been shown by, in this paper. Another drug, which is the dydrogesterone. Everybody is jumping with the dydrogesterone these days, and we have also added with progesterone, and the dydrogesterone has been added for the luteal support, 10 milligram 3 times a day till the pregnancy becomes the positive, and I prefer to give up to 12 weeks when then placenta takes over. This is my own protocol, and I believe patients are coming with very difficulty to come for the IVF, so we should give as high as chances we should give for the IVF. So take home message is 5 T's. There should be thoughtful selection of the patient, thoughtful individualized selection of protocol, thoughtful monitoring to avoid OHSS, thoughtful choice of luteal support, and thoughtful achievement of conception. Then only you will be successful as a IVF specialist, and the patient will be happy to take the healthy baby at home. Thank you so much for the patient hearing.
Thank you, Dr. Sudha Prasad, madam. I think that was a fantastic talk which encompassed so many key practice points in such a short period of time. Only somebody with your experience and expertise could have summarized it so beautifully, including all the recent advances of dual trigger, USTM, all the different things which you covered. Thank you so much for being here and being part of today's program. I hand over to my chairperson to introduce the next speaker, please.
Hello, Dr. Coordinators, please, whether Nandita madam has joined.
I think Dr. Nandita madam is not seen, but I saw briefly Dr. Sanjeeva Reddy.
Dr. Banker is there. Dr. Manish Banker is there.
I think if sir is okay, then we can go ahead either with Dr. Manish Banker or with Dr. Sanjeeva Reddy.
I'm okay. I'm ready.
So moving to the next topic. I'm moving to the next topic. The topic is the IVF and ICSI, timing and techniques, demystified. So the speaker is none other than Dr. Manish Banker, sir. So the coordinators, please share the CV of Manish Banker, sir. So to introduce Dr. Manish Banker, it's the director of Banker IVF and Women's Hospital, awarded the Dr. B.C. Roy Award to the Medical Council of India for the year 2017. And he was the past president of ISAR in 2012 to 2014, the Regional Representative International Committee for Monitoring of ART, Senior Associate Editor, Journal of Human Reproductive Sciences, Member Board of Directors, Member Surveillance Editorial Board of IFFS, Member Board of Directors, Pacific Rim Society of Reproductive Medicine, Founder Board Member, Aspire, and member draft committee of ART Bill of India. So I request Banker sir to move forward with the presentation.
Thank you very much for the kind invitation. It is really a pleasure to be a part of this very interesting and a very comprehensive webinar. So what I have been asked to speak on is demystifying the techniques and timings of IVF and ICSI procedures. We all know that all interventions that will include in vitro handling of either sperms and or oocytes or even an embryo for the purpose of reproduction is included as an assisted reproductive technology. And what I shall be focusing on is the last two, the IVF and ICSI. So my previous speaker, Dr. Sudha Prasad, has already mentioned about the nuances of ovarian stimulation and folliculating monitoring, the ovulation induction or the trigger. And once we reach and complete the stage of egg collection, we then have the issue of performing insemination, either through the conventional IVF or through intracytoplasmic sperm injection. And this is what I will be focusing over the next 15 minutes or so. So IVF essentially means in vitro fertilization. That means a sperm and the egg is incubated outside the body in vitro. And since the initial attempts were done in a test tube, we got the term test tube baby. But today it is done either in 4-well dishes or in flat dishes. And the idea is to prepare an embryo which can then be subsequently transferred into the uterus. So conventional IVF is the procedure where we separate the oocytes, or rather the follicles, and we add washed semen sample to these follicles in a petri dish. And we then wish that one of the sperms would fertilize the egg and would eventually result in the generation of an embryo. So the steps to do this conventional IVF begin with preparation of the semen sample. This can be by any of the methods, either a density gradient, a single simple swim up, or a centrifugation and swim up, depending on the count and the motility. But we should use a technique which is least harmful to the sperm and which will lead to the least production of ROS. So the cumulus oocyte complexes, which are, when the follicular fluid is aspirated, the embryologist first separates the cumulus oocyte complexes from the follicular fluid. And these are then kept in dishes and cultured in a culture media for varying periods of time to achieve equilibrium. And the sperm count is then adjusted to a specific count and motility depending on the method of insemination that you are eventually going to do. If you are planning a microdrop culture for the conventional IVF, we prepare small 100 microliter drops of the semen suspension, and this is put in a petri dish and is covered with oil. This is then equilibrated in an incubator for about 15 to 20 minutes. So what we have is only a micro droplet which has some amount of sperms in it. After this period of incubation of around 15 to 20 minutes, one or at the most two this cumulus oocyte complexes are then transferred into this micro droplet. So this is the micro droplet culture. It is a small droplet with sperms, and then we add 1 or 2 COCs to it. But if a well culture is being planned, then for a period of 3 to 5 hours, the COCs are allowed to equilibrate in the 4-well, and then a measured volume of semen suspension is added into each well to get the desired concentration. And up to 10 follicles can be transferred into each well. So we have a higher number of COCs when the well culture is being done. So to compare these two approaches to do conventional IVF, in the microdrop insemination, we have a small droplet of semen suspension. This is covered with liquid oil and is incubated with 1 or 2 COCs along with the droplet. In the well insemination, there is a larger volume of semen suspension and added to each well of a 4-well dish, and this will have multiple COCs, and you can do this with or without oil overlay because these are large volumes of droplets, whereas in micro droplets, it is a must to have an oil overlay. But conventionally or traditionally, even for the well insemination, they're always covered with oil. So once this has been done, you then allow the sperm and the eggs to remain together for there are 2 ways you can do this. One is a short time co-incubation. Here, a higher concentration of sperms in a low volume is put with the COCs, and they are allowed to remain together for anything between 2 to 4 hours. After this period of co-incubation, the COCs are removed from the presence of the sperm and they're shifted to a fresh media, and the subsequent FERT check is done 12 to 16 hours later. So here, a higher concentration of sperm is used, but it is allowed to remain together with the COCs for a short period of time of 2 to 4 hours only. Alternatively, you can use a lower concentration of between 50,000 to 100,000 sperms only in a large volume of 750 to 1,000 microliters. And here they are co-incubated with the COC overnight. So they will remain together till the time of the FERT check, which is 12 to 16 hours post-insemination. So the essential difference is a shorter incubation with a higher semen concentration or a longer incubation with a lower semen concentration. There have been multiple papers comparing the short and the long incubation time from as low as 1 hour to overnight to maybe 4 hours to overnight. And you can see from this multiple publications that there is no statistically significant difference in either the live birth or the clinical pregnancy or the miscarriage or the implantation, irrespective of whether you use the short or the standard overnight co-incubation. So this is essentially a choice of the clinic. And then when you do the IVF, the first picture shows how the COCs would look at the time of insemination, or when you put it for co-incubation. You do the FERT check where you see the top pronuclear if it is normally fertilized, and the embryos on day 3, an 8-cell embryo or a blastocyst on day 5 or day 6. Now, this standard IVF is essentially used for non-male factor infertility patients. So when you're doing IVF for tubal factors, or when you are doing it for egg donation, or when the patient has history of previous pregnancies and you're doing IVF for secondary infertility, or when it is pure fertility preservation, again, this is slightly debatable, but here, since the fertility has not been tested, maybe this can be used. But this cannot be used when there is presence of a male factor, whether it is severe OAT or asthenospermia or oligospermia or teratospermia. It cannot be used for testicular or epididymal sperms. It is obviously the option when there is a previous failed fertilization in an IVF, and it is also a must in patients who are undergoing pre-implantation genetic testing, because you cannot have the chromosomal complement from 2 sperms when you are doing the embryo biopsy. There could be some small fragments which could have remained attached. So then what is ICSI? So this is something which revolutionized the way IVF was being practiced. And unlike in IVF, where thousands of sperms are allowed to co-incubate with an egg, here this involves the injection of a single sperm directly into the oocytes. So the shortcomings of IVF in terms of minimal requirements of sperms or the incidence of fertilization failure were overcome with this. And all patients with male factor or with previous IVF failed fertilizations had a better shot with this IVF. So how is this being done? So after the oocyte collection, the first step that is to be done is what is called denudation. In IVF, it is the entire COC which is put along with the sperms. But here, since we need to inject a sperm into a single egg, the first step would be to separate out all the cumulus cells which are surrounding the oocyte in the COC. And this is done with a combination of mechanical stripping by gradually decreasing pipette size of decreasing bore, and with a brief exposure of the enzyme hyaluronidase for doing an enzymatic stripping. The timing of denudation could be varied post-oocyte collection. Once the oocytes have been denuded, the procedure of ICSI is then immediately commenced. But how soon should the COC be denuded post-oocyte collection? And there have been plenty of publications looking at the time interval between the oocyte retrieval and the process of denudation. Should it be done immediately or should it be done after a few hours? And most of the publications suggest that we should wait for at least 2 to 3 hours to allow the oocyte to attain some degree of maturity before you start the process of denudation. After the denudation, the oocytes are then graded into the mature ones, which are called metaphase 2, which will have the extruded first polar body in the perivitelline space, or it could be a metaphase 1, where the polar body is not there, or it could still be a germinal vesicle and an immature egg. And the ICSI is performed only on the metaphase 2 oocytes. So one morphologically normal sperm, which is exhibiting linear motility, is immobilized. The egg is held in such a way that the polar body is at 6 or 12 o'clock position, because the mitotic spindle is generally immediately below this. So by putting the mitotic spindle at 6 or 12 o'clock, you avoid damaging it. And the sperm is then injected right into the center of the egg. The subsequent procedure is then checking for fertilization 16 to 18 hours later. So on the denudation, again, most publications have suggested this 2 to 6 hour window. And this is what the picture looks when you're doing IVF. So this is the COC, but the difference between IVF and ICSI is that you need to denude the oocytes and identify a metaphase 2 oocyte, perform ICSI, and the subsequent assessment is the same. So this is how the ICSI procedures be carried out. It is not a complicated procedure. So you isolate a single sperm, you aspirate into the pipette, you hold the egg here, the polar body is at 12 o'clock, and you inject this sperm into the egg. And you keep on repeating this for every oocyte that has been retrieved. So the difference between the conventional IVF and ICSI is that for ICSI, we need very few. It is as low as that is possible, that is 1 sperm per egg. It is best suited for patients who have male factor infertility. It is thought to have better embryological outcomes in selected patients, but when indicated, IVF is equally good. It is slightly more expensive because you need effort from the embryologist, you need the injection and holding pipettes, apart from the inverted microscopes. IVF needs a higher number of sperms. The sperm that fertilizes the egg is by natural selection, and hence some people believe that a better quality sperm would probably fertilize the egg and hence lead to better IVF outcomes, but it is not suitable when the sperm counts are very low. Now, when would you do this ICSI? The debate that was began in the 1980s that should you do ICSI or the insemination of IVF immediately, or would you wait for a few hours before you carry out the insemination of IVF or the injection in a patient having ICSI? And this RCT showed that in good prognosis couples, there was no difference if this was carried out in an expected window of 2 to 6 hours post-retrieval if the retrieval was done at 34 hours after the trigger. So essentially between 36 to 40 hours after the trigger, this would be the best time to carry out the insemination if it is IVF, or ICSI if you're doing the injection, if you're planning an ICSI. So this window of 37 to 48 hours post HCG is appeared to be the best indicator for doing the inseminations. What does the Istanbul consensus tell us about this? So this mentions that once you do the ICSI, you then do the subsequent examinations as followed. So you look for fertilization at 17 hours. You look for syngamy at 23 hours and early cleavage at between 26 to 28 hours. But we then had a lot of data coming from the time-lapse incubators. This is a publication looking at large number of ICSI and IVF cycles. Nearly 80,000 embryos have been observed. And this showed that the best time to look for the 2PN was between 16 to 16 and a half hours, because if you are later than 17 hours, there could be the pronuclear breakdown and you will miss a fertilized oocytes. So based on the evidence that emerges from all the time-lapse images, it has been proposed during the last HRA that this timing should be changed. And what has been suggested is that the forward check of 17 plus minus 1 could be moved to 16 to 17, and the syngamy check at 23 plus minus 1 to 25 for ICSI and 26 for IVF, and so on and so forth. So slight delay in doing the assessment than what was being mentioned in the Istanbul consensus. So this was based on the time-lapse imaging, because we still don't know as to when the sperm actually fertilizes the oocytes. So to conclude, to choose between conventional IVF and ICSI essentially depends on what is the indication. And for non-male factor patients having adequate sperm count, IVF should be the first line of treatment, though there are a lot of clinics worldwide which practice ICSI for all. So this is an ongoing debate as to whether we should do ICSI for all or we should do it only when there is an indication. The optimum time for doing this is between 37 to 41 hours post the trigger. Considering that the standard OPU is at 34 hours, you do the insemination in IVF at 2 to 5 hours, and you do the ICSI at between 4 to 6 hours. Thank you very much. And once again, I would like to thank Dr. MC Patel and the organizers for making me a part of this webinar. Thank you very much.
Thank you, sir, for enlightening us on the IVF and ICSI from basics to the different aspects, how to do the IVF, what is the timing, what is the technique, and also the different steps, and mostly focusing on the consensus, newer consensus and newer evidences. Thank you, sir.
Thank you, Dr. Manish Bankar, sir. It's always wonderful to listen to you. Your concepts are so clear and you communicate them so beautifully with economy of expression. Always something to learn from you, sir. Thank you so much for being here with us. Can we move to the introduction of the next speaker, please, Dr. Sanjeeva Reddy? Dr. Nilesh, will you be introducing or should I go ahead?
There for the next panel, sir, but yeah.
Okay, because I don't know whether you're there as a chairperson or not from the program that I have. Dr. Sanjeeva Reddy, sir, is well known in ART and infertility circles. He's been presented with the BC Roy National Award in 2015. He's also the chairperson of TAPISAR, past chairperson, and he's been organizing secretary of several conferences in Chennai. Sir is here to speak to us regarding metabolic syndrome and fertility, unraveling the complex link. Over to Dr. Sanjeeva Reddy.
Thank you, Dr. Pratik, for your kind introduction. At the outset, I would like to thank Dr. MC Patel for involving me in this wonderful web conference. I'm going to speak on metabolic syndrome and fertility. Metabolic syndrome represents a cluster of abnormalities, including abdominal obesity, impaired glucose metabolism, hypertriglyceridemia, low HDL cholesterol, and hypertension, which identifies subject high risk for developing type 2 diabetes mellitus and cardiovascular diseases. The prevalence of metabolic syndrome worldwide varies greatly, ranging from 8% to 67%. This high variation depends upon a combination of genetic, biological, and social factors, as well as on the lack of global accepted criteria defining metabolic syndrome. The prevalence of metabolic syndrome is high and is increasing worldwide. If you take the definition, there is no consensus. Each society is giving one definition like this: National Cholesterol Education Program, Third Adult Treatment Panel 3, International Diabetic Federation, World Health Organization, American College of Endocrinology, American Heart Association, National Heart, Lung and Blood Institute, and also they combine like the common definition by IDF and AHA, NHLBI. These are the many prevalence. If you take, there are many people in this. They combined mainly there are 5 things will be there. Of this, they will take 2 or 3, and they have given little difference in the definitions, like fasting blood sugar or diastolic or systolic things, and weight and hip ratio, and also like diameters of these things. This way, if you take NCP and ATP, there will be 3 or more of the following will be there. And if you take IDF, there will be central obesity is a must. In addition, there will be 2 or more of these things will be there. The other nomenclatures for this one is syndrome X, deadly quartet, insulin resistance syndrome. The guidelines proposed by the International Diabetes Federation, National Cholesterol Education Program, Adult Treatment Panel 3, World Health Organization's definition are commonly utilized to recognize this condition in clinical practice. So these are the things. Here I told you already, the central obesity, raised blood pressure, raised fasting plasma glucose, or raised cholesterol. These are the things. It will be varying, like there is very little difference if you take here the weight hip ratio. Each thing WH if you take, they have taken the waist hip ratio and the BP like 140/90, whereas NCEP, ATP, if you take like the waist circumference, they have taken for men and women separately, and they have taken the hypertension as 130/80. Like same way, this is the small difference. In IDF, you see the BP, they have taken 130/85. These are the differences. But most of the conditions, they contain all these things: central obesity, raised blood pressure, raised fasting glucose, and raised dyslipidemia will be present. What are the other associated conditions along with the metabolic syndrome? In both centers, they will have non-alcoholic fatty liver disease, obstructive sleep apnea, lipodystrophy, microvascular disease, cancer development, and there will be increased mortality in this patient. In women, polycystic ovary syndrome is associated with this. In men, they will have hypogonadism, erectile dysfunction, prostatic disorders, psychological disturbances, and male infertility. The prevalence of metabolic syndrome we take, I told you already, it will be less than 10% to 84%. This high variation is dependent on geographic location, age, race, and ethnicity, as well as the accepted definition, which one they are following. Apart from this one, the genetic background, family history of diabetes, and smoking are additional risk factors for metabolic syndrome that also influence the prevalence of metabolic syndrome and its components. Pathophysiology of metabolic syndrome take. Pathogenesis of metabolic syndrome is not completely clear. That's the problem why we are not able to come to a conclusion of the definition. There are some factors that have been implicated, like dietary habits, sedentary lifestyle, increasing age, and body mass index. Recent studies have demonstrated that there are sex differences concerning risk predictors of metabolic syndrome, implying that levels of sex hormones and estrogen androgen balance potentially play a vital role in determining metabolic syndrome. To take here, there will be dysregulation in the appetite control, so they will have more amount of food they will take, disruption of the HPT axis. There will be blood system, there will be increased blood pressure. In pancreas, there will be increased insulin secretion because of insulin resistance. In adipose tissue, they will have increased leptin production, decreased energy expenditure, dysregulation of immune system, accumulation of toxins. There is increased lipid accumulation and increased aromatase activity. Same way in the liver, if you take, there will be increased glucose uptake and it will be converted into lipids. There will be increased fatty acid uptake, conversion into the triglycerides and low density lipoproteins. In the stomach and gut, decreased ghrelin. This is useful for the satiety of the center. Here, then decreased POI and decreased GLP-1. So these all resulting in the decreased testosterone estradiol ratio. There will be increased gonadal temperature because of accumulation of the fat near the scrotum. There will be, it can affect the spermatogenesis, and also they will have erectile dysfunction. There will be so much hormonal changes also will be there because of negative feedback thing. So both adipose tissue and other places resulting in there will be effect on the sperm quality. So here we have seen already hypertension, insulin resistance, obesity, dyslipidemia. In the adipose stage, there will be increased inflammation because of hyperglycemia and free fatty acids, resulting in the increased amounts of ROS. This leads to oxidative stress. This is the problem in the mainly for all the problems in male. We'll see the metabolic syndrome and its effect on sperm quality. Metabolic syndrome is involved in worsening of sperm parameters and in the pathogenesis of male infertility. It produces lower semen volume, lower concentration, lower sperm motility, altered sperm morphology and vitality. Metabolic syndrome may lead to reduced male fertility via multiple mechanisms, including altered hormonal profiles, epigenetic changes, increased testicular temperature, inflammation, and oxidative stress. In addition, reduced bioavailability of nitrous oxide due to the high ROS levels causes vasoconstriction, thrombosis, inflammation, and vascular hypertrophy, which together lead to endothelial dysfunction with possible consequences also to gonadal level. See here, this is summary. Like if you take, there are many studies they have done. It shows there will be decrease in semen volume, decrease sperm concentration, sperm motility, sperm morphology, sperm vitality. At the same time, there will be increase in the DNA fragmentation index, and there will be decreased mitochondrial membrane potential. This graph also shows the all semen volume, concentration, count, motility, morphology, vitality, everything will be decreased, but DNA fragmentation will be increased and this MMP will be decreased. Same way the hormones, all hormones like FSH, LH, testosterone, inhibin B, and AMH, everything will be decreased. The productivity will be same, not much. In the estradiol also not much difference will be there. Is there a link between metabolic syndrome and male infertility? Each disease that is part of metabolic syndrome definition has effects on male fertility separately. When put together, these metabolic elements can have additive effects on fertility. Metabolic syndrome was associated with a decline in total testosterone without alterations in gonadotropin levels. The risk of erectile dysfunction increases with the number of metabolic syndrome factors. If there is all is there, that 5 is there, then they will have more chance of erectile dysfunction. Metabolic syndrome is associated with lower sperm concentration, lower count, total motility, sperm viability, mitochondrial membrane potential, pre-testosterone and progesterone levels, high sperm DNA fragmentation in men with metabolic syndrome. This will affect the fertility. Infertile men with metabolic syndrome were also likely to have hypogonadism, lower levels of total testosterone, SHBG will be less, inhibin B will be less, and anti-mullerian hormones also will be less. And in the obesity and male infertility, there is twofold increase in risk of oligospermia in morbidly obese men, a significant negative correlation with BMI and sperm motility, a significant inverse relationship between BMI and sperm concentration, sperm morphology, total testosterone, and testosterone-estradiol ratio. A significantly increased rate of sperm DNA damage and lower mitochondrial activity have been observed. High risk of erectile dysfunction due to lower testosterone levels and high levels of inflammatory factors. And what is the mechanism for all these things? An imbalance between testosterone and estradiol ratio and consequently other sexual hormones due to the excessive aromatization in adipocytes. Excessive inflammation and oxidative stress resulting from the high levels of adipokines and toxins in adipose tissue of obese men. Increase of gonadal temperature due to an accumulation of fat tissue in the scrotal region, impairing spermatogenesis. Dysregulation of several hormones such as leptin that can alter the hypothalamo-pituitary gonadal axis. What is the effect of glucose, that is glucose metabolism and male infertility? There will be lower progressive motility and an increase in sperm DNA fragmentation in diabetic patients. Clinical pregnancy rate less and the miscarriage rates was higher. There will be lower sperm concentration, lower motility, but normal morphology and lower ejaculate volume. Secondary to alterations in testicular environment, testosterone homeostasis, ejaculatory function, and libido, this all will produce the above problems. What is the effect of dyslipidemia on male infertility? Higher levels of serum total cholesterol, free cholesterol, and phospholipids in patients with a significantly lower percentage of spermatozoa with intact acrosome and smaller sperm head area. So these are the problems with a positive association with sperm morphologic states and a negative association with serum testosterone level. An inverse relationship with sperm motility and deleterious effect on spermatogenesis. A significantly longer time to conceive. Oxidative stress, which often accompanies the derangement in serum lipid concentration, may be the driving force behind the male infertility. What is the effect of hypertension on male infertility? Existing data suggests an association between hypertension and impaired semen quality. Men with hypertension had lower semen volume, motility, total count, and total motile count. Theories linking hypertension with reproductive dysfunction are mainly based on endocrine derangements or erectile dysfunction. There will be 10% reduction in total testosterone levels in hypertensive patients. Erectile dysfunction is more prevalent in hypertensive men with a twofold increased risk than general population. What is the treatment for metabolic syndrome in men? Weight loss, though adoption of a healthy lifestyle, in addition to regular physical activity, is the cornerstone treatment for metabolic syndrome. Following the weight loss of 15%, an increase in total sperm count, volume, testosterone, SHBG, and AMH were observed. A significant positive correlation between weight loss and percentage of progressive sperm motility and static percentage also was observed. The effect of weight loss following bariatric surgery on semen parameters and male fertility is still controversial, with some studies reporting no or worse influence, while others finding an improvement in semen parameters following bariatric surgery. But some latest studies are coming after prolonged observation. There is some benefit is there following bariatric surgery also you can observe. What is the treatment of impaired glucose metabolism and its impact on semen quality? The most studied medication used to treat impaired glucose metabolism is metformin. 6 months treatment of with metformin, 850 milligrams for 3 times a day. A significant improvement in sperm concentration, motility, and normal morphology was observed. The improvement of semen characteristics was associated with the metformin-related reduction of insulin resistance and SHBG levels and the increase of total and free testosterone levels. So in those patients, if you are treating with the FSH for idiopathic infertility, if you add metformin 500 milligrams per day, there will be the response is better than using FSH alone in these patients. What is the treatment of hypertension and its impact on sperm quality? Few studies investigated the effect of antihypertensive drugs on semen parameters with contradictory results. Yamamoto from Japan reported that after treating idiopathic infertility men with alpha-1 blocker and beta stimulator for 5 months, he observed an increase in sperm count and seminal volume occurred in 80% of cases. North City performed on normotensive men with idiopathic oligospermia and infertility reported with AC inhibitor lisinopril an increase in sperm total count, motility, morphology, and normalization of seminal parameters occurred in around 53% of participants. Due to the contradictory results of preclinical and clinical studies, further large longitudinal studies are needed to elucidate the relationship between antihypertensive medications and male infertility. It is the treatment of dyslipidemia and its impact on semen quality. If you see, a few studies reported the effect of statins on seminal parameters in human. The largest study in the review reported a negative effect of statins on semen volume, sperm concentration, and motility. We should be careful when you are advising this medication. In summary of treatment of metabolic syndrome and its impact on semen quality, if you see, the use of metformin to ameliorate the semen quality of metabolic syndrome patients is supported by the few available studies. The role of antihypertensive medication is debated and needs larger longitudinal studies. Statins seems to have a negative effect on semen characteristics, while bariatric surgery seems not to improve sperm quality and function of short duration, but in the longer duration, if you follow for longer time, there is some improvement is there. However, caution on this topic is needed since available studies are limited and often performed on so small cohorts. Larger longitudinal studies are therefore advocated. Then only we can say definitely. When it comes to the women's fertility, energy stores and metabolism in the body determine the onset of puberty and fertility. Conditions of negative energy balance and metabolic stress such as diabetes mellitus, acute inflammation, and chronic dietary restriction can affect fertility. These conditions cause hypogonadism by suppressing the expression of the hypothalamic His protein, implying that His1 neurons are sensitive to alterations in metabolic status. Women who are obese and diabetic have been shown to have an elevated risk of complications associated with pregnancy. Metabolic disorders in women fertility, if you see, and the ovarian function, an increase in the incidence of reproductive abnormalities caused by insulin excess, particularly during polycystic ovary syndrome, excessive weight gain, and hyperandrogenism has been reported. Insulin promotes ovarian steroidogenesis and follicular development through insulin receptors in granulosa cells. Insulin has also been shown to augment FSH-stimulated steroid secretion. Its gonadotrophic effects on folliculogenesis promote recruitment and pre-ovary follicular growth. These numerous actions of insulin form the basis for the potential impact of disturbed insulin secretion on the development and functions of the ovaries. The subfertility in obese women is partly ascribed to the complete absence or reduced frequency of ovulation in these patients. Obesity has been reported to have a negative impact on ART because it adversely affects the duration of stimulation, fertilization rate, quality, and less number of oocytes and embryos. The rate of embryo transfer will be less, and also the pregnancy rate will be affected. Obese women have been shown to require higher dose of gonadotropins and longer duration of ovarian stimulation in case of ART. Higher incidence of follicular asynchrony and higher cancellation rates in these patients. The lower number of oocytes retrieved in obese women could be attributed to technical difficulties or lower number of follicles present. And diabetes and women's fertility, if you take, hyperglycemia and insulin resistance have been shown to induce oxidative stress, resulting in imbalance between free oxygen radical activity and antioxidant defense mechanisms at the cellular level. Uncontrolled diabetes is likely to result in a profound hypogonadotropic state, typified by low levels of sex steroids and gonadotropics, and reduced LH pulsatility, resulting in disturbed negative feedback responses. Positive feedback disruption in females has been shown to cause delayed or absent pre-ovulatory LH surges and anovulation in females. Follicular growth and survival abnormalities, including increased granulosa and follicular apoptosis, as well as impede oocyte granuloma communication, oocyte maturation, and development of ovarian follicles. In conclusion, metabolic syndrome is increasing worldwide, almost approaching the pandemic state. Its key components, namely obesity, insulin resistance, dyslipidemia, and hypertension, can have detrimental effects on various aspects of human health. Male fertility is one condition that can be influenced by metabolic syndrome through several mechanisms: endocrine system dysregulation, total temperature elevation, oxidative stress, and alteration of the erectile and ejaculatory functions are well-recognized metabolic syndrome consequences that can impair sperm production and function, ultimately affecting male fertility. A healthy lifestyle characterized by good nutrition and regular physical activities is key to prevent the unwanted effects of metabolic syndrome, not only on fecundity, but also on health and well-being of overall. Reproduction is an important process in human lives. Metabolic disorders have adverse effects on women's reproduction by affecting their fertility. Metabolic disorders, including diabetes, obesity, and hyperlipidemia, can affect women's fertility directly or indirectly by interfering with the pituitary hypothalamic function or ovarian function. Metabolic disorders cause hypogonadism through the suppression of the hypothalamic kisspeptin expression. In diabetic patients, elevated blood glucose triggers peripheral insulin resistance. The existing insulin resistance and hyperinsulinemia can potentially trigger the development of PCOS. Hyperglycemia is also thought to affect ovarian function via advanced glycation products and receptors. Their receptors have been reported to exist in theca and granular cells of healthy women. The findings also indicate that obesity, which is a component of metabolic syndrome, has a significant impact on female fertility, as evident from reports show a high prevalence of obese women in the infertile population when they compared with the normal population, and also the PCOS also is very high in these patients. Thank you.
Thank you, Dr. Sanjeeva Reddy, for a fantastic presentation explaining to us the entire concept of metabolic syndrome and all the different problems that happen in both male and female patients of infertility, specifically with regard to obesity and the metabolic syndrome. I'd like to express my gratitude on behalf of my co-chairpersons to the organizers, and specifically Dr. MC Patel, sir, wishing him all the very best for the future. And without further ado, I hand over the session back for the next session to begin.
Thank you, Pratik.
So now we are heading towards our last session of the day. On the day of Guru Purnima, actually, today we have, gathered so much of knowledge in our practice. I really appreciate all the efforts of organizing committee.
And Sheetal ma'am, I would like to take this opportunity today to wish all the stalwarts of IVF and all the respected seniors to wish happy Guru Purnima. And thank you, Dr. MC Patel, sir, for inviting me today for this marathon webinar. And I would like to thank the chairpersons, Dr. Pratik Tambe, sir, and Dr. Ojaswini, madam. And now the next session, and I think the last session of today's marathon, I would like to invite the coordinator, Dr. Kavita Kapadia and Dr. Prerna Keshan, to take over the next session.
Thank you. Thank you very much. And wishing you all a very good evening. And I'm immensely honored to be a part of this wonderful day-long academic extravaganza on a hosting a string of self-publishing research to practice wide and from the basics to advanced technologies. And we move on to the concluding session today, that is a panel discussion on the rising endemic of today's generation, that is PCOS. And we'll be discussing on the navigating through challenges and solutions. To moderate this panel, we have Dr. Nilesh Balkaude. Sir, can we have Dr. Nilesh CV, please? Dr. Nilesh Balkaude, sir, is the chairperson of was the chairperson of the quiz committee FOXY 21-2025 and has been the joint secretary MOGS, treasurer MSR, and the past clinical secretary of POGS 21-22 and the member of Infertility Committee MOGS 2022. Sir is a fellow in reproductive medicine from Germany, and sir has many awards and publications to his credit. We are really, really honored, sir, to have you amongst us as the moderator for today's esteemed panel. Kindly take up the dais, sir. Dr. Nilesh, sir.
Yeah, thank you so much, Dr. Prerna. And at the outset, I would like to thank the team Fertility 360 Degrees. It's being a wonderful webinar and online conference for a whole day on Sunday. And I would like to thank the organizing chairperson, Dr. MC Patel, sir, our mentor and guide, Dr. Alpesh Gandhi, sir, the past president on FOXY, who is the scientific chairperson for this event. And I thank sir for giving me this last minute opportunity where I'm taking over from Sanjay Makwana, sir, to moderate this panel as sir was not available. So I hope I could give this justice to this panel because I'm just a last minute entry. And I welcome my panelists. I would like to share my screen. I welcome my esteemed panelists and request them to kindly speak one word about themselves because I don't have their CV. So please kindly introduce yourselves. I request Dr. Sunil Shah, sir.
Yes, Dr. Nilesh.
Yes.
Yeah.
Good
sir,
evening.
Nilesh sir, we have CVs of Sunil sir and RJ Patel and the other esteemed panelists. So
that's okay. I will introduce myself. So,
sir, Sunil sir, yes, please.
Let's go ahead without wasting time. I'm Dr. Sunil Shah, currently a president of Ahmedabad Obstetric Gynec Society and joint secretary FOXY 2020 with Dr. Alpesh Gandhi. And I am an IVF specialist here in Ahmedabad at Sarvamangal IVF. Thank you.
Thank you, sir. It was wonderful to work under your leadership in the COVID times, and we have seen wonderful activities as a joint secretary to Alpesh Gandhi, sir. Thank you so much, sir.
Thank you, Nilesh.
And I welcome Dr. R.G. Patel, sir, again, a renowned fertility specialist. I welcome, sir, and please, sir, can you introduce yourselves?
Dr. R.G. Patel?
Sir, you're muted. Sir, you're muted.
Sir, you need to unmute.
Yeah.
Yes.
Good evening to everybody. Myself, Dr. R.G. Patel, Director, Sunflower Hospital. At present, I am the President of Gujarat Chapter, ISAR. And also in the Central Board to regulate the ART and surrogacy. Thank you.
Thank you so much, sir. Welcome, sir. And we look forward to you for help in many aspects. So thank you so much. I request a good friend, and I can see her, Dr. Rekha Rajendra Kumar.
Yeah, thank you, Dr. Nilesh, for including me in the panel. First of all, thanks to MC Patel, sir, for this conference. I'm Dr. Rekha Rajendra Kumar. I'm the Medical Director of Chandana Hospital and Miracle IVF Bangalore. I'm the President of Bangalore Society of Obstetrics Gynecology, as well as the South Zone Coordinator of Medical Disorders Committee, FOXY. Thank you.
Thank you, madam. Welcome.
Thank you.
And I have seen Dr. Ashish Kale, sir, if you are there. Dr. Ashish Kale, renowned fertility specialist from the city of Pune. Sir, if you are there, can you just come up?
Good evening, everyone. Myself, Dr. Ashish Kale, Director of Asha Kiran Hospital and Asha Fertility Center. I am a treasurer of ISAR and Foxy Committee Chairperson of Family Welfare Committee. Thank you.
Thank you, Ashish, sir. I cannot see Dr. Kundan Ingle. He is the past chairperson of Infertility Committee of Foxy, and Dr. Nitin Lad. If they are there, can they please come in, because I can't see them. Yeah. So I think we have our panelists here. We have all of them, and it's going to be a simple panel, and we want all of you to share your practical points for all the August audience present today. So invention is a process. You don't get there overnight. That was being told by Louis Freeman. And recently there has been a study where about a cause of polycystic ovarian syndrome discovered at last. So pregnant women with PCOS have higher levels of AMH, and that is subsequently passed on to the future generation. That was the recent study in 2018, which said. Then there is a PCOS survey, which tells us, hope I'm audible.
Yes.
Yeah, because
yes,
it was shown that my internet connection was unstable. So PCOS survey recently showed that 25% of Indian women didn't know about their PCOS. 65% of women are not aware about PCOS symptoms, and 35% of women have never spoken about PCOS to anyone. So, it's still a neglected thing in many aspects, and therefore this awareness about PCOS is much, much needed. We'll directly jump on to our clinical aspects and this panel discussion for today. We have 3 different cases, and we'll try to cover each case in around 10 to 15 minutes so that we finish our panel in time. So, Mrs. Sanyogita, 26-year-old, came with irregular menses and anxious to conceive. She's married since 2 years and trying since her marriage to conceive. Her husband is a 26-year-old IT professional, and she has a menstrual cycle of 6 to 7 days every 40 to 60 days. And it has an irregular pattern. Sometimes she has to receive withdrawal. She has to take withdrawal, and then only her periods come. So her body mass index is 27. Her baseline routine investigations indicate her hemoglobin percentage to be 11 gram%, blood sugar level to be 175 milligram%, and thyroid levels ultra TSH to be 1.5, FSH 4.5, and LH 8. The semen analysis showed 22 million count with 25% progressive motility and 4% morphology. These are the investigations which she has come up with. These are the only investigations. So now with this, can I have the diagnosis in this case? A tentative diagnosis before we jump on to investigation.
Yeah, because of this young 26-year irregular period, and BMI is more than 25, 27. So it's a PCOS.
And
Irregular oligoovulation with hyperandrogenemia. So by looking clinical history, she has a PCOS.
Great. So our diagnosis is PCOS. Can I come to Dr. Rekha, madam, to kindly give us just an overview of definition of PCOS? How do we come to a diagnosis of PCOS? What is the definition?
There are different aspects of diagnosis of PCOS, and there are many criteria, and there are many associations also, like as you have put National Institute of Child Health, the Rotterdam criteria, and there are so many other criteria for the diagnosis. What we go practically is, one is a clinical way of looking at it, including history part. The second one is the laboratory parameters, and third is the ultrasound parameters. I'm talking about the clinical part of it. When you talk about the clinical part of it, as you have already mentioned, the menstrual irregularity, the painless anovulatory cycles, which I don't have to describe, as you have put oligo or anovulation. Sometimes they may not even get the periods for a long time, which needs withdrawal. So that is the very cause of PCOS in most of the cases, and cycles are prolonged. And on clinical examination, we see all the pictures, what we mentioned about the skin manifestations and all that, like hyperacanthosis and all that, and acne and all that. That comes the clinical part of it. talking about the laboratory parameters. One is the impact glucose tolerance or a frank diabetes. We don't check the fasting insulin. So we check these two things for knowing the diabetes. Associated metabolic syndromes are also there. The FSH, LH are not a clear indication for the diagnosis of PCOS. Previously, we used to say ratio of 1:3 and all that is no more holds good. And AMH most of the times are increased in these women. And there are many other clinical, the laboratory parameters also for the diagnosis. Coming to the ultrasound diagnosis of
Thank you, madam.
PCOS.
I'll
Yeah.
just go to Sunil Shah, sir. Sunil Shah, sir, we know that polycystic ovaries is a different entity, but PCOS as a syndrome, what does this mean to you? What are your 3 or 4 features when you come to a diagnosis of PCOS?
See, basically, PCOS, it is a very broad and very various kind of a presentation when lady comes to us. So all the patient with PCOS may not have obesity. All the patient of PCOS may not have a hyperandrogenism, right? So you have to check it very properly, right? And very rightly mentioned by all the criteria given by the NIH and Rotterdam for the diagnosis of PCOS, but they have very specifically designed that what are the inclusion criteria and when you do a sonography, right?
Yes.
So what are the factors you have to see? Because there are many times there is an over diagnosis of PCOS when a young girl comes to you with a normal, healthy, good AFC count ovaries which is non-androgenic or the criteria that is fit into the PCO morphology. So now you have shown it to that what are the different phenotypes which includes hyperandrogenism, then ovarian dysfunction, PCO morphology, phenotype B where there may not be hyperandrogenism. So you have to do it very precisely. Some lady has a delayed ovulation, and I always tell my fellows who comes to for the training that PCO morphology you have to very precisely say, and don't use the word irregular menstruation. In PCOS invariably there is a delayed menses rather than early menses. Early menses is exactly reverse to the PCOS. So
Yeah.
this should go to the general gynecologist that there is never irregular. It is always delayed period because there is an oligo ovulation.
Yeah, it is always
So,
oligomenorrhea.
so there is an oligomenorrhea. Yeah.
So we have this
Yeah,
patient who, our first impression is a young overweight PCOS. Now I will go to Ashish Kale, sir. So what are your diagnostic tests which you will undertake in this patient? Her glucose levels, random glucose were 175. So what is your test of choice for glucose tolerance, glucose intolerance, and what are the other investigations you would like to perform in this patient before progressing ahead?
Basically, for this patient, if we thought of hyperandrogenism or maybe hyperinsulinemia, we need to know with the HOMA index, that is free insulin with the fasting blood sugar. If the HOMA index is irregular, then we can thought of doing the insulin resistance, and in that case, we need to go with the use of a metformin, that is a drug of choice. And according to if it is a obese patient, what we usually we talking about, it is better to the ovulation induction in this case is a letrozole is the drug of choice, and you can
So
see
we'll come up to
the patient.
the treatment part. Any other investigation? I would like to
Yeah.
ask you any role of AMH in diagnosis of
Yes,
in the
yes.
current
So
circumstances?
Yeah, the AMH in this patient, because of the polycystic ovaries, we know some of the patients do have the variation in the AMH. The AMH may not be a concomitant with the PCOS criteria. In many of the patients, you see the AMH is on the higher side, and in some of the patients with the PCOS, only ultrasonographically will have the same AMH as that of the normal responders. So the AMH with the hyper response, you only will be able to know the which drug has to be used in that case.
yeah,
Absolutely.
Ashish Kale, very nice.
I
But at the
agree.
whole
Just I
ovarian,
would like to give one comment here that International Consensus Guidelines 2021 regarding PCOS, they also mention what Dr. Ashish Kale said right now, that AMH cannot be used as a diagnostic feature, but of course it can be used for prognosis and especially planning your treatment. RG Patel, sir, you wanted to say
Yeah,
something.
yeah. Because for the responder, hyper responder, normal responder, or poor responder, what we are doing assessment of the ovarian function. That mostly practically in clinical practice we see the age, AMH, AFC by ultrasound, and cycle length. If it is normal length, but it is early period, it is poor responder. Late period, maybe 3 days, 5 days, 7 days. Even patients are not getting period with medicine also. So these are the 4 criteria or previous response. In that way, we can diagnose what will be the management previous. So depending on the age, AFC, AMH, and previous response and cycle length.
Yeah. So yeah,
Dr.
I'll come up to the treatment part.
Yeah,
Just
Dr.
for one
Nilesh, one
question, I'm
thing.
coming. Yeah, I'm coming to you, Rekha madam. For one
Okay.
question, you can add then.
Okay.
Glucose intolerance, you have to check for every 2 years, even if the glucose tolerance is normal. So you have to check every 2 years. That's what the position statement regarding PCOS says. I want to come to you, Dr. Rekha madam, regarding the scan in PCOS patient. What all you will do in a sonography in PCOS patient, and you can add whatever you wanted to say. Yes, madam.
Yeah, first, before this, what I wanted to say was regarding the AMH part. Of course, what RG Patel sir said, I agree. But another clinical implication of doing AMH, though a case of PCOS, of course, we don't do in all the patients because we go by AFC for whatever reason. But if you do AMH, it is especially where the cases when you do the laparoscopic ovarian drilling. Most of the time, we don't do that. It is obsolete. I totally agree with all of you. I know that you will tell me. But if
No,
you
no,
do
it is
that,
not. It is not absolute, madam. You are right.
No, absolutely, madam.
International
It's
guidelines 2021.
Okay, fine.
They also say
we
there is
need
no role. We'll come to that. We'll come to that.
this
Fine,
all
fine.
thing we
Okay.
need during what dose we have to monitor. We have to monitor the control the number of follicle. For that we need age, AMH, and AFC, and what trigger we have to give. So that AMH, age, AFC, everything is important.
Yes, sir. Okay. Other
Rekha
than
madam,
that,
can you
what I was
highlight
telling
about
is,
the
But
ultrasound? Because we have
discussion
very,
in
because we have very less time. I would like
yeah.
everyone
Yeah.
to be very crisp
But
and
about
precise. Only,
insulin resistance,
sir,
yeah. I
RG
would
Patel
request
sir, I was
everyone
talking
to
of.
answer only in 2 lines
Fine.
so that
Okay.
we can
Now,
complete all 3 cases.
okay. Now coming to the diagnosis, it's a transvaginal scan only. Transabdominal, maybe a cursory scan in the beginning, what you do, but the diagnosis, one of the important is by transvaginal scan. As you have put, it is a AFC in one ovary, more than 20. The count is very important. That is the size of the follicle also is important. It's a 2 to 9 millimeter follicle. That is what we say. That number is very important, more than 20. Ovarian volume also you have to count in each ovary, more than 10 cc. And ovarian stromal vascularity is not for the diagnosis. You check the density of the stroma. That is another thing, is an important ultrasound picture of a PCOS. Other than the endometrial hyperplasia and all those things.
Yeah, thank you. Thank you, madam. Just one point I would like to add regarding ovarian stromal vascularity, that if you check the stromal vascularity here, the stromal vessels are the vessels where you exclude the follicular vessels, you exclude the pedicular vessel.
yes,
And
yes.
if you measure the stromal vascularity by putting the Dopplers
Yeah,
on
that
the
is
lower
for
range.
reserve. But
Sir, just
what
a
we
moment,
have
sir.
to
I'll just complete. Sir, just a moment. Because the connection is poor, we will be overriding each other. So I'll just complete that. You have to check the stromal vascularity, and if the stromal vascular RI and PSV, they have to measure. If the peak systolic velocity is between more than 10, that indicates that it is a hyper responding patient, and here the dose has to be really limited. And you have to take into consideration these RI PSV values. And if you have a good machine, the vascularity index and the vascularity flow indices can also be calculated, and accordingly you can decide about the doses. RG Patel sir, sorry.
What we have to see in a stroma versus cortex ratio also. If more and more stroma is there, that is a resistance ovary. Over and above pulse like all like follicle on around the ovary.
Absolutely.
Volume of stroma.
Absolutely, sir. I agree. So, can Sunil Shah sir take up about this? What are the different other metabolic abnormalities in PCOS, and what we would like to investigate in such kind of patients?
See, in addition to the insulin resistance, right, other are the abnormalities like the hyperlipidemia, hypercholesterol, and all these things. But that is for the when the that particular lady grows older, then there is hyperlipidemia and all the other metabolic abnormalities will be there. Also, there will be a high inflammation. So it is considered that now we should give a probiotics for these inflammation and all these things. But mostly in a late age, and I have never observed this inflammation, right? There may be few reports which says that there is an inflammation and you should give this probiotic, vulvovaginal probiotics. But practically speaking, I am okay with the PCOD patient where I never give in my center this probiotics for this thing.
Yeah. Now I would come to Ashish Kale, sir. All practical questions, sir. What is your plan of management in this patient? Will you wait? Will you start treatment immediately? She has already, she's anxious 2 years. What is your plan of treatment, sir? Ashish, sir.
Hello.
If Ashish, sir, you are there?
Yes, Nilesh. Tell
Yes.
me.
So your plan
Yeah.
of management for this patient?
Basically, when we're talking about this patient, this is the BMI of this patient is a little bit on a higher side, not that much on a obese PCO, I will not say.
Yeah.
So lifestyle modification and the diet will be appropriate way of management for her. According to the if you see the PCOM criteria, that is the type A, phenotype A, it is better to I will stimulate her no matter what it may. It will be a 2.5 milligram of letrozole twice a day will be apt for her for ovulation induction. And I'm saying that similarly, if you see the counterpart of her, like a male factors, again the male factor is deranged. There is a mild OATS, so it is better to have a IUI in this patient after the tubal patency.
Yeah, but
RJ Patel, sir, your
yeah,
choice
yes.
always letrozole or some patients clomifene?
No. In this case, yes, lifestyle management, diet management, exercise, plus we can add metformin. Metformin will have a positive role on to improve the egg quality, avoid OHSS, and it will increase the ongoing pregnancy rate. It will decrease the abortion rate. So metformin
which all patients will think about metformin, sir?
And with metformin, we'll first start with the low dose tolerance, then we can go for the full dose, and then we can start the, as Kale said rightly, ovulation induction with letrozole. Provided here, patient, we have to explain about the ovarian hyperstimulation, target for the dose adjustment, and target for 2 or 3 follicle. So we can go ahead with the ovulation plantation, or in this patient particularly morphology is 4% normals, we can suggest IUI. Yes.
Okay. Thank you so much. So I was asking regarding metformin. So PCOS with anovulation, CC resistant PCOS, impaired glucose tolerance, BMI, overweight and obese patients, and metabolic syndrome. These are the category of patients where we initiate metformin. We were on to clomifene and letrozole. So I would like Rekha madam to take, which patients you still try clomifene or it's letrozole for all patients?
In my practice, it is letrozole for all patients, for all the advantages what you have mentioned. I don't think I have to go into the explaining about the advantages over CC. But maybe 25 years back, we were using CC.
So what is your protocol in PCOS management? Sometimes even patients don't respond to a letrozole 2.5 milligram OD or BD regimen. So in that cases, what is your protocol for treatment?
Is the question for me?
Yeah.
Yeah. See, as your first line, I don't start the CC. Other than what the previous panelists have mentioned, the lifestyle modification, weight reduction, plus metformin, because the IGT was there, impaired glucose tolerance was there. So I will definitely take her for letrozole. I start with 5 milligram letrozole for 5 days. And day 7, from day 2 to 5 days. Day 7, I straight away take her for gonadotropin. Of course, I check the interfollicle count, AMH, etc. before, so that I decide the dose of gonadotropin. My gonadotropin most of the times is only HMG. At intervals, I check her. Other than checking the endometrial thickness for the trilaminar layer, etc. Most of my cases do not take the antag if it is IUI. It is only for weekend or so, but 99% of the cases of mine, of IUI I'm talking about, don't go for antag. It is just the gonadotrophin. And once it is the follicle size, as we say for letros, it is 18 to 20 and all that, then I give the trigger. And in this case, HCG trigger only, no other triggers is necessary. And her AMH, I don't remember how much that was. If it is a manageable case, I even sometimes give a 10,000 HCG also. It's not always 5,000 HCG. Unless a very severe case of PCOS, and 36 to 40 hours. My IUI is usually not 36 hours. It's around 38 to 40 hours is my IUI, and it is single IUI I do.
Absolutely. Sunil Shah, sir, any other protocol in your practice for PCOS patients? Sunil Shah, sir.
Nilesh, I use many combination and many experiments. I use extended letrozole. I
Yeah,
also
we would like to hear it, because very few people are using. We would like to hear your experience.
Yeah, so basically I use 5 milligram to 10 milligram of letrozole, and I give it from 5 days to 15 days till I get good size follicle along with good endometrium and good uterine artery PI. I wait till 22 to 23 millimeter of follicle because I need a good endometrium of 8 to 9 millimeter. Unless and until I get 8 to 9 millimeter of endometrium, I don't give trigger, right? And most of the time in my center, I give recombinant HCG. And as very rightly mentioned by Dr. Rekha, I never do IUI at 36 hours, right? I do on an average 38 to 40 hours post trigger IUI.
Great. Wonderful. So, I would like to ask Ashish Kale, sir, sometimes we give letrozole and there is no response. So in these patients, we can use extended letrozole regimen or we can use gonadotropin regimen. What is your choice, and how do you give gonadotropins here? Is it chronic low dose step-up protocol, or is there some other regimen?
When you're talking about the letrozole, there is a entity called as a letrozole resistance.
Yes.
Nowadays, we talk about the letrozole resistance, in which the letrozole is given to 2.5 milligram for 5 days and the follicle is not been forming. So in that case, there is a step-up protocol or the extended letrozole protocol. I personally believe if you give a step-up protocol, that is a 1 tablet and then 2 tablets, then 3 tablets and 4 tablets, usually gives a multifollicular development, and same will happen with the extended letrozole protocol. But the similar way, if you add a metformin with the letrozole, it will have the excellent results and which will overcome your letrozole resistance as well as with the gonadotropins. If at all you wish to give the gonadotropins should be started from after the uses of the letrozole. Then the letrozole can be added from 2.5 to 5 to 7.5 for 5 days. After that, you can give the gonadotropins, mainly a HMG, for the daily doses depending upon the BMI, whether it is a 150 or 225, and you have to continue with the effect that the desired follicle will be between the 18 to 20 millimeters, and then you can give a recombinant HCG for the trigger.
Great. Wonderful. So, as we have heard from all the experts, letrozole is a drug of choice according to international consensus guidelines.
Can I add?
Gonadotropins are usually used as the second line agents for PCOS, in where letrozole may not act. You can also use laparoscopic ovarian drilling. We have already spoken about
Dr. RG Patel wants to add something.
Yeah.
Sorry to interrupt.
Sorry.
The dose of gonadotropin after letrozole, this is the PCOD. Already there is a high LH. Are you using HMG or FHH?
HMG,
What
sir,
I
most of
believe
the cases.
to give only FHH.
There are
Why
different
we have to
schools of
add HMG, LH in this case of PCOD cases? So
Sir,
normally what I
we
believe
have this Megaset HR trial. We are going to talk about it. Let's come to type of gonadotropin in just some time. Can you just take up this question, sir, RG Patel, sir? How do we manage resistant PCOS? What is your option? Lifestyle modification or glucocorticoids or metformin?
Yeah. So again, we have talked first metformin, then letrozole. After letrozole, no resistance, letrozole plus gonadotropin, only gonadotropin, and sometime, even though some we have to add laparoscopic drilling.
Absolutely.
What is the indication of laparoscopy drilling? Because we have to aware of the 4 puncture, 4 what? 4 second in each ovary.
Absolutely.
What our aim is to destroy the theca cells, not the periphery follicles.
Absolutely.
We need long needle, and then you can do PCOD drilling. After drilling, immediately you have to wash with the saline to decrease the hot ovary. Particularly here, we have to see the LH decrease after PCOD drilling. Mainly benefited in obese PCOD also and lean thin PCOD. Because in obese PCOD, you can give metformin. But in lean thin PCOD, one option is PCOD drilling, those who have high LH. That high LH will decrease by this PCOD drilling. Here we have to be very careful not to do excessive PCOD drilling. We have seen many cases after drilling, there is a too much decrease in ovarian reserve.
Absolutely agree, sir.
I have a query because I am strongly against laparoscopic ovarian drilling. How will you judge when you are doing a laparoscopic drilling that you are going into the theca cells only and not injuring the antral follicles? Right, so you will puncture for the 4 this is a see basically when there were no good stimulating agents in the form of the oral ovulations or the gonadotropins, and IVF and ICSI was not so good. So for that purpose, where the facility is not available and patient wants to wait for some time or in the periphery, so in urban areas, I think we should avoid, because we don't know that how much injury we are going to do to the ovary, which is live and there are good antral follicles. So this is my personal view regarding laparoscopic ovarian drilling, and I always discourage whenever patient comes to me for the laparoscopic ovarian drilling.
And there are so many studies which are there which say that gonadotropins are much better than laparoscopic ovarian drilling.
Yeah,
I'll just come up to the consensus statement.
When the lateros fail, gonadotropin fail, then we have to add the very few indicated cases for the laparoscopy. Those who are not ready for IVF or not affording for that, and sperm count should be normal. Young, around 2-3 years of married life, they have tried for 1 or 2 IUI with letrozole, with gonadotropin, and then we fail. Then there is a indicated case we can manage with the PCOD drilling and counsel them. 30-40% will be the result after within 3-4 months. If you not get pregnancy after 4-5 months, you may need IVF.
I'll just sum up all this.
Is very important, but few cases.
Can I sum up, sir?
Young.
Yes, Dr. Nilesh.
Yeah, I'll just sum up what arguments have been raised, and I respect each and every argument because that is the argument which is raised in multiple studies. We have lots of studies comparing gonadotropins and laparoscopic ovarian drilling, and that's where comes in the international consensus guidelines 2018 and 2021 about PCOS. What do they say? The first line of treatment is letrozole, that is a drug of choice, that is ovulation induction. The second line of treatment is either gonadotropin IUI, that is controlled ovarian hyperstimulation with IUI, or it is laparoscopic ovarian drilling where the patient doesn't want a follow-up or a non-compliant patient. So still they haven't ruled out that laparoscopic ovarian drilling is not a treatment. So few selected patients where I have highlighted here in indications, you can do laparoscopic ovarian drilling, but as R.G. Patel sir said, that you have to be very selective while doing drilling. But even the international guidelines say that, it is a second line of treatment. And when your first and second line of treatments fail, you should prepare the patients for IVF. So that is the consensus which I would like to share. So we have all seen about laparoscopic ovarian drilling. So which gonadotropin to choose? Yeah, we had again a difference of opinion here. Can you justify yourself, each one of you, for the type of gonadotropin, whether it is FSH or HMG? Then I'll come to the consensus again. R.G. Patel sir, you said about FSH.
Here is the what we have counseled the patient about hyperstimulation. Proper dose we have to start. What I use with recombinant FSH, but any HP FSH is okay. Dose I have calculated depend on the age, weight, AMH, and AFC. Maybe 150 or 225 we will start, and close monitoring is required. I will do once or twice E2 or LH level, and antagonist protocol I use, and after for the triggering I will use analog and freeze-all cycle and FET cycle from next or next to next cycle. So recommended FHS, antagonist protocol, analog, freeze-all, and blastocyst formation.
Okay. So yeah. So in this patient of PCOS, when will you, we are talking about control ovarian hyperstimulation and trigger. So when will you trigger this patient, especially to avoid luteinized unruptured follicle? You know, many cases of PCOS have this LUF. Now they are, you know, talking that LUF, the entity is not there, but still you see that many cases you have LUF and you don't see any results. So Sunil Shah sir, can you just highlight on this? How do you prevent your LUF in this PCOS patient?
See, I spoke previously about this thing that I always wait for the combination of only three things. One, the follicular size in case of a latrose, even if it reaches to the 24 millimeter size, I will wait till I get a good endometrium of 8 to 9 millimeter, right? Along with uterine artery PI of less than 3, right? Preferably 2.5 to 2. And then I will give trigger. So I see, I wait till even 24 millimeter size of the follicle. I never give injection HCG or any trigger when the follicle is 18 to 19 millimeter, because premature HCG or any trigger will lead to a premature luteinization of unruptured follicle, right? And you will not get, and particularly in PCOS patient, the follicular wall thickness will be more than the other woman. So wait for the proper expansion. Wait for 22 to 24 millimeter. See for the good uterine artery PI, right? If it is less than 3 and good endometrium, then give injection HCG or any kind of a trigger. I am talking about IUI, right? I am talking about IUI, not for the IVF.
Yes, yes, we agree. So we are talking about IUI. It should be based on all these parameters which Dr. Sunil Shah sir has said, and Doppler dependent triggers are very useful. Again, you can do a follicular artery. These follicles have these vessels, and you can do a Doppler of those vessels, and your PSV will indicate when to trigger. So if your PSV is more than 10, that is the ideal time when you should trigger these patients, because this means that your follicle is ripe. I'm not going into details of other causes of LUF because that's not a topic today. We'll come to the second case. So this is a case of primary infertility, and both the husband and wife, the age is 36 and 37 respectively. Known case of PCOS, and the follicle number per ovary is more than 20. BMI is again 28.7. There is no other significant past history. The semen analysis again shows a problem. The count is 10 million. Progressive motility is 20%, and the morphology is 4%. So in this patient, already the patient has been infertile for almost 8 years now. And this kind of patients comes to you with this report. So FSH is 4.2, LH is 7.7, AMH is 7.4, and vitamin D levels are 22.4 nanograms per ml. So she had multiple cycles of ovulation induction and timed intercourse, and she had 2 failed cycles of IUI. She was also suggested laparoscopy outside, and a laparoscopic ovarian drilling was done at the age of 35, that is 1 year back. So now, is time important in such a case, or whether we will treat conservatively because she has all the reserve in the world with her? So RG Patel, sir, you want to say something?
Yeah, so this is a case of IVF, indication of IVF, because looking her all the clinical history and treatment previously taken. So counseling is must about the procedure, result, visit, and any complication. I start with the gonadotropin, maybe recombinant, maybe HP. My preference is FHS because her age is 36. After 35, I add some LH, only 75, with 150 FHH. For 5 days, I will do E2 and LH, monitor the how many follicle is there. When the follicle is 14 mm, I will add the antagonist. I will continue the dose for 8 or 9 or 10 days. When the follicle become mature, I will again do sonography thoroughly and see the when to give trigger.
Yes.
And triggering, depending on the E2 and number of follicle, my trigger in this case, because of PCOD, mostly analog triggering. I prefer maybe lupride, maybe the decapeptide, 0.1, 2 injection, 0.2. And after 36 hours, I will do pickup.
Great, sir. So,
And freeze-all cycle.
Right, sir. So anyone would like to highlight, regarding the oocyte quality and, age, is any age important factor even in PCOS patient, or you expect a good oocyte quality with this reserve? Ashish Kale sir or Rekha madam can take this up.
Yeah, when you're talking about the ovarian reserve in a PCOM patient, it's not always that you will get the good quality of the oocyte. Usually, you will not get the M2 oocyte quality, which is on a higher side. So, depending upon the FORT ratio, that is a follicle output ratio, you need to, we are talking about, you need to give a ANTAC protocol with the thinking that whatever follicles you are seeing, at least 2/3 of the follicle should be M2, and then the ICSI should be done, wherein the quality of the oocyte can be assured.
Great. Sir, just additional question to you before I go on to the next panelist. How can we improve the oocyte quality in such category of patients? Like is pre-treatment needed or pre-medication required in such category of patients to improve the oocyte quality in PCOS before going in for IVF cycle?
Usually, in this patient, you need to understand whether we are dealing with the hyperinsulinemia or whether you are dealing with the what you call as the LH levels or on a higher side. If the LH level is on a higher side, it is better to give a pre-treatment with the steroids because that will improve the quality of the oocytes. And secondly, if the if the free insulin levels are high, it is better to add a metformin with the same formulation, and then you can start stimulation.
Absolutely. Rekha madam.
I sorry, Nilesh, I never add this steroids, right? And adding a metformin also, I always check for the hyperinsulinemia. Unless and until I don't add metformin, because I always believe that metformin is insulin sensitizer, and when there is no insulin resistance, what is the fun in giving metformin? And steroid, I strongly never recommend. This, in addition to the obesity, which already she has, it is adding a lot of burden on the body.
No, Sunil. Sunil,
Yes,
because
yes.
of there is some problem to investigate the hyperinsulinemia. Practically, how many we are doing insulin level measurement, how many we are doing insulin index, androgen index, and some limitation and even costly. So metformin you see.
Sir, I do it in all patient of PCOS. All other.
No, you can monitor just by the impaired glucose, the blood sugar level.
HbA1c is okay. In all cases, obesity, age, we do HbA1c. That is a 3-month glucose tolerance test. HbA1c should be around 6 or around 5.5, 6 or 6.5. That is the only test we are doing.
I respect your this thing, but when there is no insulin, when no impaired glucose tolerance test.
Even though, Sunil, metformin have many positive roles. It's like weight reduction, improve the egg quality, avoid the OHSS, avoid the abortion. Even it's like nowadays it's anti-aging even. So many studies ongoing for the metformin.
I agreed with the Dr. R.G. Patel, sir. If you, Dr. Sunil, if you go with the Cochrane review of a multicentric study, wherein they compare the letrozole or they compare with the HMG with the letrozole and the metformin, they said that the addition of the metformin increases the oocyte qualities. So if you go with the research also, the addition of the metformin will increase the chances of the M2 retrievals. So with the proved medical way of a treatment, it is always better to add this kind of a drugs where you are not with, because what we thought in initial days, if you are PCOS, we are going to get the more M2 oocytes, which not hold the true. That's why what Dr. R.G. Patel sir is talking about is the whole true when you are talking about the stimulation protocol, wherein you need to have the Ford ratio on a higher side. Thank you.
Thank you. So the consensus statement, I just would like to conclude here.
One minute. It is not
Rekha
just
madam,
the
we have already discussed. We'll just go
Fine.
on to the next point. So just
No, I just
conclude
wanted
here
to add. Okay,
that
fine. No.
OHSS can be prevented by adding metformin, and which is a very important factor in managing PCOS patient. And the consensus guideline clearly state that metformin can be added, especially to prevent OHSS. What Dr. Ashish Kale sir is saying, that we have a recent Cochrane review also about adding the oocyte quality. It hasn't come up in the recommendations regarding oocyte quality, but yes, we have that Cochrane review as well. Now, I would like to come up to you all regarding the dose of gonadotropin in PCOS patient. Sunil Shah, sir.
Sorry. So the dosage of gonadotropins, as repeatedly said by Dr. R.G. Patel, that age, AMH, and AFC, these three things are very important, right? So, and you have to see a ovary. If ovarian theca is more, then you might need little more dose, right? So also look for the BMI. If BMI is high, you may need little higher dose of gonadotropin. So combination of all these things which you have mentioned, among these, the three more important: age, AMH, AFC, and BMI I will see, and then I will select the gonadotropins. About FSH and LH, I am in IVF. I never add LH or HMG into that. I start with pure FSH, whether it is a recombinant FSH or highly purified FSH, urinary FSH. And so, and I never give dose of less than 225 in any given time, unless it is a very thin PCOS, right? So my first preference is FSH and 225 plus for FSH.
Yeah. So thank you for that comment. We have already had comments from R.G. Patel sir and Rekha madam regarding their usage. Rekha madam had said regarding HMG. So we have this Megaset HR trial in 2021, which was an open label trial in PCOS, especially in PCOS patient, comparing highly purified HMG with recombinant FSH, and it has shown that number of oocytes retrieved didn't. However, they were higher in cases of RFSH. The number of excellent blast, they didn't differ, and the live birth rate, if we see, didn't differ in the both the categories. So Megaset HR trial, which is being conducted on a larger study, has clearly said that any type of gonadotropin can be used. However, there can be differences of opinion, but this is what the guidelines say. And there is also one statement regarding FSH receptor polymorphism. So therefore, HMG to an extent can also be considered for these patients, even from day 2. There can be argument about this. Sunil Shah sir might not agree, but yes, this is how it goes.
Yes.
I'm not going about the asynchronous growth. So there is no
Yes.
follicle growth on day 7 in PCOS patient. If you see, we have started gonadotropin dose, as Sunil Shah said, minimum 225 dose if they have used, and is no follicular growth on day 7. What we will do in such situation? Anybody can take this up.
Yeah, this is the case of FHH-LH polymorphism. So looking, ovarian reserve is good, PCOD is there, started normal dose. After 5 days or 6 days of stimulation, there is hypo response or slow response. That is a FHH-LH polymorphism. In that case, on day 6, you can add LH, and you can even increase the dose of FHH. And then you can continue high dose of FHH and LH with the antagonist. And after 10 days, when you are needed, you can do triggering. If you have enough egg in same cycle, otherwise next cycle you have to see, because ovarian reserve is good, proper dose is given, you are not retrieving good number of M2. Fertilization rate is also less. Even fertilization, sometimes no even day 3 or day 5 embryo formation. We have seen very few cases. Around 10 cases of PCOD creates this type of problem. Otherwise, 90% will go with the expected stimulation.
Yes.
But these type of cases, that is a FHH and LH polymorphism. In that case, we have to add next time LH from day 1 of the stimulation.
Okay.
And LH or FHH depending on the polymorphism.
Can I take up this question to Sunil Shah sir? Your experience and when will you add antagonist in this patient? Will it be a flexible dose antag, or day 7 there is no follicular growth, still you will add antag? So you follow a fixed dose antag regimen or a flexible dose?
It's always a flexible dose. Even in my center, I don't start antagonist when the follicle reaches to 14 millimeter size. So it is always a flexible, and there is no doubt about adding an antagonist in this case. So in such cases, I definitely increase the dose of FSH and I add HMG into that. I agree totally with Dr. R.G. Patel Sahib.
Absolutely. A very good take-home message here that, fixed dose regimen can have these problems, those who are routinely adding fixed dose on day 6 or day 7. As Sunil Shah sir said, you can wait even till day 7, day 8, and even at our centers, we have seen that, day 9, there is follicular growth at around 14 mm, and suddenly the follicles grow after day 9. So, you should wait as a flexible dose regimen of antagonist, adding antagonist in PCOS patient. Regarding
At this
trigger,
juncture, can I add only one question? Anybody's experience on many number of days of antag, if at all they have stuck on to the fixed protocol of antag. I go for flexible protocol, but if anybody has used antag more than 7 days, 8 days, any experience about the oocyte quality?
When you add, madam, antag for a longer time, there are the two things the problem will occur. The antag, whenever you are adding a antag, there are the two problems where we give antag. Antag has a short life. If you think of adding a antag, it has a shorter half-life. It causes a drastic decrease in the LH levels, and the FSH later on falls down. So the number of gonadotropin stimulation will be higher in those cases. So that is the only thing.
To monitor this patient with E2LH. With the
I said about
stimulation,
the oocyte quality.
yeah, it always, if needed more stimulation, more dose, quality of egg may be decreased on inferior side.
Yeah. Even I felt in 1 or 2 cases. That's why I'm asking. Okay, thank you.
Yeah.
Next.
Everyone of us have experienced this. I'll just come up to the few last questions. Sunil Shah sir, your choice of trigger in this patient.
Okay, so I will see the number of the follicles, right? And how many number of the follicles are there, right? If required, I will ask for serum estradiol level also, right? And then the combination of GnRH analog plus HCG. I love giving HCG because the quality of the oocyte after HCG is always better. I am not afraid of OHSS, so I prefer giving HCG as a trigger. Required, then I most of the time I do a freeze-all cycle, so I am not worried about the OHSS. So in the carry home message is that I always give HCG along with GnRH analog, even if the number of the follicles are 25 or 30, though also I give some HCG there.
So some means how much?
2500 IU.
Okay, great. I would like to have some argument here. R.G. Patel sir was about a proponent about only GnRH. So, sir, your choice of trigger.
Yeah, same. In more, again, I have seen number of follicle, E2 level, age, AFC, AMH, because lean thin, high MH, some chance of hyperstimulation. So in which case we have to add HCG, I have to select. Mostly, if it is more than 30 lean thin PCOD, I will avoid HCG. But borderline cases, I will add 2000 HCG, even 1500 HCG. Sometime I will add only 1000 HCG. But depend on all the criteria, number of follicle, E2 level, age, AMH, and weight of the patient.
Anybody who
target is to avoid the ovarian hyperstimulation. At the same time, we need good number of M2.
Yeah. So we are, currently following a no OHSS or OHSS free
Yeah,
clinic.
OHS free clinic.
So Ashish Kale sir, your choice only GnRH agonist or some HCG?
And it depends upon the age of the patient. It depends upon the number of the follicles, because usually in this patient of the PCOS, we'll start with the ANTAC protocol. So if the number of the follicles are on a higher side, I will prefer to give a agonist trigger. And if the follicles are lesser on the side, I will give a SCG trigger, because I don't want the OHSS to occur in the larger aspect.
Okay. So we have a mixed opinion coming up from the panel. So the concluding statement is that you have to be careful when you are adding SCG. If it is a follicle number per ovary, it is expected, which is more than 20, the risk of OHSS is higher, and the E to serum E2 levels more than 3,500, the risk of OHSS is still there. So in these patients, you should be careful about adding HCG. Of course, as the expert panel has said, that you may have your own experiences regarding the use of HCG. Currently, it is said that GnRH agonist only trigger doesn't, affect the oocyte quality. So, that is also a good choice to have. So I would just rest it here, and I would go on to the next question, which is a very important question. Empty follicle syndrome we see in many PCOS patients, at least 20 to 30% patients. What is your strategy to deal about empty follicle syndrome in PCOS patient? Rekha, madam.
Fortunately, many of my patients, I don't have much experience on this, because almost all my patients, I can say in my practice that I have come across very rarely on this EFS.
Anyone else would like to take this up?
Yeah.
Ashish sir?
HCG is not given most of the times. We check the blood LH for the trigger.
Ashish,
Yes.
hello. Can I answer?
Yes, sir.
Yeah. This is very interesting because very frustrating situation.
Yes.
So flushing, sometime high pressure, not getting any follicle.
Yeah.
We will stop for one ovary. We will wait. We will do LH, beta HCG level, E2 level, and progesterone level.
Yeah.
Mostly fault with the delivering injection. Maybe with the batch. Maybe patient have taken OC pill for long time before the starting stimulation. So LH level before the stimulation may be less. On the day of HCG, maybe LH level low. And patient may have taken analog, GnRH analog for endometriosis before 1 month, 2 months, 3 months. This is the likely case for the empty follicle. So what we have to monitor, whether we have to check patient have taken injection properly or not, batch is properly or not. So if E2 level, LH and progesterone level is good, you after giving analog, it suggests triggering analog given properly.
Right.
So that is the case of empty follicle. After seeing all the parameter, again we give the antagonist stimulation after aspirating one ovary. If it is fault in stimulation, low LH, low beta HCG, low progesterone, that suggests there is some fault in delivering the injection.
Absolutely.
If there is a delivering injection problem, we can repeat the HCG after one ovary aspiration, and we go ahead with the after 36 hours second ovary. And we have seen around 7 cases, and in 5 cases we have succeeded after giving second stimulation and second triggering.
Thank you so much.
We have seen 2 cases. True, even in long protocol, we have changed the protocol, antagonist protocol, instead of HCG, analog protocol triggering, instead of analog, we have given HCG, even though 2 cases we have seen there is empty follicle. In that case, egg donation was the last resort.
Yes, I agree. A wonderful answer by RG Patel, sir. So we have true and pseudo empty follicle syndrome, as he said. I would just like to mention the levels. So, once you are giving a GnRH agonist trigger, the LH level should be at least more than 15 to say that your trigger has worked. If your LH levels are less than 15, probably your LH hasn't worked. So it's a fault in the injection or fault in giving the injection or not taking the injection. All this can be a possibility, and this can be a pseudo empty follicle syndrome. In cases you have given a HCG trigger, probably you do a follicular HCG, a follicular fluid HCG on the pregnancy test kit, or probably you do a blood levels. In that case, the blood level should be more than 50. So these are the levels which you should remain in your mind and probably can utilize. So this patient had a good course with us. We went for an antac protocol and we had good follicles. We don't want OHSS in this era, and therefore these are certain strategies to prevent OHSS and manage OHSS. I'm not going into the details of this because of shortage of time. So, everybody of our panel consultant has given a good choice for this patient. And finally, we had a positive beta SCG for this patient. So concluding remarks regarding, this in your practice, anybody, using growth hormone for PCOS or IVM, still, there is a possibility that we can use IVM for such patients, or any peculiar pre-treatment which can be used. So final concluding remarks from each of you. What different you are doing for PCOS patient in managing while doing IVF? I would start from RG Patel sir. So what different? What आपका नुस्खा क्या है? आप कैसे सक्सेस बढ़ाते हो आपका?
बस पेशेंट को जैसे इवेल्युएशन अच्छा करो, थरो इन्वेस्टिगेशन, काउंसलिंग, प्री ट्रीटमेंट, and then the proper stimulation, proper monitoring, proper triggering, and lab management. But I have one interesting case, very interesting. A patient from US, obese, around 97 kg. Patient have low FHH and LH and PCOD. AFC in each ovary was 100. So it's a not pakka case of almost near to hypogonadotropic hypogonadism and PCOD, strong PCOD. So what dose you will start? 150, no response. High dose, all the follicle will develop. If all the follicle develop, may become mature, what will be the trigger? In this case, you cannot give analog.
Yes.
You have to give HCG.
Yes.
Then you will be in trouble. Because of HCG, both sides there is 100 follicle.
Yeah.
And patient was obese, patient from US. How will you manage?
Right. So please highlight on this.
So in that case, in one ovary, we have aspirate without any stimulation, either triggering. And we got some immature cells. So in that case, we have given in the ICM 99, that is a in vitro maturation media. And luckily, we found one mature egg, and we have done ICSI and one embryo form. And then second, after aspiration of one ovary, we have given very low dose, that is 3000 HCG. And we have aspirated second ovary. In that case, we got around 5 mature. We have done ICSI, few of them immature. Again, we have put in in vitro maturation media. And after maturation, we have done ICSI. And after second pickup, we got around 3 embryo formation. And we have transferred 1 FET cycle and got the result.
Great.
What dose of gonadotropins you use, sir?
Only 150, Sunil. Because if you give more, then all follicle will develop. It's a create problem. We have to remain in.
Or if you get it, becomes a sudden growth of all the follicles.
Yeah, the 100, how will you manage? Even aspiration of all the follicle, the troubleshooting. We don't know. So that was a very interesting case.
Wonderful case share, sir. I would just like to share our first experience of the first Kappa IVM baby in India. So it is called as a capacitation IVM. Along with the foreign university, we have done this study at Oasis Fertility, where we just give 3 doses of HMG 150 international units, or sometimes a very less dose also, and we would aspirate the follicles at around 8 to 10 millimeter size, and do a capacitation IVM in 2 different media, 24 hours first media and the second media around 24 hours later. So 48 hours later, we get a mature oocyte in PCOS patient. We use very less drug and no chances of OHSS in this patient because we are not using HCG. So as sir has said, adversities bring out the best outcomes in us. So I would end up here. that IVM is an treatment of choice in such patients, and the consensus guidelines say that it can be offered in selected patients. So it is never not considered the experimental nowadays. It is a modality which can be tried. So to summarize, we have elderly patients we have to treat with more caution.
You are right, very truly say because because of OHSS there was too much havoc. But patients, many centers shifted to IVM also, and there's so many research is ongoing. But suddenly, because of antagonist protocol and an analog triggering, there are result of PCOD and mostly all the problem will solve. So that IVM interest and all the research came down.
Yes.
But again, you can rethink about the
newer studies are coming up, and we are at our center also proposing a new study, which is a randomized control study regarding use of IVM and antagonist protocol. And we have seen that almost the results are clinical pregnancy rates are almost similar, so to the tune of around 50%. So in both studies, so that is what we are doing. But yes, as you said, that use of antagonist protocol and agonist trigger has brought down the research in IVM. To conclude, because of shortage of time, PCOS we have to be very careful, and especially elderly PCOS, we should exercise more caution. Protocol should be individualized. We should follow OHSS free clinic as a dictum, and treating the patient as a whole is important. So also the male factor should also be closely monitored. With this, I rest my case, and I thank all my panelists who are extremely experts in their field. R.G. Patel sir, very stalwart in infertility. Sunil Shah sir, whom I have been learning as a joint secretary of POPSI. Dr. Ashish Kale, who is again a leading fertility specialist from the city of Pune and a very good senior and mentor in POGS. And Dr. Rekha Rajendra Kumar, a very good leading fertility specialist in the city of Bangalore, and my friend and colleague whom I studied IVF with. So with that, I rest my case. Thank you so much, panelists. Thank you, organizers. MC Patel sir, I wish you all the best for all your future endeavors. MC sir, thank you.
Thank you, Dr. Nilesh. It being a wonderful panel with you.
Many congratulations, Dr. Nilesh, for conducting very interesting panel in a very excellent and effective way. And in our odd hours, you have helped us a lot. And all the panelists, big round of applause for all the panelists making this panel very interesting and informative.
So it's
Dr. R.G. Patel, Dr. Rekha Rajendra Kumar, Sunil Shah, and of course, Dr. Ashish. Thank you all the panelists.
MC Patel sir, all the best for your pre-election, sir.
Dr. Kavita, please mute yourself. Dr. Kavita, please mute yourself.
Yes, Kavita.
Nice. Yeah, fine. Thank you. Sir, thank you so much for the opportunity. It's a very nice program that's been happening since morning. And on behalf of sir, I request everybody here to vote for sir, which I have been doing since long time. And it's my earnest request to all of you to please vote and make sir successful in his career and future endeavors. Thank you.
Thank you.
So to add to Dr. Rekha, what she said, see, in this new era where the patients are looking at us as somebody different than doctors, right? And then so many medical legal cases, and now because of the Google, like everybody is like, searching on the Google and coming to us. So here only Dr. MC Patel, being the medical legal expert, can help us in like all our practice. So like, I would definitely strongly recommend everybody that please vote for Dr. MC Patel. Being Foxy president, he is like savior for all of us. Thank you very much.
Thank you, Sita.
Wait.
Thank you.
Everybody with you.
Yes, R.G. Patel, thank you.
Thank you so much.
Sir, all the best, sir.
Yes, Kavita.
Yes, I'm so sorry for the disturbance. I'm traveling, but nonetheless, thank you so much, Dr. Nilesh, for stepping in last minute and taking up this challenge. It indeed turned out to be a wonderful panel. Thank you all the panelists for making this so interactive and so interesting. With this, we come to the end of today's academic program. And what a brilliant day for academics. Today turns out to be Guru Purnima. And on this day, I would like to wish all the stalwarts a very happy Guru Purnima and seek their blessings. I would like to thank Dr. MC Patel, the organizing chairperson of Mytri conferences, Dr. Alpesh Gandhi, who is the scientific head, our esteemed chief guest today, Dr. Rishikesh Pai, Dr. Prakash Trivedi, our conveners who've just worked tirelessly, Dr. Dolly and Dr. Sheetal, all the chairpersons who spared their valuable time with us today. the speakers and the panelists with whose expertise we've learned and been enlightened today. I would also like to thank Corona Remedies and Pioneer, Vasu and all the technical support team for giving us seamless transmission today. And last but not the least, all the wonderful attendees who spent their wonderful, valuable Sunday with us, without which this webinar would not be successful. Thank you all. Wish you a very, very happy Guru Purnima and a happy Sunday. Thank you for being with us. On behalf of Mytri, I thank all of you.
Yeah. So thank you all who have helped this webinar, webcon, to be successful and memorable one. Vasu and Team Corona and all the faculties who have joined this webcon. Thank you very much.
Thank you.
Vasu,
Bye-bye.
yes,
Yeah,
we can
okay.
conclude.
Thank you.
Vasu.
Sir has taken so much of efforts. Can imagine for the entire day's conference how much of work has gone.
It's my passion. It's my hobby.
Thank you. Thank you
Thank
all.
you. Thank you.
Okay.
Thank you. Bye-bye, everybody.
Bye.
Thank
Thank
sir.
you.
Bye bye.
Bye-bye.
All the best. And we are all
Thank
hoping.
you. Thank you, Nilesh. Thank you.
Yes.
Thank you, sir.
Thank you, MC Patel, sir.
Thank you, Vasu, for all the help.
Thank you. Thank you so much, sir. Thank you so much.
Thank you.
Thank you, Asu.
Thank you, ma'am. Thank you.
Bye. Bye.
Thank you. We can